Students, good evening. I hope you can all hear me and I hope you can see me. I'm not stuck in traffic. I'm very much in the studio, but there were some problems. These glitches keep happening, and I hope you're not perturbed by this delay of 10-15 minutes. And it's just that sometimes things are not in our control. So today's session is based entirely on discussing as many MCQs as we can regarding the last many years of NEET PG, and I've tried to get all the topics. That's what we're trying to do. So it's a marathon session. I'll give you a short break in between, but I want all of you to understand as much as theory as we can revise. And before we start the discussion, I want you to understand that this is that one moment. You have only around another 3-4 days left for the exam. I don't want you to read in the panic mode. Don't make yourself thoroughly nervous and confused before the exam by trying to read everything possible which is given in all the books and all the guides. This is that moment where you should aram se keep a book in front of yourself and keep reading. That's all. Keep reading as much as you can. Don't get into panic that you have not read this, you have not read that. There is no one in this world who can finish all the 19 subjects in all the details and do a complete revision. I mean, you have to individually be an MD in all the 19 subjects to achieve that kind of performance. So please, आराम से पढ़ो, जितना पढ़ सकते हो. Go slowly. पुरमे पढ़िकलंपा, ओकांदी पुरमे पढ़िकला. Okay, do not get too worked up. Okay, that's my very simple advice before we do the sessions. Hi, good evening everybody. And time duration mid clock. I wish I could say that. It depends on how many questions you're asking me. I've got a few MCQs. Maybe some topics, if they are left, you can ask me to teach you. So I've kept it open. It can go up to 7 hours or it may finish in 2. Okay, chalo, let's start the discussions. We'll start with obstetrics. We'll get for a change. I'm starting with obstetrics because people keep saying that I do always gynae first. It's because I want to aram se do obstetrics because it's going to take time. So let's do obstetrics first for a change and then gynae. But later half of the paper has mixed gynae and obs questions. Chalo, shuru karte hain. Which of the following condition will lead to oligohydramnios? If you see the amniotic fluid index, we always say is 10 to 15 centimeters, and less than 5 is oligoamnios, and more than 25 is polyhydramnios, and single pocket, a single pocket, if it is 2 centimeters or small is oligo, and if a pocket is 8 centimeters or more, it is polyhydramnios. So that is the basic of the amniotic fluid index. I'm sure you knew this, but just for a quick revision. Now, when you talk about LICA production, you know that LICA production is mostly from the fetal urine after 20 weeks. So remember, in the initial few weeks, that's the one which we keep forgetting. In the first few weeks of pregnancy, there are 3 mechanisms. One is a transmembranous flow, that is across the amnion, intramembranous flow across fetal vessels, and then across the fetal skin. We call it the transcutaneous flow in the initial few months. And then fetal contribution, which is the major contribution, it's from the fetal skin and from the urine, and that's the major contribution to the amniotic fluid after 20 weeks of gestation. So remember this. Now, what are the amniotic fluid dynamics? How much is produced every month, every day, and how much is absorbed by the body? So remember, urine is of the fetal urine is 1000 ml every day, and lung secretions are 350 ml. So 1350 is the production of amniotic fluid. What is the absorption of amniotic fluid? Fetal swallowing itself is 750 ml, and then intramembranous fluid transport. That intramembranous fluid transport is 400 ml. So this is like roughly around 1150. So that's why we say roughly, okay, roughly there's a addition of 200 ml of LICA. It does not happen 200 ml LICA, still there is a lot more absorption, but always remember that the production is more than the absorption by the body. So that is the dynamics of the amniotic fluid. So let us see the answer to this question. Which of the following condition will lead to oligoamnios? So cardiac anomalies, tracheoesophageal fistula, renal agenesis, and ureteral stricture. So which one will cause which one will cause oligoamnios? So renal agenesis is the straightaway answer. Renal agenesis is the straightaway answer. Ureteral stricture can also cause, but if there are two almost right kind of answers, I'll go with the renal agenesis because that is a major production. All right, ureteral stricture, who knows, the baby is able to void. But yes, if there was a posterior urethral valve, if there's a posterior urethral valve, that would have been a much stronger answer. So since C and D look like, these are recall based questions, and that's why I'm not bothering to change all the choices, just trying to tell you what is there in all the guidebooks. We try to assimilate all the questions from the guidebooks, and these are the choices given to me. So I will go with renal agenesis, which is a straightforward answer, right? Chalo. Tracheoesophageal fistula, yes, that will not ideally cause oligo. Okay, that will cause polyhydramnios. Chalo, आगे चलते हैं and see something else. Now, this is a very interesting question. A pregnant lady with 8 months of amenorrhea has the following findings. Lactic dehydrogenase 690 enzymes are elevated here in this patient in pregnancy. 8 months. So, let's give you 34 weeks. Okay, always weeks mein hota hai. Then platelets of 75,000, which is less. Bilirubin is slightly increased. SGPT, SGOT is mild increase. More than double, but it is, yes, not very high. Viral hepatitis will have much more. So already I'm not thinking in terms of viral hepatitis. And blood pressure, which is a little high, 140/90. A coagulation profile, renal function test is normal. What is the diagnosis? I will not say viral hepatitis. I'll have to think in terms of acute fatty liver pregnancy and HELP syndrome. Intrahepatic cholestasis, the enzymes won't increase. The total bilirubin, the bilirubin can be in intrahepatic cholestasis of pregnancy, bilirubin can be, total bilirubin can be up to 5. That can happen. But remember, enzymes, only alkaline phosphatase will increase in intrahepatic cholestasis of pregnancy. So I don't think this is also the choice. So not viral hepatitis and not IHCP. So I think it is between acute fatty liver pregnancy and HELP syndrome. I just want to tell you a little bit more about the cholestasis of pregnancy. That remember, in intrahepatic cholestasis, the total bilirubin is almost always never more than 5. So if they give you a question where the bilirubin is 15, 18, something like that, please don't think of IHCP. Pregnancy may, don't think that IHCP is the only problem which happens to the liver. Please don't think that way. Now, between these two, between acute fatty liver pregnancy and HELP syndrome, let me help you and tell you. So, IHCP is not there, viral hepatitis is not there. Now, let's look at acute fatty liver pregnancy and HELP syndrome. These are the two which I am trying to distinguish for you, because here also the platelets are a little reduced in this case. So, let us see about the platelets. Both in IHCP and HELP syndrome, the platelets will be reduced. All right. Enzymes also will be almost the same range, and almost the bilirubin, which is 1.5, it comes in both of these. But remember, the coagulation profile is deranged in acute fatty liver pregnancy, and it is preserved in the HELP syndrome. And the patient in acute fatty liver pregnancy will have DIC also. So the problem with HELP syndrome is that the patient is having a liver which is strained, but the liver is working properly. It is strained, the enzymes are increased, but the patient is not in hepatic failure. But in acute fatty liver pregnancy, the patient is in hepatic failure. Patient can actually die. We lose such patients sometimes. So what is the best answer here? When the patient is having mild elevated liver enzymes and the bilirubin is, it can be in both, and there is a platelet which is 75,000 and the blood pressure is little high. So based on this, based on the low platelets and the mild high elevated blood pressure, I would go with the answer of HELP syndrome and not acute fatty liver pregnancy, because acute fatty liver pregnancy, I would see that the patient will also have a deranged coagulation profile and will also have DIC. Remember that. Now, acute fatty liver pregnancy, the patient will be in hepatic failure. I will go with HELP syndrome in this patient. But remember, acute fatty liver of pregnancy also comes at 34 weeks of gestation. That is also, it comes late in pregnancy, but it's a very rapid deterioration of a patient. All right. Now, um, in addition to this, let me give you some more information, and that is regarding the bile acids. In intrahepatic cholestasis of pregnancy, it is something, you see this, there will be itching all over the bodies, more on the extensor surface. You know, the question answer is over. I told you the answer is HELLP syndrome. वो खत्म हो गया. I'm just trying to give you more information. Okay. So याद रखो कि in cholestasis of pregnancy, itching will be there, like some of you are saying. Enzymes are not very high elevated. Bilirubin is generally not more than 5, like I told you, but they'll be increased in the bile acids. I want to stress on this just now. And also, the treatment is to give ursodeoxycholic acid. There is a very famous drug, all your interns must have given it, Udiliv. You know, it's a trade name. Okay, I'm just trying to familiarize you with the drug which you must have been giving. If you had an obstetrics posting, you would have given this drug to a lot of patients who have this itching. So if a patient has itching and is having intrahepatic cholestasis, it's a mild liver problem in pregnancy. It happens to many people. But I want you to concentrate on something called the bile acids. Now, these bile acids, sometimes, now it is happening so many times that fetal medicine people may ask you this question. It may just come. These bile acids, generally we are happy if they are less than 10, but around more than 40 is worrisome. I'm just giving you a basic, and more than 80 is, some people say more than 100, is alarming. Some people say more than 100. I'm not going to, there are many ways of classifying this. So, recently I had a patient whose bile acids were 140. That is critical. Now, why bile acids are bad? Now, when these bile acids are high, remember, these bile acids in high concentration can be cardiotoxic to the fetus, and they can suddenly stop the heart of the baby. So when we have this bile acids high, we increase our surveillance. More than 40, we increase our surveillance, and if it is more than 80, then the patient is admitted, and on a daily basis, we are doing a surveillance. Remember, what is surveillance? Surveillance is non-stress test, biophysical profile, Doppler. Look, I have told you many times, revising. I am an obstetrician because I know surveillance. That's all. I know surveillance, that's why I'm an obstetrician. What is the drug of choice for hypertension pregnancy? Labetalol. What do you do for diabetes in pregnancy? Give insulin. ये तो किसी को भी पता है. But how do I continue a pregnancy which is diagnosed to be a diabetes pregnancy at, let's say, 24 weeks and take it till 37 weeks of gestation without the baby dying and the mother being fine? My surveillance, fetal surveillance, makes me an obstetrician. So fetal surveillance will increase in all high-risk pregnancies, and when the bilirubin, the bile acids are high, our surveillance increases. And more than 100, if it is, then we know, more than 80 or more than 100, when it is, we know that the baby may be getting this cardiotoxic action of the bile acids may suddenly stop the heartbeat. So I will try to push the pregnancy till 34 weeks and deliver. I will not wait much beyond 34 weeks. If the bile acids are high at, let's say, 34 weeks, I do the test and the bile acids are high, I'll deliver. I will not want to take the risk. So that is the new thing. I'm sure that, you know, I'm giving you just a brief overview of the use of bile acids values which are used in the OPDs these days on a regular basis. All right, chalo, आगे बढ़ते हैं and get into something else. A pregnant woman post-cesarean section was put on magnesium sulfate for preeclampsia. She's also known case of diabetes. Okay, somewhat trying to confuse you. She had a cesarean maybe for preeclampsia, and she was about to throw convulsion, so she was put on magnesium sulfate. She developed delirium and appears drowsy with a respiratory rate of 10, random blood glucose of 240, oliguria, bilateral absent knee jerks. Oliguria, they're all important, and absent knee jerks. What is the cause of a condition? So delirium can be there in diabetic ketoacidosis also. That's why they are trying to confuse you. So if a patient, क्या है one question, आप FMG को 2 word जरूर बोल के आप गौतम नगर में आए थे. Thank you so much, love. Oh guys, thank you so much for writing all that. But That's the least I can do. You are fighting for a very major cause in your life, and God bless you with whatever you want. And we stand with you always. I hope there is more transparency in the exam, that you people at least get to know the answers which they are expecting, and you people should get the answer sheets so that you know that you've been marked right or wrong. Why? At least that much can be done. There are many other demands. I can't judge either the students or the national board whether they are good demands or bad demands, but I feel that there should be more transparency. That is an immediate demand even by us doctors, so that those who have not passed this exam, at least they know why they have not passed this exam. At least for the next time, you know, a lot of people will tolerate a failure. It's difficult. People will tolerate a failure, but a lot of us would actually want to know why I failed, because the transparency part is not there at all in most of the exams. So I take this opportunity to stand once again for the students and say that if you know the answers, it'll be best. All right, quickly, let's get back to work. So we have a lady who's got magnesium sulfate going on, and then these are the signs. Sugar is high. So is it? It is not diabetes insipidus. Isko to chhod do. Is it diabetic ketoacidosis? It's not eclampsia. She's not convulsing. Is it diabetic ketoacidosis, or is it magnesium sulfate toxicity? Now, upfront, it looks like magnesium sulfate toxicity, but the sugar is high. Now, sugar is generally upwards of 250, can be 240 also, upwards of 250 for diabetic ketoacidosis. Okay, not that 240 cannot cause it, but there are many other things. They must give you an electrolyte profile also. The hyperkalemia also should be there. So, sugars around 250 or more, and blood and urine ketones value should be there for us to diagnose diabetic ketoacidosis. And the pH should have been there for me to be more happy, and the bicarbonate should be less. So if I get this information, I'll be happier to diagnose a diabetic ketoacidosis. Whereas I have all the information to diagnose magnesium sulfate toxicity. You know that the magnesium sulfate toxicity, magnesium sulfate levels, when we are talking about the levels, it is 4 to 7 milliequivalents per liter. That's the level of magnesium sulfate we should have for a therapeutic action to prevent convulsions. Now, if it is more than that, that is magnesium sulfate toxicity, and more than that, 8 to 10, there will be knee-jerk suppression. And knee-jerk suppression is the first sign of magnesium sulfate toxicity. 10 to 15, there will be respiratory compromise, there will be respiratory depression. This is depression, please. That's why I don't tell this in the class mostly, because respiratory arrest is 12 to 15. Around this and more, there is respiratory arrest. Now, this respiratory arrest is what generally comes in the exam. Around 15 and more, there will be respiratory arrest, and 25 and more, there will be cardiac arrest. Right. So, this is definitely magnesium sulfate toxicity and does not look like diabetic ketoacidosis. Now, please remember, please read about magnesium sulfate. A couple of places more. This is coming in the discussion today, so I'm not going into great details. But magnesium sulfate dose, 14 grams loading dose, 10 grams intramuscular, 4 grams IV, and then after delivery, you must give it for 24 hours more so that the convulsions don't happen. Remember, the respiratory rate should be more than 14, more than equal to 14, and the output should be more than 100 ml in the 4 hours, and the knee jerks should be present. So when we do this 4 hourly, 5 grams intramuscular, we have to give 4 grams, 5 hourly. Intramuscularly, magnesium sulfate has to be given for 24 hours after the convulsion, after the last convulsion. All right. So I'm sure all of you know about this, but quick revision. Chaliye. Okay. Now let's see something else. Identify the type of hymen shown in this image. So if you look at this image, the hymen is that small tissue which is present at the opening of the vagina. And this hymen necessarily, I have drawn it green here, it necessarily doesn't open only at intercourse. It can open also in a athlete because she's running a lot, and that can stretching a lot. So athletes can have a hymen which stays even before they have sexual activity. Now, this hymen normally looks like this, and it's a band around the vaginal opening. Now, if it is like this, what is this type of a hymen? So, when we talk about the hymen, the imperforate hymen is not like this. Imperforate hymen, you will not see any opening. Is it a septate hymen? Yes, it looks like a septate hymen to me. Semilunar hymen? No. Annular hymen? No. So, the types of hymen: normal hymen, this is a imperforate. This is a imperforate hymen. This is a microperforate. This is a microperforate hymen, and the next one is a something like the cribriform plate, the ethmoid plate. So, cribriform hymen, okay, that is kind of the ethmoid plate has these many small holes, isn't it, in the sinuses. So, something like that. So, cribriform hymen and then the septate hymen. So, if you know about the hymens, this has also come as a question once. So, this is definitely the septate hymen. I'm sure all of you got that correct. Absolute contraindication for the insertion of the device as shown in the image below. Absolute contraindication. Now, this is going to get a little interesting. Trophoblastic disease, menstruation immediately after delivery, and ruptured condom during intercourse. Now, ruptured condom during intercourse. So, you can give this because the person is worried that she may get pregnant. So, yes, this is what is emergency contraception, and IUCD, you know, can be given for up to 5 days, because when does the implantation takes place? Implantation earliest takes place on the 6th day after intercourse, 6th day. So, you can put an IUCD up to 5 days after unprotected intercourse. So, yes, ruptured condom में तो डाल सकते हैं. And then immediately after delivery, yes, 10 minutes to 48 hours. That is the time when you can give the PP, post-placental IUCD. Menstruation is actually the good time to put, but we generally put it on the last day of the menstrual cycle. The cervix is open and it will easily allow the IUCD to be inserted. So, you will not give in a trophoblastic disease because it will cause perforation, a soft uterus. Very easily you can cause a perforation. So, the side effect in trophoblastic disease, the side effect if you use in a trophoblastic disease, perforation, hemorrhage and infection. So, that's why the answer is A, and most of you got that correct. Hysterosalpingogram was done for a primary infertility evaluation, and the findings shown below is here in the HSG. What anomaly is seen? So, yes, when you see a uterus like this, I'll try to show you with my hand. If you see my hand like this is a normal uterus and this is a septate uterus. If you septate uterus, the cavity looks like the picture here. If you see a biconate uterus also, the cavity looks exactly what it is looking here. So, biconate and septate. See, biconate like this, the top is having a bifid fundus, but in a septate uterus, the fundus is smooth, but the cavity is like this. So, yes, this actually can be a septate uterus. See, it could be a septate like this, or it could actually be a biconate uterus. That's the confusion. So, that's why we always say that it's very important that we know a few parameters, radiological parameters, which will help me. Otherwise, the best distinction is based on laparoscopy and hysteroscopy. That you should know. HSG is a good preliminary investigation in fertility. Please do not say HSG is the best test for tubal patency and the best test for anatomy. If you're saying that, that means it's very primitive information. We should know that HSG is done in infertility, but not as the best test, maybe as one of the preliminary tests. If there's a doubt with HSG, we always confirm with laparoscopy and hysteroscopy. That information done. Now, if the angle is acute like shown in this, so acute angle and obtuse angle, intracornual distance less than 4 centimeter, more than 4 centimeter. So, that is what is a septate uterus, and this is a biconate intercornuate uterus. So intercornual distance if it is more than 4 centimeters, and the angle between these cavities if it is acute and obtuse. Now acute is not necessarily less than 90 and obtuse is not more than 90. Acute means less than 75 degrees. ये भी एक नीट का क्वेश्चन था एक बार. And obtuse is more than 105 degrees. You can see that, right? No, you can't. More than 105 degrees. So, less than 90 in geometry is acute, but in obstetrics we say 15 degrees lesser than acute is sure short septate. That means less than 75 is acute and 15 degrees more than 90 is sure short obtuse, which is more than 105. So, by this very simple demonstration, I feel this is a septate uterus, right? So, that is a septate uterus. Let's see another one. Now, this, let me see, I'm going to see what questions you're asking me. Okay, fine, you're just answering so far. Chalo, ye dekhte hain. A pregnant woman with no other comorbid conditions develops preeclampsia. She inquires about the cause of a condition. The doctor explains that this is the failure of the invasion of what? Why does a woman have hypertension of pregnancy, preeclampsia? So, we say when the blood pressure is more than 140/90, after 20 weeks of gestation. 20 weeks of gestation के बाद ऐसा क्या होता है? What happens in the body that the blood pressure increases? So, before I give you the answer, I want you to see this, that in all normal pregnancy, there's a vasodilation in the spiral arteries after 20 weeks. Look, very simple logic that once the mother is having a baby, the blood flow to the baby should increase to get the nourishment to happen to the baby. So, if you see this very important picture, the blood flow from the mother goes to the baby by the spiral arteries. And now this black thing which is given here, this black thing is actually the blood. The spiral arteries from the mother in the uterus is giving this blood. So, this black thing is basically the blood in which the baby has dipped the villi. If you see that picture and look at my fingers, see the baby has dipped his villi. This is like a net. It is like a, Hindi में बोलते हैं ना जाल है, एक syncytium है. A baby has put his net into the mother's blood and is taking the nourishment. He's taking the nourishment from the mother's blood. He's not taking the mother's blood, RBC. He's taking the nourishment. So, this villi dip into the mother's blood and the baby just like that starts to suck in the nourishment. So, all the minerals, electrolytes, carbohydrates, proteins, oxygen, everything goes through this villi to the baby, but not the RBCs. So, that's why any mother, the mother could be A positive, the baby could be A negative, mother could be B, baby could be O. Any combination can survive in any mother because the mother is never giving RBCs to the baby. Mother is never giving RBCs to the baby. All right. So, just yeah. So, mother is never giving RBCs to the baby. Now, the flow to the baby should increase in pregnancy, and that is why there is remodeling. That is why there is remodeling of the spiral arteries in pregnancy. What is the meaning of remodeling? The spiral arteries will lose the muscle layer. Can you see the muscle layer is now replaced by some cells? This is replaced more, and ultimately there is so much of replacement that there is no muscle layer left by the time there is third trimester. So, can you see the diameter here of the blood vessel? And can you see the diameter here of the blood vessel? So, the blood vessel becomes progressively dilated. So, vasodilation is normal in all the pregnancies to increase the blood flow. And how is that achieved? The trophoblast. Now, this is the net, syncytium, syncytiotrophblast. And then there are these cells. These are the cytotrophoblast. So, syncytiotrophblast and the cells, cytotrophoblast. So, syncytiotrophblast and cytotrophoblast makes the villi, and a lot of villi is basically the placenta. You know that obviously. Now, these are the villi and this is the syncytium and these are the cytotrophoblast, the cells. Now, there are trophoblastic cells which come and replace these smooth muscles. So can you see these cells? They are similar to the cells here. So these are also trophoblastic cells which are invading and replacing the smooth muscle cells, and these are not the trophoblastic cells of the villus. So we say extravillus cytotrophoblast comes and replaces these smooth muscles, and that's what causes vasodilation. So that's what we are giving you here. What is the cause of the blood vessels to be narrow? It is because there is failure of the invasion of spiral arteries with the extravillus trophoblast. The answer is this itself. Radial artery, spiral artery by villus trophoblast, no. Extravillus, arcuate artery, no. So all of these are wrong. The answer is already given here. So the muscle layer of the spiral arteries is not replaced, and it persists to be like this. Normally it is replaced and becomes dilated. If it is not replaced and it stays like this, then you can imagine if the blood vessel is so narrow, the flow going towards the placenta obviously will be very less. So the mother increases the contractility of her heart to increase the blood pressure, and with the high blood pressure, when the blood flows through these blood vessels, then the baby gets a nourishment. So increase in the mother's blood pressure, that will help give perfusion to the baby. Normally, baby ka blood vessels becomes like this. The baby's blood vessels become like this, and normal blood pressure of the mother can perfuse her baby. But now the blood vessel is like this. That's why vasospasm has happened. So the pathology of PIH is vasospasm. The whole discussion of PIH is about vasospasm. So that vasospasm present in the spiral arteries is the reason by which the mother increases her blood pressure. Now, you think the blood pressure is high only in the uterine arteries and the spiral arteries? You think the blood pressure is high only there? This high blood pressure is going to the uterus, the same high blood pressure is going to the kidneys. Such high blood pressure, zigging, that high blood pressure is going to break the glomeruli and the patient is going to have proteinuria. The same high blood pressure goes to the liver, subcapsular hematoma, liver injury, SNI damage, dysfunction of the liver. That same high blood pressure goes to the eye, papilla edema and retinal hemorrhages. The same high blood pressure goes to the brain, releases glutamic acid. Glutamic acid release causes convulsions. So the whole pathology of the mother is based upon the high blood pressure, and that high blood pressure is to overcome the vasospasm. All right. So once you've understood that, I just want to tell you more. Yes, the answer to the question I've already given you. The answer is A. Now I just want to tell you this vasospasm is contributed by a few more things. Vasospasm, lot of questions come on this. I thought I'll just quickly revise this for you. Vasospasm can be because of the inadequate invasion that I've already discussed. I'm not telling you. It is also contributed by the increase in the T helper 1, not I, I'm sorry. T helper 1 function. Normally what happens in pregnancy? Normally there is T helper 2 bias in pregnancy. So when there is more T helper 1 function, the cytokines which are released will contribute to the vasospasm. Don't forget, the key word is vasospasm. What contributes to the vasospasm? The immunity also contributes, the bad immunity. The T helper 1 function increases in a PIH pregnancy. Normally there is T helper 2 function bias in pregnancy. If TH1 increases, vasospasm. What else contributes to the vasospasm? Increase vasoconstrictors and decrease vasodilators. Now, what are the vasoconstrictors? Vasoconstrictors are like the angiotensin and the thromboxane A2. And vasodilators will reduce like the nitric oxide and the prostacyclin PGI2. So, reduce vasodilators increase vasoconstrictors. And very important, एंटीएंजियोजेनिक, ये आने वाला है गाइस, INI-CET में बहुत बार आ चुका है, एक बार नीट में आया. This is coming, एंटी एंजियोजेनिक फैक्टर्स. anti-angiogenic factors. When you want a good placenta to form, you want good blood vessels, you want the blood vessel to modify and become dilated, and that dilated vessel gives good flow to the baby. Now, if that blood vessel is narrow, it is vasospasm. What else contributes to the vasospasm? The anti-angiogenic factors. What are angiogenic factors? Look, I want angiogenesis here. There are a lot of times when you keep talking about, anti-angiogenic factors when there is proliferative, neoproliferation is happening in the eye, and when you want to do anti-angiogenesis by anti-VEGF, fine. In the eye, you don't want all that to happen, but in the placenta, you want that to happen because you want good blood vessels to form. So, angiogenic factors are required, but anti-angiogenic factors are increasing, which causes vasospasm. Now, let's just see this a little bit more in detail. So, angiogenic factors are vascular endothelial growth factor, and then the transforming growth factor. Now, these are limited by anti-angiogenic factors. I'll write them here. Okay, anti-angiogenic factors like soluble endoglin, and this is limited by soluble FMS like tyrosine kinase 1. So we generally write it SFLT1. Soluble FMS like tyrosine kinase 1 and soluble endoglin. Basically, this is soluble endoglin. So, soluble endoglin binds to the transforming growth factor, and SFLT1, soluble FMS like tyrosine kinase 1, will bind to the vascular endothelial growth factor. So, these are the anti-angiogenic growth factors. So, when there is no angiogenesis, blood vessels will stay spastic, vasospastic. So, basic pathology is vasospasm. The basic reason is inadequate trophoblastic replacement of the spiral arteries muscle. Basic. What else is contributing? These three things. So, if you remember this, NEET exam comes in a little bit more detail about these factors. Chalo, let's see something else. What would uterine artery Doppler be able to detect at 14 weeks of gestation in a woman with G2P1 score? G2P1 means she's a second gravida, para 1. She's had a delivery earlier, now she's second gravida. And you do a uterine artery Doppler. Now, uterine artery Dopplers are known to see the flow in the blood vessels. At 14 weeks, what you can see, if the uterine artery flow is not good, that means later there can be problems. At least this much we can know just by that, isn't it? So, this can tell us something about early onset eclampsia. All right. So many times we see blood pressure is high after 20 weeks. Sometimes it is high after 30-32 weeks. But we can predict if the uterine artery Doppler is showing us some resistance and high restive index. So, just see that early onset eclampsia. Yes, some people say it can also help in diagnosing early problems of field growth restriction, but pre-eclampsia will eventually cause growth restriction. Okay, so I'll go with the stronger answer as B for Bombay. This will be the better answer. So, abnormal uterine Doppler is heavily linked to a significantly increased risk of developing preterm or early onset preeclampsia. A uterine artery Doppler between 11 to 14 weeks is an early warning system. It measures the resistance of the blood flow from the mother to the placenta. So, if the spiral arteries fail to remodel properly, it can cause a high vascular resistance. It results in a high pulsatility index, high restive index, and persistent diastolic notching. You know, there should be systolic flow and diastolic flow, systolic flow and diastolic flow, like that. But if the flow is like this, there is a diastolic notching. This diastolic notching is the first sign of compromise. Systole में flow है, diastole में flow है, systole में flow, diastole में flow. But if there is a diastolic notching, then this pattern, increase RI, increase PI and diastolic notching, will tell us that there is compromise to the flow. That means the blood vessels are not modeling properly. If the blood vessels are not modeling properly, then the mother will have to increase the blood pressure to push blood through these narrow vessels later on. So, that's why it can predispose to early onset preeclampsia. That's why I taught you preeclampsia before I taught you this question. Chalo, आगे बढ़ते हैं. After conducting delivery by the maneuver shown below, incomplete separation of the placenta and massive hemorrhage was detected. What is your next step in management? So you can see incomplete separation of the placenta. What are you doing? You are having the cord in your hand, your other hand is on the abdomen. So you're doing a controlled cord traction. When you're doing a controlled cord traction, see, you're holding the cord and putting one hand here. This is what is a controlled cord traction. So when you're doing a controlled cord traction to take out the placenta, and maybe the placenta comes out half or the cord breaks, then what do you do? Yes, interns, what do you do, man? You put your hand and take out the placenta there and then, isn't it? Don't do that. Take it to the OT and do it. Or at least give her some pethidine in the labor room itself. You're ideally supposed to do it under anesthesia, but tum log, because your PGs also do it, you also do it, isn't it? Please, it's a very painful experience to put a full hand in the vagina of a lady. Yes, it is accommodative right now because a baby of 3 kg, 3.5 kg has come out. But whenever you do a manual remove of the placenta, please do it under anesthesia or at least some IV sedation. Okay, so the management is manual removal of the प्लासेंटा. स्पॉन्टेनियस डिलीवरी की मैं नहीं वेट करूंगा भाई. जब टूट जाता है तो स्पॉन्टेनियस डिलीवरी करने में देयर विल बी लॉट ऑफ ब्लीडिंग. आई डोंट वांट दैट टू हैपन. So conservative managements are described by a lot of people. You'll see journals will say just start oxytocin. My women, the patients who are coming to me in the hospital, they are as it is anemic. So that's why we expect you to answer remove the placenta manually. Manual remove the placenta. Now this is different from something else. This is a retained placenta. This condition which I have described in such a long statement is basically retained placenta. When we talk about a retained placenta, you do a manual removal of placenta. But there's another condition which is retained placental bits. What are retained placental bits? The delivery has happened, the patient has gone home, but you did not check the placenta properly after delivery, and there's a small chunk of placental tissue which has stayed back, and that gets infected, and the patient has secondary PPH, which happens from after 24 hours of delivery till 12 weeks. So patient comes to me after 2 months of delivery. 8 weeks later, she comes and says, sir, I'm having profuse bleeding. You delivered me and I'm now bleeding profusely. She comes to me after 8 weeks. I do an ultrasound, I see there's a small chunk of placental tissue which has stayed back, and this has now got infected. This now got badly infected, and that infected placenta is making her have a bleeding. Now, when a patient is bleeding because of retained bit, forget putting your hand, you can't even put your finger inside. So when there is a retained placental bit, then you have to do a curettage. You have to scrape this out. You cannot do a manual removal. So retained placental bit, you do a curettage. A curettage is done, okay? Yeah, most of you are going to say DNC, but when a woman has delivered, you don't have to dilate. So if you say DNC, you are like, okay, you know that you have to do a curettage, but we don't say dilatation curettage. If you simply say curettage, that is enough. Of course, it's a OT procedure. Now, this curettage is in a puerperal uterus, and this is likely going to cause Asherman syndrome. Asherman syndrome, highest likelihood. It's a frequently, if you see Asherman syndrome, it is because of overzealous curettage. One of the causes overzealous curettage, other one is the tuberculosis. Now, when there is overzealous curettage, that overzealous curettage can be done when you're doing an MTP, you're doing let's say DNC for abnormal uterine bleeding, or you're doing a DNC for this. Let me tell you, curettage, where all you can do it for abnormal uterine bleeding, you can do it for a DNC for MTP, that is also a curettage, or for a secondary PPH, which I am describing right now. So curettage, all over gynae, curettage is done for these conditions. When you're doing a curettage, and if you're really over enthusiastic and tumne ragad ke uterus ko, you've done so much of injury that the uterus has totally got injured and fibrotic, that is going to cause Asherman syndrome. Okay, second amenorrhea because of endometrial destruction. What condition can cause Asherman syndrome more likely? A curettage done for secondary PPH. Okay. So massive hemorrhage is mentioned already. So we will do the manual removal even then. Why not? We have to do it even faster because the cause is come. I like your question so much. What else do you want to do? What else you want to do, my friend? Come. That's a very good question. I like such questions, guys. See, the placenta is, one chunk is here and half of the placenta has come out like this and this much is still inside. And there is massive hemorrhage because this uterus here, see, this uterus is not contracting. ये uterus contract होगा तभी तो उसका base में से bleeding बंद होगा. The base will stop bleeding only when the uterus gets contracted. Now, if the placenta is still there, the uterus won't contract. Suppose it is stuck there, it won't contract. Suppose it is just lying in the uterus, still the uterus will not contract properly. So I have to do this even faster. Why is it this an emergency? This is the typical obstetrics emergency. It's a bloody emergency. That's what is obstetrics. The moment there's a retained placenta, you cannot say कि अरे यार तेरा बेबी तो निकल गया, placenta is retained, कोई बात नहीं, I'll go and have lunch and come back. By the time you come back, the patient will be dead. That is what is obstetrics, man. You immediately rush. You can have anything happening in this world, but this woman goes to the OT and you put a hand inside the uterus and take out the placenta. That's what is manual removal of placenta, because there is massive hemorrhage and more massive hemorrhage will happen, you lose the patient. Oh wow, you got me spurred up, man. Good question. Chalo, let's move on. Okay, should we give oxytocin first? Oxytocin चलता रहेगा यार. Oxytocin चलता रहेगा. Oxytocin साथ में चलता रहेगा, ठीक है? Oxytocin में मना नहीं कर रहे हैं. Spontaneous delivery. Just to overemphasize, nothing called spontaneous delivery when the patient is already having massive. Okay, chalo. Good you asked me and good we discussed. आगे बढ़ते हैं. Profuse bleeding and features of disseminated intravascular coagulation was found in a patient who collapsed soon after delivery. Which of the following is the most likely etiology? देखो यार, this question has come so many times and a lot of confusion keeps staying. Okay, I'm taking away the question. Wait. Now, patient delivers, shock and dies. There is only one answer, that is PPH. Never forget that. Most common cause of death after delivery in shock is PPH. That's all. A question they have twisted. They're asking you something else. So be very careful. Patient delivers, delivery done by a intern. That line has also come in the exams. One intern has done, I mean, they have agreed that the interns don't know anything, which I really don't like such questions. They could have written untrained person, but this question came in one of the MCI exam, I think June 22. So you are asking intern to do the delivery and he doesn't know control cord traction. He holds the cord and pulls the placenta out. He pulls the placenta out and causes a inversion of the uterus and the shock and the patient dies. So that story will be given. Delivery done by a untrained person and patient has inversion and dies. So patient delivers, bleeds and dies, PPH. Patient delivered, does not bleed too much, but the delivery was done by an untrained person and the patient died because of a hemorrhage, because of a neurogenic shock of a inverted uterus. Patient delivers, no bleeding. Delivery done by the head of the department of Obs and Gynae, senior person like me. बहुत अच्छे से किया. Nothing wrong. Doctor is sitting and doing episiotomy, talking to the patient, talking to the nurse. Nurse, चाय ready करो, बस ये suturing करके मैं आता हूँ, फिर चाय पीते हैं and get me some biscuits also. ये सब बातें चल रही, काम हो गया. We are just doing an episiotomy. Suddenly the mother stops talking. She suddenly passes out. Crash of her blood pressure, thready pulse, low volume pulse, and blood pressure is gone. And we start CPR. We intubate the patient, give ADR, give atropine. There was no PPH, but the patient delivers and within next 15 minutes, she goes into shock and next 15 minutes, we stop half an hour ideally, we stop the CPR and declare her dead. Now that is amniotic fluid embolism. So they will give you the story very nicely. Okay. Remember, you will understand this. So patient who has collapsed soon after delivery and there is DIC ka features. This is definitely amniotic fluid embolism. Yes, it can be PPH, but they've not given you a story of bleeding. Peripartum cardiomyopathy, they should have given you more information. Yes, the dilated cardiomyopathy is the most common cardiomyopathy of pregnant mothers. They should have given you, there was some, respiratory distress in the mother during labor. Before delivery, she was having NYHA 2 or 3 symptoms. Something should have been there. Sometimes they are not there. She may not be symptomatic. She may have dilated cardiomyopathy, but there will be more information than this. DCM does not go into DIC. That is also something you should know. Rupture of the uterus, not at all. They will not say soon after. They'll try to give you suprapubic pain and sudden collapse. The baby details should be there. So rupture uterus is unlikely. This is ideally the amniotic fluid embolism. So when a patient has amniotic fluid embolism, the incidence is very, very low, fortunately, but most of them die. Yes. I'm going to teach you that more than 50% will die. That means around 30-40 we should be able to save. In my practice, we've saved 2 people. I mean, like, they were vegetative women. They had severe hypoxic brain damage. All my life, yes. I'm bad at managing amniotic fluid embolisms. If somebody is saying that he's very good, God bless him or her. But amniotic fluid embolisms, we mostly lose the patients. Very major stark reality of life. Just pray that you don't have a patient with amniotic fluid embolism. It can just suddenly, obstetrics is that branch, suddenly you have, obstetrics is a happy ending branch, isn't it? Sara time, sab kuch khushi to hai, baby ho gaya, and lot of happiness we spread, and we get a lot of sweets and chocolates. But one day you're going to have an amniotic fluid embolism, and then you're going to lose all the confidence on yourself. So yes, that is that. It is an anaphylactoid reaction. The amniotic fluid releases the tissue factor, and that amniotic fluid gets into the circulation, releases the tissue factor, which will start triggering the coagulation cascade, and it will go into DIC. Then the fetal squams will release the endothelin, which will also be contributing, and the amniotic membranes will release the phosphatidyl serine. All of this will contribute to the coagulopathy, the anaphylactoid reaction, and then the coagulopathy. And then the phases of the amniotic fluid embolism. The first phase is actually the cardiovascular collapse, then the patient goes into DIC, and then multi-organ dysfunction, and that's why we lose most of these patients. Yes, more than 50% patients will die. Now, what are you guys asking me? All right, you're answering so far. Chalo, chalte hain aage. A multigravidia is in the second stage of labor for the past 2 hours. Multigravidia, second stage for the 2 hours. More than 1 hour is prolonged in a case of a multigravida, and more than 2 hours is prolonged in a case of a primigravida. On examination, contractions are adequate. The cervix is dilated with the head stationed at 0. Head is at 0. Molding is 2+. This is not station. Molding means the bones, the fetal bones. Yes, these fetal bones, if you understand, sometimes the pelvis, if you see, this pelvis is so adequate. This baby can go into this pelvis and aram se come out. This is a very spacious gynecoid pelvis for this baby's head. Now, sometimes the pelvis is narrow. So, if the pelvis is narrow, especially the mid pelvis, what will happen? These bones, can you see the parietal bones, the frontal bones, the sagittal suture? So, if you imagine my fingers as the bones, the sutures are not fused. So, to enter narrow spaces, the head will mold. The molding of the head, and the head enters the pelvis. So, this molding, no molding, the bones are separate. Grade 0. Grade 1, touching each other. Grade 2, overlapping, but you can reduce them. Grade 3, overlapping, but you cannot reduce them. So, more severe the molding, more harder the baby is trying to go through narrow places. So, more severe the molding, more severe is the contraction of the pelvis. Now, we understand this, and let's see this. The molding is 2+, bad enough. Next is 3. And caput is 2+, means the head is at a place for a long time This head is at a place, same place for a long time, and since it is staying there for a long time, it is getting the accumulation of fluid also in the head. Caput is also forming, molding is also forming, but the head is at 0 station. So, I have always told you one thing. Remember one basic principle in obstetrics: 0 plus 1 plus 2 plus 2 station. If the head is at plus 2 station, see, head is at plus 2 station. That plus 2 station is the assurance. This is going to come later also in our discussion. This plus 2 station is the assurance that the broadest part, the broadest diameter of fetus is the bipedal diameter. It has gone through the narrowest. It has gone through the narrowest mid-pelvic diameter. What is the narrowest mid-pelvic diameter? Bispinous diameter. We also call it interspinous diameter, which is 10.5. So, bipedal diameter 9.5, interspinous. So, this is 9.5 and from here to here is 10.5. So, when the baby, the broadest part has gone through the narrowest part, the station will be plus 2. In other words, when the lowest bone, I do a PV, I do a PV like this, lowest bone, and I put my finger here and I see the ischial spine. See here like this. I put my finger in the vagina, see the head and the ischial spine. See, this is how you see that. So, when you feel the head of the baby and the ischial spine at the same level, 0 station. But when it is at plus 2 station, yes, when it is at plus 2 station, see, this is how you see plus 2. Yes, with my experience as an obstetrician, I can make out. See, this my finger, the station is plus 2. Why? My middle finger is much higher, that is the ischial spine, and my index finger is much lower. So, with the PV, I know it's a plus 2 station. Plus 2 station means the broadest part of the baby has gone through the narrowest part of the pelvis, and the chance of delivery is excellent in this patient. Most likely to happen until unless there is an outlet contracture. So, this patient's head is actually at 0 station. It is much higher than this. So, 0 station means the head is actually like this. It is here. This is 0 station. Now, what is the other story? The sagittal suture is in the right occipitotransverse position. The fetal heart rate is 140. That means there is no distress. Which of the following is carried out for the management of this patient? Right occipitotransverse, and for the last 2 hours in a multigravida. Okay, she's a multigravida. She should actually deliver fast, but maybe the baby is big in this pregnancy, and for the last 2 hours it is at 0 station, and I will not do instrumentation here. I will not do instrumentation because instrumentation is done only at plus 2 and below, because I know that my instrument will be able to bring the baby down. In modern obstetrics, instruments support at plus 2 station and below, forceps and vacuum. Now, she's at 0 station. She's there for the last 2 hours. In a multigravida, there's no business that she'll stay at plus 2 at 0 station for 2 hours and more. This patient has a cephalopelvic disproportion, and also there's a right occipitotransverse. So, it is classically that deep transverse arrest, which is not going to come down. I cannot even do rotation of the head because there is severe molding. I cannot try to rotate and take the baby out by forceps because it is not coming down. So, I will go and say do a cesarean section. C is the best answer for this, not B, vacuum assisted. नहीं कर सकते भाई. No, you cannot put forceps in vacuum. You cannot put plus 2 and below, because the broadest part of the baby has not gone through the narrowest part. If the baby is very high and the baby is having a big head, you can apply forceps, and with my muscles and a big, 90 kg man, I can go and put forceps anywhere and hold the baby and pull him out. निकालना तो कोई भी कर सकता है. You can take out any baby from any pelvis. But what condition you take out? You break the pelvic bones, you tear the vagina, she bleeds and have a massive PPH, and the head gets crushed. The head gets crushed and the baby comes out with intraventricular hemorrhage, and baby will have cerebral palsy because of hypoxia. You are not going to do that kind of delivery, isn't it? Only at plus 2 and below, you're going to do these things. Right. So, chalo, आगे बढ़ते हैं. Good evening. Some people are joining late. Where to find the PDF? Can you please? PDF will come at the end of the class, and my, the PW team is going to send it to you. I'm sure. We always give it to them. Don't worry about that. Okay, so cesarean section is the answer for this question. A primigrata presented at 40 weeks of gestation with lower abdominal pain. 40 weeks, lower abdominal pain. She has been in labor for 3 hours. Okay, which of the following will be determining that she's in active stage of labor? Okay, simple question. Fetal head is 5 by 5 palpable per abdominal examination. What is 5 by 5 means? If you see the head of the baby, now this is actually a little tricky, okay? You look here, see the head of the baby is divided into 5 imaginary parts. If you see the head, if you put 4 lines, my fingers are too stubby, but imagine there are 4 lines you draw and divide the head into 5 parts. So when do we say the head is engaged? See, this is a unengaged head. All the 5 parts are palpable per abdomen. Now this has gone inside 1/5, 2/5, 3/5. When more than 3 or more parts have gone inside and 2 and less are outside, we say the head is engaged. So 2/5 or less is an engaged head. Now this is nothing to do with the active labor here. So head is 5 by 5 palpable means it's an unengaged head. Less than equal to 2 by 5 palpable is called engagement. Engaged head. Okay, that is nothing to do with active labor. 2 contractions lasting for 10 seconds in 10 minutes. Nonsense. 3 contractions or more in 10 minutes and more than 40 seconds. That is what is a good contraction. So we can have how many contractions in 10 minutes in pregnant ladies who are delivering? 3 to 5 in 10 minutes. And more than 5 is known as a tachysystole. It is known as a tachysystole. That is too many contractions. So then we sometimes relax the labor, because if there are too many contractions, then the fetal perfusion will get compromised. All right. So this is not active labor. Rupture of membranes is no sign. Rupture of membrane can happen even before onset of labor, which is known as premature rupture of membranes. All right. So that is also not. So more than 4 centimeter cervical dilation with complete effacement. Yes, more than 4 centimeter dilatation is what is active stage of labor. So yes, all of us know that we start the partogram only. Okay. 0, 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. So 4 centimeters and more, we start the partogram. Okay, partogram. So we have the alert line here, and 4 hours later we have the action line here. So partogram is started at 4 centimeters because that is active labor. Now this is the modified WHO partogram. Yes, we all know that ever since 2018, there is something called the Labor Care Guide given by the WHO, and that has modified things. They say 5 and more. 5 centimeters and more is active labor. American College of Obstetricians and Gynecologists say 6 centimeters and more is active labor. देखो यार, मेरे को ना आप लोग जब बोलते हैं ना अपडेट क्या आ गया, लेटेस्ट क्या है यार, you should know what is happening in the labor rooms in the hospitals in the country, the government hospitals and the medical colleges, because the Ministry of Health and Family Welfare decides what we follow. So labor care guide has been there around for a long time. When the partograms in all the medical colleges change, I will tell you. But yes, I have always taught you for the last 5-6 years I am selling, if they say labor care guide because they're trying to ask you an update, please go ahead and say 5 centimeters active stage of labor. UPSC 2 weeks back, active stage of labor according to labor care guide. Finally that question came. According to labor care guide, how much is active labor? Beyond what centimeters active labor? 5 and more, correct. But in WHO partogram, it is still 4 centimeters. You can go to any of the medical colleges, it is still 4 centimeters. A lot of people are saying we must implement the labor care guide. Go ahead and implement it and ask regularly the labor care guide. Go ahead and answer that. So if they ask you labor care guide specifically, answer 5. Otherwise, active stage of labor is 4 centimeters and more, and that's when we start the pardogram in the country even now. Right, so that's done. Question has been answered. Identify the blue colored area shown in the image below. So if you see, there's a, from the back of the pubic symphysis at the junction between the second sacral vertebra and the third sacral vertebra is here, and from the base of the pubic symphysis to the tip of the sacrum. Ideally, this should have been here, tip of the sacrum, not here. It should be at the tip of the sacrum. So this zone is the zone of the mid pelvis. So what are these markings? So this upper one is the plane of the greatest pelvic dimensions, and this is the least pelvic dimensions. If you try and see, I know I'll try and help you here. If you see the greatest and the least, so the greatest pelvic dimensions are from the back of the pubic symphysis, not from the tip, from the back of the pubic symphysis, you know, because there is a bony projection from the back of the pubic symphysis. So from the back of the pubic symphysis to the junction of the second and the third sacral vertebra. Why? Because it is very roomy here. Dekh rahe na aap, so roomy here. See, if you see the sacrum coming like this area will be roomy. See, यहाँ पे सबसे ज़्यादा curve है. So this area will be the roomiest, greatest pelvic. So from the back of the pubic symphysis to the junction of the second and the third sacral vertebra, and going on the sides to the upper border of the sacrosciatic foramina and the obturator foramina here. So sacrosciatic notch, obturator foramina, and coming like this. So this is the plane of the greatest pelvic dimensions. Now, what is the narrowest diameter of the mid pelvis? Remember, narrowest diameter of the mid pelvis is the bispinous diameter, narrowest. So the least pelvic dimensions. So this, can you see? Yes, through my shirt. Okay, yes. Now you can see the two bones. Yes, these are the two ischial spines. This is the narrowest. So narrowest mid pelvis is this. So the least pelvic dimension will go through this. So the two ischial spines, the base of the pubic symphysis and the tip of the sacrum. Base of the pubic symphysis, tip of the sacrum, and the ischial spines on the side. So that is the least pelvic dimensions. So yes, they're showing you a cut section here. They have not given you the boundaries, but I just told you the boundaries. If you have not written them, then please rewind and replay. You will remember them. All right. So this is the mid pelvis. This is the mid pelvis. Okay, plane of the maximum pelvic dimensions and the least pelvic dimensions. On the second day post delivery, what will be the level of the uterus? Now, this is something which is so individual. Okay, it is so observer variant that I really hated this question. This actually came in the exam. Immediately after delivery, the uterus is just below the level of the umbilicus. Let me just tell you the story here, very important story. And the uterus becomes a pelvic organ in 2 weeks, and it becomes a normal organ in 6 weeks. So why are they asking you this question in the first place? That when you see the uterus, you know, the uterus is here, suppose, I can't show you, okay, I'll get up like that. So when the uterus is just below the umbilicus here, suppose you're feeling the uterus here, then what you can do, you can feel the uterus, make incision here, go into the abdomen and do a very simple tubectomy. That's why they keep asking you this question. Where is the uterus immediately after delivery? Just below the umbilicus. Today she's delivered, is just here. So one finger below you will see it, and you can make an incision tomorrow morning and do a very simple tubectomy. Now every day it goes down by 1.5 centimeters. See, 1.5 centimeter is my finger. Every day it goes down. Some books say 1.25 centimeter. That's really, you know, fingers are not vernier calipers, okay? And the uterus also doesn't go down by that kind of a measurement. It's roughly around one finger, or roughly around 1.5 centimeter in length. So day 1, it is just a finger below. Today, that is, I'm so sorry, day 0 and day 1, you know, you will see that it is one finger below, and second day it will be 2 finger below. So that's why it's a very observer variant kind of a finding. So we'll say 2 finger breadth below the umbilicus. Okay, 3 finger नहीं होगा यार, 2 होगा. Okay, अच्छा नहीं 3 हुआ ना, because 1 on the day, 2 on the first day and 3. Yes, I will go with 3 fingers. I'll go with 3 finger breadth. Yes, correct. On the day of delivery, it is 1 centimeter below, and second day it will be 2 finger, third day it will be 3 finger, right? Your second day it will be 3 finger, right? Go ahead. And my 2 fingers, that's why I keep saying it is so observariant. Look here. This is the finger of a typical lady who's a gynecologist. She's 5 feet 2 inches height of a lady. Her fingers will be typical fingers of a woman. And look at a finger of a man like me. So it is so observer variant that I feel that this is not a great question to ask. If they had asked in centimeters also, it would have made some sense. But never mind. On the day of delivery, 1 finger. Tomorrow, 2 finger. And on the second day, 3 finger. All right. Chalo, let's move on and see. Okay. Nutritional advice to a primary grada at 12 weeks of gestation is nutritional advice to a primary grada at 12 weeks of gestation. So now that's the beginning of the second trimester. Remember, in the first trimester, we don't have to give any additional calories. At 12th week, that is the beginning of the second trimester, till 28 weeks is the second trimester, and after that it's the third trimester. So second trimester, we should increase the intake of the calories. So additional 300 calories in the first trimester is wrong, 300 calories in the second trimester is right, 400 calories in the third trimester, that is not at 12 weeks. So this is correct, but it is not, I mean, it's a correct answer, but they're asking at second trimester, so that's fine. Throughout the pregnancy, no, that is not correct. So yes, the answer is B for Bombay. Additional 300 kilocalories in second trimester. Actually, these were the choices. I think they have come from the PSM book, but additional calorie intake from Williams Obstetrics is 350 kilocalories in the second trimester, that is 12 to the 28 weeks. And third trimester, it is 28 to delivery, that is the third trimester, and that is 450 calories per day. All right, so remember that, and let's move on. Which of the following is a contraindication for cervical encerclage? You know that cervical encerclage is for a short cervix like this. If you have a patient who's got a short cervix, let's say the normal cervix should be something like this. This should be the normal length of the cervix. But suppose the cervix is small. The cervix is only like this. See, this is the cervix. So if the cervix is so small, this is the cervix, which is very small. A small cervix can get effaced and cause an abortion and also cause preterm labor. So for this cervix, we will have to put a cerclage. When you put a cerclage like this, it prevents the preterm labor and abortion. Now, what is a contraindication? Advanced maternal age, we can actually put it till 28 weeks, because after 28 weeks, I don't want to put. Why? Because if a baby delivers, let's say at 30 weeks or 32 weeks, the baby can be saved. So till 28 weeks, I can put. We can put a cerclage till 28 weeks because you want to hold the cervix so that the baby doesn't deliver. So recently one patient came to me and she was saying that, sir, I'm having mild heaviness. I did a per-vaginal examination and the cervix was actually 2 centimeters dilated. And the patient had delivered twice earlier. So it was a patulous cervix and a little bit more, looked like 2 centimeters dilated. Somebody had put a stitch somewhere in private. Now she says, sir, is my baby going to come out? I said, it is 2 centimeters and the cervix, there's a stitch already. I'm not going to put any more stitches for you because you're already 32 weeks. Even if you deliver, I can save the baby. So there is a stitch in place, we'll wait. She ultimately went till 37 weeks and delivered vaginally and the baby is healthy. So I will not put a stitch after 28 weeks because if the baby delivers, I can save it. So advanced maternal age, advanced period of gestation is definitely not a contraindication. That's not the answer. Prolapse of membrane into the vagina. What is the meaning of this? prolapse of membranes into the vagina, something like this, but the membranes are intact. So I can push this membrane inside by a wet tissue, hold the membrane inside, and then apply a suture like this. I can push it inside and do a suture. So yes, this is what is known as a emergency cerclage. We do it so many times. Yes, this is also not a contraindication. So advanced maternal age is not a contraindication. Prolapse of membrane through the vagina is not a contraindication. Fetal fibronectin is positive. Yes, it is telling me that the patient is going to go into labor, but it's not a contraindication. Yes, I'll go ahead. Ruptured membrane is definitely a contraindication. If the membranes are ruptured, then you don't put a stitch, because already the membranes are now in communication with the vagina and already the bacteria would have gone inside. You're only going to increase the sepsis if you put a stitch. So definitely ruptured membrane. Following, which one is a contraindication? Ruptured membranes. All right. Good, most of you got that correct, I think. Let's move on. Primary gravidae present in the early stage of labor with adequate uterine contractions. On per vaginal examination, she seems to have a gynecoid pelvis. The membranes are ruptured and the vertex is felt in the right occipito-posterior position. How will you manage this patient? She has an average gynecoid pelvis, matlab everything is fine. And now there is a baby which is in a right occipito-posterior presentation. So if you see this one, and you see the occiput, this is occipito anterior. Okay, this is occipito anterior. The light is enough. All right, this is occipito anterior. You can see that, yes, occipito anterior. Now this is the right occipito anterior. Patient's right, not your right. Patient's right. This is right occipito transverse, and this is right occipito posterior. How do you say it is occipito posterior? The triangular suture. Always in your exams, they'll put a suture like this and there'll be a triangular suture here. The triangular suture will be the hallmark for us to decide, because the occiput is next to the triangular suture, the lambdoid suture. Okay, you know, ahead in this, I'm showing you this also. See, this is a triangular suture, and this is in the posterior part of the pelvis, and it is towards the right of the mother. This is what is a right occipito posterior. Now, what happens in a right occipito posterior? See, this is a right occipito posterior. It hits the pelvic floor, and in a gynecoid pelvis, it's going to hit the pelvic floor, rotate to occipito transverse, rotate to occipito anterior, and become ultimately direct occipito anterior and deliver vaginally. So, occipito posterior delivers by becoming occipito anterior. That is in a gynecoid pelvis. Suppose the pelvis is not gynecoid, it is an anthropoid pelvis. Rotation is not possible. So, right occipito posterior stays occipito posterior. So, it delivers as occipito posterior. It can deliver as occipito posterior. See, it has delivered. Only thing is that the face will be looking at the pubis of the mother. This is what is a face to pubis delivery. So, occipito posterior may become anterior and deliver, or it stays posterior and still delivers. So, never say occipito posterior, I am going to do a cesarean section. Occipito posterior delivers vaginally. Yes. So, that's what we have to say. How will you manage this patient? We will do a normal vaginal delivery. Do not say cesarean section. Yes, you may have to do a vacuum, but that's not the intention. You will do a normal vaginal delivery. If she needs a vacuum, I'll do it. But the plan is to do a normal vaginal delivery. So, yes, you can put a vacuum, you can put a forceps. These are also good answers. But definitely the best answer is go ahead and do this. It's not that you intentionally going to do. Maybe they could have given a better choice, but normal vaginal delivery is what is going to happen. So, AIIMS, this question came. A woman is in occipito posterior, what do? Wait and watch. That was the answer, because she will go into labor, she'll get into active labor, and then she'll rotate and become occipito anterior and deliver vaginally. If she stays occipito posterior, it'll take a little longer, maybe another hour or so, but it'll still deliver vaginally. So, occipito posterior delivers. This is the one, right? Most of the times, it has a favorable anti-rotation. If you divide the pelvis into 8 parts, then it rotates 1/3, another 1/3, and another. So if you see, there are 1, 2, 3, 4, 5, 6, 7, 8. There are 8 parts in the pelvis. So it's rotating 1/8, 1/8, and 1/8. So 3/8 of a circle. 3/8 of a circle, if it rotates anteriorly, it can deliver. Or if it is an anthropoid pelvis, it'll just go back. It'll go back 1/8 of a circle and it'll become occipitoposterior. So in a gynecoid pelvis, 3/8 anterior rotation is possible and delivery happens. In an anthropoid pelvis, NEET people have not been asked this question for a long time. The brunt of this anthropoid pelvis and occipitoposterior has been taken by the FMGs of late. So this anthropoid, no rotation possible. No rotation possible. But never mind, it stays occipitoposterior and delivers by the method called phase to pubis. It will deliver vaginally. All right. So occipitoposterior delivers. Chalo, आगे बढ़ते हैं. A pregnant patient who underwent a classical cesarean section in the previous pregnancy presents to the OPD. Okay, she's in the OPD. She's currently at 35 weeks of gestation with breech presentation. What is the next step in management? Please don't say external cephalic version. In a previous cesarean, which is classical, I am not going to do vaginal. Even in a lower segment, I am not going to do a vaginal. तो इसको नहीं पढ़ते हैं. पहले एक चीज याद रखो. If breech is there, if it is breech, it delivers. Definitely breech delivers. But complicated breech क्या है? Complicated breech means breech plus intrauterine growth restriction, breech plus let's say previous LSCS, any other complication, breech as first fetus in twins. So all these, there are many conditions we say these are complicated breech presentations. So breech delivers, even primary breech delivers. See, we are asking you breech because we deliver breech. तो ये मत बोलो breech का delivery नहीं होता है. Lot of private hospitals and a few government hospitals now they made a rule कि primary breech है तो भाई पंगा मत लो, cesarean कर लो. That is not obstetrics. सभी का cesarean कर दो, obstetrics का खत्म ही कर दो ना यार. बढ़ाई क्यों रहे हैं obstetrics? सभी का cesarean कर दो. So the nature made vagina as the mode of delivery, and babies delivering vaginally and the mothers delivering vaginally are always better than mothers delivering with cesarean. That's not a, yes, cesarean has become fairly safe, but the best method of delivery is obviously the vaginal delivery. Easy recovery and much better conditions of the baby also. Now, if there's a problem, thank God we got a cesarean section to fall back on. So breech will deliver vaginally. Now, when a baby is delivering by breech, but there is an IUGR, I will not do. I will do cesarean section. There's a breech with a previous lower segment cesarean. I'll do a repeat cesarean. Now the question is, there's a breech with a classical cesarean section. I'll do a cesarean section at 37 weeks. Oh hello, classical में मैं तो 36 weeks पे कर देता हूँ, because if she goes into labor, she can rupture the uterus at almost 10% chance. So yes, but I'm not writing that. Don't remember what I wrote just now. But we do it off at 36 weeks, so that we don't want to take a panga that 37 weeks she goes into labor. So by the book, I'm teaching you cesarean section at 37 weeks. Go ahead and do that. And ultrasound and visit after 2 weeks. Even if it's cephalic, I'm not going to do a normal delivery. Internal podalic version तो इसमें होता भी नहीं. There's only one indication of IPV. Internal podalic version is in second of twin in transverse lie. Yes, there's a patient who has delivered the first baby and the second fetus is in transverse lie like this. Second fetus. In the second fetus, I go inside and hold the baby with my hand inside, other hand on the top of the abdomen, and I do a internal podalic version. So only indication of IPV, yes, this is the only indication. ब्रीच के लिए IPV क्यों करना है? ब्रीच तो नॉर्मली है, ब्रीच तो है ही, उसकी इंटरनल पोर्टालिक वर्जन क्या करना है? इट्स ऑलरेडी ब्रीच. So internal portalic version nonsense. Advice no, not right. External cephalic version at 36 weeks, no. I will not do in a previous classical. I will not do in a previous LACS also. We don't do versions. We can cause a stretch of the uterus and maybe a possible injury to the scar. So even in a previous LACS, I will not do a version. देखो experimental therapies पहले करते थे. What my professors have done and achieved in obstetrics and safely achieved, we cannot teach you as rules of obstetrics. Some of us will try and do things in obstetrics because we experience, and we can get away with a lot of risk also, but we are not teaching you that as basic rules. So rules say that we can do external cephalic version for breech at 36 weeks, but there should not be any scar on the uterus. In a scarred uterus, I will not do. So none of these things hold correct, and do a cesarean at 37 weeks. Chalo. Yes, A was the answer. A primary grad at 23 weeks of gestation presented with profuse vaginal bleeding. Her blood pressure and glucose levels are within normal limits. 23 weeks, profuse vaginal bleeding. Placental implantation at which of the following site can cause this? Now, that's a difficult question. 23 weeks, profuse vaginal bleeding. So now they are trying to scare you with the placenta previa at 23 weeks. Fallopian tube, ovarian will not last so long. Abdomen will not last so long. All these ectopic pregnancies are already settled by this time, going by the rules. So they are just trying to tell you a placenta previa, and placenta previa can bleed at 23 weeks. Yes, why not? Placenta previa will bleed mostly at term, but it has bled earlier also. Yes, they're a very simple question. There's not much to discuss about this. Okay, what are you asking? ECV in first pregnancy if breech, primary gravida. Yes, why not? Breech vaginal delivery is done. Breech vaginal delivery is done, definitely. If it's a primary breech, I'll do vaginal delivery. But yes, I will do a breech delivery. Who is supposed to do a breech delivery? You know that? Breech cannot be done by my PG, cannot be done by senior resident also. I have to do. A consultant has to be there. And a consultant will supervise a senior resident or a junior consultant to do a breech vaginal delivery. Now, the baby has come to me at 36 weeks with the cephalic, no problem, has come to me with the breech in a primary gravida. Obviously, I can turn it and make it cephalic in a primary gravida, and if it is cephalic, she'll deliver normally. If it is a breech, also will deliver vaginally, but breech vaginal delivery requires a consultant and it can injure more. Yes, breech vaginal delivery is classically more injuries versus normal. So why not try and turn the baby and make it cephalic at 36 weeks? Yes, primary breech, we can do external cephalic version. Okay, chalo, आगे बढ़ते हैं. A 31-year-old female patient presented with complaints of fatigability and constipation for the past 1 year. She has a history of multiple but transfusions after delivery 4 years ago. She has had a lactation failure and never regained her periods after delivery. What is the most probable diagnosis? So, a woman having fatigue and having lactation failure after a delivery. Now, there cannot be an easier question, and that is a postpartum pituitary necrosis or a Sheehan syndrome. Sheehan syndrome classical finding is lactational failure. Look, there are many variations to this history. I'm not going to details of that, but please remember, if there is a woman who is having lactation, she is able to lactate, give breastfeeding. A mother is having amenorrhea. She is not able to walk properly. She is having weakness, but she was able to breastfeed her child after delivery. It is not Sheehan syndrome. It can be many other causes of malnutrition, and amenorrhea can be many other reasons. So, if a woman is having lactation failure, that's the hallmark of Sheehan syndrome. You do not diagnose Sheehan syndrome without lactation failure. Okay? Right. So, yeah. This is a mnemonic for understanding what is the series of losing pituitary function after a patient has pituitary necrosis, a Sheehan syndrome. So yes, if the FSH and LH is lost, obviously gonadotropins are lost and the ovarian follicular genesis doesn't take place and the patient has no estrogen progesterone to cause periods. But what is the chain of events? So first thing to be lost in the order of losing, first thing to be lost is the growth hormone, then the prolactin, then the FSH, then the TSH, and the last to be lost is the ACTH. That's the series of losing the functions. So I remember it as general practice first, then advanced. पहले आप general practice करोगे, then you'll do advanced practice. That's not a very great mnemonic, but I'm not very good at mnemonics. I rather make you understand things, but sometimes we need mnemonics and GPFTA. Okay, so this is the chain of events. First, losses of growth hormone, the last losses of the ACTH when there's a Sheehan syndrome. Okay, is there a problem? Are you getting? Right. The ultrasound of a young woman with infertility is suggestive of a uterine anomaly. Which of the following is used to confirm the diagnosis? Now, this question has already been discussed. If you do an ultrasound and you think it's a septate or a bicornuate, you think it's a unicornuate, the best method to diagnose a Mullerian defect or a uterine defect is a laparoscopy and a hysteroscopy in the same setting. So, suppose there's a uterus which is having, let's say, a septum like this. So, this septum, how are you sure? Because when you do the HSG, when you do the HSG, you will see this yellow part, the radiopaque part, which I'm trying to show. But when you're doing a laparoscopy and a hysteroscopy, when you're doing a laparoscopy, like this, you put a scope into the abdomen, and you're doing a hysteroscopy, you put a scope into the uterus, then you're very sure that you're dealing with a septum, because in a laparoscopy, you see the fundus is uniform. So if you do laparoscopy, hysteroscopy, you best diagnose this. Now, answer is done. Now this one, see, this is a hysteroscopy, hysterosalpingography. In a hysterosalpingography, you're using a Leach cannula. Use a Leach Wilkinson cannula to put the radiopaque dye under fluoroscopy. Fluoroscopy guidance. Continuous radiation is known as fluoroscopy. So when you see this, you put in the dye here, you put in the dye, you can see the tube and you can see the uterine cavity, but you cannot see anything else. So that's why I keep saying it's not a complete investigation. It's a good preliminary investigation, but the best is to a laparoscopy and a hysteroscopy. So that is what is a HSG. Now, why did I show you this video? I want to ask you, what is the name of the dye for a hysterosalpingography? What is this dye which I used here? Come, tell me the name of the dye. Come, I'm waiting for you guys. Come. Yes? Water break for me, you tell me. जहां जा सकते हैं कैमरा पहुंचा दो. Yes, hysteroscopy, laparoscopy. Yes, you're very correct. जहां पे भी scope डाल सकते हैं. It's a good way. Nowadays, we keep saying in medicine that the body parts where you can put a camera, then that endoscopy becomes of that area. The endoscopy of that becomes the best diagnostic procedure. Correct. ENT में you can have otoscopy, you can do nasoscopy, you can do a endoscopy of the gut, you can do upper GI, lower GI. So wherever you can put a scope, that is the best way of diagnosing. So तुम लोग ने dye का नाम नहीं बताया यार. Nobody told me the name of the dye. Okay, fine. Since you're not telling me, I'll ask you. Please do not say tazographin or urographin. Don't say these. These are trade names. Nobody is going to ask you trade names. So please say the dye is it's a radiopaque iodine based dye, and the name of the dye is meglumine. It is meglumine ditrizoate. Meglumine. So for a hysterosalpingography, you need a radiopaque dye. It is, please don't say methylene blue. For a laparoscopy, when you're doing a laparoscopy, and in that when you're doing a dye test, that's where we use a methylene blue. That's where. So you're putting a scope, you put in a scope into the uterus like this and looking at the scope, and one of my intern friends or my PG is sitting below and with a leech cannula into the uterus. So I'm doing a laparoscopy, I'm looking at the uterus and you push in the dye and the blue dye comes out from the tubes. So when I look and see a blue dye, that's a laparoscopy and a chromotubation, and that's where we say methylene blue. But in this you say meglumine diazoate. Apart from the question in this, HSG करना best option नहीं होगा. HSG plus histoscopy नहीं. HSG plus histoscopy is it's a arrangement. You don't want to do a laparoscopy and the patient cannot afford a laparoscopy. We do this. I'm Partha's Harthi. I don't know how you got that understanding. We do this for many poor patients who say, I work in a Christian hospital. We charge patients, but we charge them minimal. Some poor patients cannot even afford the minimal amount of money. So what we do, histoscopy is much cheaper, we do HSG. But still, if you do a histoscopy in HSG, can you see the top of the uterus? Can you see the tubes properly? If they are stuck in the abdomen, will you know that with the HSG? No. So HSG histoscopy is a good jugaad, but not the best. So good question you asked. We do it occasionally, but I cannot teach you that. Best you have to know is laparoscopy, histoscopy and a dye test. Chalo. On examination of a pregnant woman, infraumbilical flattening was found and the fetal heart sounds were heard just below the umbilicus. What could be the fetal presentation position? So infraumbilical flattening. See, that's the picture here. So if you see, if the mother, I'm showing you mother in a view where I'm standing, sagittal section, showing you from the right side. So if a mother is like this and look at the abdomen wall is, this is the umbilicus, it's like this. And this baby's head is anterior, towards the anterior, occipital anterior, the baby will be like that. But when the occiput is posterior, see the occiput is towards the back of the mother. Occipital posterior, the back of the baby is towards the back of the mother. The baby is towards the back of the mother. So there is infraumbilical flattening. See, infraumbilical also there's a bulge, isn't it? If there is infraumbilical flattening, and you can easily hear the heartbeat. What is written here? Infraumbilical flattening, and the heart sounds were heard just below the umbilicus. Heart sounds are not heard just below the umbilicus usually. Heart sounds are heard. See, most common position. What is the most common position? Is the left occipitotransverse. See, left of the mother, bhai. Ye left hai, ye right hai. ठीक है? Left of the mother. So occiput is towards the left of the mother. Here, this is the occiput here. Left occipitotransverse. So the back of the baby is like this. So if you see, this is the umbilicus. Wait, I'll make it easier for you to understand. Okay, this is the mother's umbilicus, and there are the flanks of the mother's abdomen. This is the anterosuperior iliac spine, and the heart of the baby will be towards the left. So when we say the baby's back is here, this is the right of the baby, this is the left of the baby. So the heartbeat will be here. So it's in the spine-umbilical line. So junction of the left spino-umbilical line. Which junction? The medial 2/3 and the lateral 1/3. The junction of the medial 2/3 and the lateral 1/3 here. This where you're going to hear the heartbeat in the most common position, which is the left occipitotransverse. This is what is normal. Now this is occipitoposterior. Look at the head of the baby. The forehead is here, so occiput is posterior. In occipitoposterior, now you see the heart will be heard. Can you see this? Just below the umbilicus, just below the baby's heart will be somewhere here, just below the umbilicus, and very loud heard. So there will be infraumbilical flattening and a very loud and clear heart sound heard just below the umbilicus. Now somebody's still stuck at oh Parthasarthi again. Okay, fine, sir. But hysteroscopy से tubes and fundus दोनों दिख जाएगा. Tubes कहाँ से दिखा hysteroscopy से यार? I can't see. How can you see tubes? No man. Okay, practical हो जाते हैं तो oh. Yeah. See this. Uterus fallopian tube. Hysteroscope. I can see the uterus. I can see the tubal ostia, but I cannot see this tube. This tube might be stuck somewhere in the bowel. I can't see. How can I see with a hysteroscope? I can't see the tube. Yeah, I can put in dye. I take out the hysteroscope and put in a HSG cannula and put in dye. It will show me that the tube is open or closed. But will it tell me that the tube is stuck in adhesions? Will it tell me that actually the woman is having miliary tuberculosis and there are adhesions? Will it tell me that there is endometriosis of the ovary? यार नहीं है हिस्टोस्कोपी बेस्ट, लैप्रोस्कोपी एंड हिस्टोस्कोपी बेस्ट है. आज लगता है पार्थसारथी तो हिस्टोस्कोपी करके छोड़ेगा. Never mind, you can ask me more questions, no problem. Hysteroscopy is also invasive, ठीक है. चलो. A primary at term presented with labor pain. On examination, multiple painful vesical lesions were found on her vulva. No rashes were found other parts of the body. This is herpes. What will be the management of this case? Now, when there are lesions which are actively present in the genitalia, then there's a chance of transmission to the baby. But if they're at the other parts of the body, then there's no problem. So, when there are active vesicular lesions and they are burst lesions, there is a theoretical chance that it may be transmitted to the baby. So, that is why we say active lesions or prodromal symptoms are present. Active genital lesions and prodromal symptoms are present. Genital herpes lesions are there. Prodromal symptoms like vulval burning, pain and tingling when labor begins. Then the cesarean delivery is best. Okay, because it significantly minimizes the baby's direct exposure to the viral shedding in the birth canal. So, yes, I will give a cesarean section. Where is the cesarean? This one. Of course, I'll also give acyclovir because I don't want the patient to fall sick and the baby, of course, when the baby is born, I don't want the baby to have the transmission of this virus and cause the baby to have pneumonia. So, I will give this patient acyclovir, IV acyclovir, the mother 10 to 15 milligrams per kg every 8 hours with hospitalization. Of course, if there are non-genital lesions, now that question has not come. If the lesions are not in the genitalia, suppose they are on the back or they are on the abdomen, non-genital lesions, then like the back or the thigh, we can cover them with occlusive dressing and there we can do vaginal delivery. All right. So, one more thing. ये तो हो गया क्वेश्चन के बारे में. I'll do a cesarean. There is a question that if a woman has chicken pox, woman has active chicken pox and she's pregnant, do you abort? So, remember the maximum infection is from 13 weeks to 20 weeks. That is the maximum chance. I'm talking about chicken pox now. If a woman has chicken pox, has vesicles and she is pregnant and she is 30 weeks, I'll not do anything. The chance of transmission is very less. Anyway, the organogenesis happened. But here the chance of transmission is very high in this. So, congenital varicella syndrome can happen with this maximum. Congenital varicella syndrome is maximum if it is between 13 to 20 weeks. If a mother has this time, I will do an abortion. So, that's what is of chicken pox which I wanted to tell you. Chalo. And being not very sharp, as you don't ask me a stupid question, Parthasarthi. Not at all. Why are you thinking like that? Arey yaar, kya baat kar di yaar? If you ask me this question, that means you've been following a lot in your internship, more than a lot of interns which I know. Please don't take it as a, it is just that we do a lot of jugaad here. When you come to me and work in my department of reproductive medicine, you'll see how many jugaads we do. How many times we do jugaads. So that's all right. It's a very good question actually. If you understood so much, that means that you've been following a lot during your posting. So please don't take it to your heart. All right, chalo. Good. Good you asked me these questions. Chalo. A couple presents to the infertility OPD, a couple presents to the infertility OPD, the woman on ultrasound seems to have an intramural fibroid of sizes 7 to 5 centimeters and 5 to 3 centimeters at the right and the left corner ends of the uterus. Husband's semen analysis was found to be normal. What is the appropriate management of this case? Now, this question had some controversial answers, needless controversial answers. I'm not even telling you those answers. I'm just trying to build the answer for you. Right and left. Chalo. On the cornual ends, right cornual end में Okay, cornu. Yeah, this is the cornu. Right cornual end and slightly small on the left cornual end. Smaller. ये right को बड़ा कर देते हैं. Okay. Now, what is the appropriate management of this case? Tubes are blocked because there's a fibroid. She cannot have normal pregnancy. Go ahead and do IVF. That's the answer given by most people. Now, remember one thing. If the tubes are blocked on the HSG, I will always confirm with a laparoscopy. And on a laparoscopy, I see there are fibroids. I will remove the fibroids. Definitely, I'll remove these such big fibroids. Maybe I'll injure the tubes because they're sitting on the cornu. Maybe the tubes will be totally destroyed by my surgery. But I'll have a normal uterus at the end of the surgery. That's what I have to tell you. I'll have an incision which would have healed, incision here. But now there's no fibroid at least. Okay, na? So I have a uterus which is finally healed in 6 months and a perfectly normal uterus. Maybe the tubes are gone. Now I'll do IVF. I have to do myomectomy because if I do IVF with such big fibroids, this pregnancy may not happen in the first place. If she gets pregnant, she's going to abort the baby. With the fibroids, there will be more abortions. So with fibroids more than 5 centimeters, we must manage them. And if I have to do IVF also eventually, I will first do a myomectomy and do a IVF. So definitely not IVF straight away. First myomectomy because it's a significant size. Okay, so that's the answer here. Uterine artery embolization is a good option when the woman has already got children. Infertile people, we don't do uterine artery embolization. Why? Uterine artery embolization will shrink the size definitely. But ये जो endometrium बनता है for pregnancy, that endometrium won't form properly because the blood supply is reduced by uterine artery embolization. I will not do that. ART, IVF, assisted reproductive technique, IVF, I will not do now. First myomectomy. GnRH and LOX can be given to reduce, the size. It buys time. It reduces vascularity also. It reduces size, but it does not reduce size so drastically that the fibroid will get vanished. No, it does not do that. All my life, I've been giving GnRH and LOX before the myomectomy to reduce the size a little bit and reduce the blood supply to the fibroid a little bit so that it does not bleed during my surgery. So that is not the best option here. Myomectomy, yes, definitely myomectomy. What is the order of ligation of blood vessels supplying the uterus during the management of atonic postpartum hemorrhage? Patient has had postpartum hemorrhage. You've tried your drug of choice oxytocin, methylargometrin, carboprost, and bleeding has not stopped. You tried the intrauterine balloon, the Bakri balloon. After that also bleeding has not stopped. You have done the Belin suture. Bleeding has not stopped. Even after Belin suture, if the bleeding has not stopped, you start ligating the blood vessels, and the first is always the uterine artery. Uterine artery has a very good anastomosis with the ovarian artery. That's next. So uterine artery will stop. If it doesn't stop, ovarian artery, and if it doesn't stop, internal iliac artery. Yes, remember internal iliac artery ligation is that hot shot question. The answer to this question is this, but internal iliac artery you should know there is antidivision and the posterior division. Which division do you ligate? So the common iliac artery, internal iliac artery and the external iliac artery is like this. Internal iliac artery has a posterior division and an antidivision. Antidivision has the uterine artery. So that's why when you do internal iliac artery ligation, you ligate only the anterior division. The posterior division is not ligated. Posterior division has superior gluteal, iliolumbar, lateral sacral, short gills, short gills. Short gills. Fishes have gills, na? Short gills. That's my mnemonic. Superior gluteal, iliolumbar, lateral sacral. So INI-CET में easy question आता है ये वाला. All of the following are the branches of the anterior division except. All of the following are posterior division branches except. So if you just remember this mnemonic short gills, you know the 3 branches of the posterior division. By exclusion, you can do the answer. But many times they ask you what is the principle of ligation of the internal iliac artery. Principle of ligation is that you're not ligating the complete internal iliac artery. You're not ligating here. No, you're ligating only the antidivision. And this is a snug ligature. It's a snug ligature to reduce the flow, reduce the pulse pressure actually from an artery. This is an artery from this high pulse pressure, you know, 120/80. So pulse pressure is 100. So that pulse pressure I want to reduce and make it to that of a vein by making this ligature. So the flow in the uterine artery, yes, which is the uterine artery here, the flow to the uterine artery will become sluggish. It causes sluggish flow. Now woman is bleeding too much and you've done the internal artery ligation, and the sluggish flow will promotes thrombosis. It promotes thrombosis in the uterine bed. The uterine bed is bleeding. Yes, this uterine bed is bleeding profusely and the blood flow in the uterine artery is very high pressure, 120/80, pulse pressure is 100. If I put a ligature, it goes down to 30 to 40 is the pulse pressure, 30 to 40 millimeters of mercury. And now the sluggish flow in these vessels will promote thrombosis. When thrombosis happens in these blood vessels, this bleeding will reduce this drastically. So you're promoting thrombosis. Okay? You're not stopping the flow, you're reducing the flow. Chaliye. A woman on treatment for infertility comes with 6 weeks of amenorrhea, abdominal pain and mild vaginal bleeding. Her beta HCG level was 2800. On ultrasound, a 3 centimeter mass was seen in the left head. Next ultrasound hai. It contained a gestation sac with no cardiac activity. Ectopic lag raha hai. What is the most appropriate management for this? She doesn't have a live child. Infertility, 6 weeks of gestation, HCG level is 2000 and mass is 3 centimeters and there's no cardiac activity. So it's an unruptured ectopic because they've not told us anything drastic like she's in shock or she's got tachycardia, low BP and fluid in the pouch of Douglas or abdomen. Ye sab kuch nahi likha hai. It's not a ruptured ectopic pregnancy, it's an unruptured ectopic. Unruptured mein you can save the tube or at least try to save the tube. That is a punchline, because if it's a ruptured ectopic pregnancy, please guys, recently somebody was arguing with me, if it is a ruptured ectopic, this tube has ruptured, it has ruptured. Ruptured ectopic has only one management and that is throw the tube in the dustbin. Total salpingectomy. Total salpingectomy for a ruptured tube. Now when there is a total salpingectomy for a ruptured tube, then we want to save tubes which have not ruptured. So when it is an unruptured tube, what can you do for these parameters? Expected management I will not do because this is high enough. If it is static and reducing, I'll think. So not expectant. Salpingectomy 2800, no. We can do medical. Single dose methotrexate, milking of the tube. Salpingectomy नहीं करेंगे, milking तो कभी भी नहीं करते. So single dose methotrexate or multiple dose methotrexate, because if it is 3000 to 5000, we think in terms of giving multiple doses. Slightly low HCG, we can do single dose methotrexate. If they had just said methotrexate, it would have been enough. So yes, I can do medical management of an unruptured ectopic pregnancy. So the answer is C. So how do you decide? Unruptured ectopic pregnancy, you want to look at my hand here, just like the picture which is given here. Yes, okay, I'll stand here. Okay, this is the uterus, this is the tube, and this knuckle of my finger is like the ectopic bulge. So when the tube is not ruptured, I can make a hole in the tube. I can make a small incision like this, and with this incision, I can open this tube and take the baby out. So when I do that, see this here like this? I can make a small incision in this and take this baby out, and that is what is known as a linear salpingostomy, making a hole in the tube and taking the baby out. Or I can do a methotrexate injection directly into this or intramuscularly to the mother. So I can do medical management or I can do surgical management. So how do you decide? Medical management is methotrexate, or you can give KCL also directly inside. KCL is into sac only. KCL is given only into the sac. That will kill the baby. Methotrexate can be given intravenous to the mother, intramuscular to the mother, or into the sac also. You can give it any of these places. And methotrexate is the only one which we are using most of the time, and that's what is coming in exams. Now, when we do medical management to kill the baby, you are saving the tube. You can also surgically take out the baby, like I told you, linear salpingostomy, and again save the tube. So unruptured ectopic pregnancy, the punchline is save the tube. So now surgical management is linear salpingostomy, like I told you, and that is the best. But you can also do a resection of this and reanastomosis. That is also done. And what is never done is milking of the tube. I don't know why it is even taught anymore. Lot of doctors keep asking in exams. I was an examiner in one of the DNV exams, and I heard another teacher asking the student, tell me the procedure of milking of the tube. And I was looking at the other examiner, and then the student was looking at me, because that student was one of my students earlier on for PG preparations, and I was doing her viva. Of course, I was not biased. I can have students for whom I have to take exams, but that student kept on looking at me, because milking of the tube, I have always taught you, please don't do it, because what happens in milking of the tube, you're destroying the tube. You're milking. See, this is milking of the tube. If you milk the tube and take the baby out, you will save the tube, but you destroy the tube in the process of milking it. So these are all ancient things. The problem is, in all your books, there's something like 10, 12 surgeries given for management of ruptured and unruptured ectopic pregnancies and so many other procedures. So carry home message nahi hota. Carry home message kya hai? Ruptured tube, throw in the dustbin. Total salpingectomy. Unruptured tube, try to save it. How do you save it? Medically, surgically. Now, what is the criteria of that? Criteria of saving medically and surgically. HCG value is 5000 से ज़्यादा, surgical 5000 से less, medical. Size of ectopic pregnancy 4 से ज़्यादा, surgical 4 से कम, medical. Cardiac present, surgical, absent, medical. So if you remember these basics, you'll never have doubts regarding this. So basically, you're able to do this all your questions, and in real life also you get mostly situations like this. Yes, if the HCG is static and falling by itself, then maybe a pregnancy is settling down by itself. Then you can do expected management, and that's what generally not asked, because these are very gray zones of management in practice. So yes, was the answer to this question? We can give methotrexate to do a medical management for this patient, right? So one more thing I just wanted to tell you before I go to the next question. Ectopic pregnancy का थोड़ा सा confusion चल रहा है. Some student asked me, what is the most common site of rupture of the ectopic? I said ampulla, but the student was hell-bent on saying it is isthmus. So I thought I'll just give you some data here. Site of ectopic isthmic is only 10 to 12%. And most common ectopic is actually the ampullary ectopic. तो अगर एक्टोपिक एम्पुला में होता है सबसे कॉमन, तो रप्चर इस्थमस में कैसे होगा? आई डोंट अंडरस्टैंड. सो मोस्ट कॉमन एक्टोपिक इज एम्पुलरी, एंड दैट्स व्हाई इट इज द कॉमनेस्ट रप्चर. Isthmic is narrow part of the tube. Remember, not the narrowest. That is also one mistake. Isthmus is narrower than is ampullary. So it ruptures earlier than the ampullary. So isthmic will be rupturing the earliest, fine, but not the commonest, because ectopic is commonest where? In the ampulla. So ampullary ectopic is the commonest. And interstitial ectopic is only 2% and is the last to rupture because interstitium is here. If you see the interstitium, it's here like this area. If there's ectopic here, so this will grow, this uterus will grow with the ectopic, and that's why this ruptures last 12 to 16 weeks. It will rupture, the last to rupture. Ampullary is the commonest, 6 to 8 weeks, and the isthmic is the earliest, 4 to 6 weeks. So I thought I'll tell you some more information. Right, students, I think I'll give you a short break, a water break. Please go and rehydrate yourself. I'll also go and drink a glass of water and come back. Let's say 10 minutes. It's exactly 15 past 7. So let's meet at 7:30. Is that too much? Let's meet at 7:30 so that we can continue our discussions. There's a lot of gynecology and then a mix of gynae and obs questions coming up. So let's meet exactly in 15 minutes. All right, guys. Hello. Hello. Yeah. Right. Can you please send the link of the Telegram group? I'll tell my team to do all of that. You should get the PDF, and I'm sure that they'll send it across. And sorry for asking this doubt late, but if previously classical is done, so next pregnancy is LS is done or classically? Look, most of the classical cesareans are done. We can use this time to tell you that. When you have a classical cesarean, you've done it in the upper segment because you cannot access the lower segment. That's mostly the reason. If you're doing a classical cesarean, see, LSCS is done here. LS is done. What is that? LSCS is done here. For that, this bladder has to be pushed down. Then only you can do this. So, agar kisi ka, if somebody has a bladder fibrosis, if somebody has, let's say, bladder fibrosis, lower segment tumor, previous vesicovaginal fistula, so previous VVF repair, bladder fibrosis, and lower segment tumors. So anyone has these. Of course, CS cervix is also indication, but CS cervix ke baad, that's another indication. If somebody has CS cervix, we have to do cesarean, classical cesarean, and do a hysterectomy. So uska next pregnancy to hoga hi nahi. She'll not have another pregnancy. So previous VVF repair, bladder fibrosis, and lower segment tumors. Obviously, these are going to stay in the next pregnancy also. So yes, if you do a classical cesarean section, next time definitely she cannot deliver vaginally. You have to do a cesarean section, which will mostly be a classical cesarean section only. Yes, if you really want to do a lower segment, there is bladder fibrosis, there will be a fibroid, it will persist. हाँ, अगर आपने fibroid निकाल दिया है, you've taken out the fibroid, she had a classic cesarean because she had a fibroid. Now you do a myomectomy after 2 years, and after 4 years she gets pregnant, and now she doesn't have a lower segment fibroid, so you can do a lower segment. So ऐसा hard and fast rule नहीं है, but mostly when you had a classical, you will end up doing a classical again. That's also a good question. Okay, so let's move on and see the next question. What would be the best method to assess the gestational age in a patient who was on oral contraceptive for the past 6 months and now presenting with 6 weeks of amenorrhea? Last menstrual period. Okay, fine. They didn't tell you the name. Okay, this is just the full form. Okay, sorry. So she's pregnant while on OCPs. Unfortunate. Maybe she was taking some enzyme inducers or she was having some fever. Some antibiotics were taken, and while on OCP, she conceived. So she doesn't actually know that what is the exact gestational age. While on OCPs, it will be difficult. When she conceived, she doesn't know. If she conceived 2 months back or she conceived last month, it will be a little difficult. So yes, the first trimester, we always say the crown rump length is the reliable indicator. Second trimester, we say the biparietal diameter. So yes, answer here is the crown rump length. A is the answer. Now, tell me one thing. What is the single best parameter in the first trimester to correlate with the gestational age? Crown rump length. What is the single best parameter in the second trimester? If you ask one, always remember, composite parameters give the best gestational age. Bible diameter, head circumference, femoral length, humeral length, all together gives the best gestational age. Remember that. But if they ask you single best parameter in the second trimester, the Bible diameter, and in the third trimester, it is not a femoral length. बहुत दिनों पहले ही आंसर हमने आपको पिछले में आई एम टीचिंग फॉर सो मेनी इयर्स एंड आई बीन टेलिंग आई थिंक लास्ट 17-18 years I've been reminding all of you, don't say femoral length. Femoral length is a fairly reliable method, but not the best, because what happens, suppose a woman comes to me at, let's say, third trimester, let's say at 29 weeks, and she's come to me for the first time. Which parameter can tell me the gestational age best? She's a village woman. She doesn't remember her date. She's anyway pregnant for the 5th time. So she's not bothered about her pregnancy. She doesn't know the dates. She's come to me for fever. and I'm doing a fever management. By the way, I want to know how much she's pregnant. Kab hua tha last period? Sir, I don't remember my period date. So I have to do the ultrasound to find out the gestational age of the baby and plan a delivery. Which parameter will be the closest? Suppose she's come roughly in the 3rd trimester, which will be the closest to the exact gestational age? That's the question. Now, what can happen? A woman can have intrauterine growth restriction sometimes. And the first parameter to be affected by the intrauterine growth restriction is the abdominal circumference. If you stop eating, you lose your abdominal fat, you as an adult also. If the baby has IUGR for whatever reason, he is not getting nutrition, and the abdominal fat will reduce and the liver size will reduce. Excuse me, guys. Abdominal fat will reduce, abdominal circumference will reduce because the liver size is reduced. Then the patient's abdominal circumference, next is the femoral length and the humeral length, but the last to be affected are the parameters of the brain. The brain will be affected the last. That's why the parameters of the brain are used as the single best parameters. So brain parameters are like the head circumference and the bipedal diameter. But even better than the bipedal diameter is the head circumference. So please, in the 3rd trimester, I will see head circumference or bipedal diameter. But if they ask you one out of this, I'll say head circumference. All right. So 3rd trimester parameters, head circumference is the best individual standard metric because it is least affected by the head molding than the bipedal diameter. If the head is trying to enter the pelvis, there might be some molding. Anyway, actually molding happens in the 3rd stage, in the labor. So if the patient is around 30, 32 weeks, 34 weeks, it is still good bipedal diameter. But I will say between head circumference and bipedal diameter, I'll go with the head circumference. Femoral length is highly reliable and easily reproducible. It is typically paired with head circumference. So I'm not saying that it is bad, but femoral length can be affected before the head in a growth restriction procedure. So we always say head circumference. Transcerebellar diameter, sooner or later this is going to be. I was talking to my radiologist friends, and all the teachers who've been working with me, most of them I spoke to them, and they're saying now this is the new kid on the block, and sooner or later the community, the radiological community, they are going to say that this is even better than the head circumference. The transcerebellar diameter, highly accurate in the 3rd trimester because the cerebellum is largely unaffected by the fetal growth restriction. All right. So it just justifies what I taught you just now. Next question, you're asking me something. Why don't we try to repair a tube in a ruptured ectopic? Please, ruptured tube, throw in the dustbin. Repair, tube hurt gayi hai. It is totally destroyed muscularis. That tube you cannot ever repair it to. If it is a cut tube, look, you must understand what is the situation. If there is a unruptured ectopic, let's say here, unruptured ectopic, this one I can cut. A surgical cut and reanastomosis, that's what I told you. Unruptured ectopic, we can do that. But if the tube is ruptured like this, people have tried repairs. It's a blasted tube. It is a ragged tear. That torn tube, if you try to repair, you're going to end up in a ectopic next time again because it's a damaged tube. So please, it's better to do. I mean, even if both the tubes rupture, first time she had ectopic on left side, next time she had on the right side, and if both have ruptured, I'll do salpingectomy on both the sides, one by one. How will she get pregnant? I'll do IVF because saving a tube which is ruptured, you'll invariably make her have a 3rd ectopic then. Not at all. Anyway, let's move on and see another question. Google में femoral length दिखा रहा है. Okay, Google नहीं पढ़ना है तौहीद हुसैन. Femoral length क्या होता है ना, Google will take the feed from many guides also which are giving wrong answers. It's okay. मैं हूँ ना तेरे सामने. Don't worry about Google so much. Okay, Google में हमारे parameters, abortion के parameters पूरे गलत दिए हुए हैं Google में because they give you Western parameters. All right. If you really want to do a search, do AI search. Don't do Google search. Okay. AI search will give you the gist of journals. So slightly better than Google search. Okay. Chalo. A newly married woman present with copious vaginal discharge without any itching. So, without itching can be bacterial vaginosis. But her last menstrual period was 13 days ago. What is the cause of a vaginal discharge? But 13 days से हमारा आंसर चेंज हो गया because 13-14 day estrogens are high and there is maximum copious mucus discharge around 13-14 days because of high estrogens. So follicle हमारा बढ़ के ऐसे day 14 पे रेडी होके एक oocyte होता है, उसकी वजह से estrogen सबसे ज्यादा होता है और endometrium has proliferated so much. So on the 14th day the estrogens are around 150 to 200 picograms. After ovulation, the progesterons will increase and they will be high for the next 10 days to 14 days. So this estrogen makes thin cervical mucus. The thin mucus because of the estrogens, is stretchable. It is stretchable. It is known as spin bar kit. Stretchable spin bar kit, and it also has fern tree appearance. The ferning and stretchability is maximum on the 13-14 day. That's why. Why? Because the oocyte is about to ovulate. So if the couple have intercourse at this time, it is the best time to have intercourse if they want to have a pregnancy. So everything is favoring a pregnancy, including a thin cervical mucus. Now that mucus will give a sense of wetness in the woman, and some women on mid-cycle have more discharge than other women. I will go with physiological discharge. It can be bacterial vaginosis, but generally bacterial vaginosis, they'll give you much more information. Clue cell, and they'll give you alkaline pH hai, clue cell hai, and fishy odor hai. Something they'll give you more than that. So clue cell yaad rakhna. Please read that chart. Every revision I've been showing you that chart. I'm just trying to avoid talking too much, but remember clue cells in a case of bacterial vaginosis and VIF test positive, which is known as the AMSEL criteria. Answer to this question is definitely A. I'm just saying in bacterial vaginosis, you must remember the AMSEL criteria, which is having that 5 things: alkaline pH, and their clue cells, and a creamy discharge, and a fishy odor, and then there is a VIF test. These 5 are there for the AMSEL's criteria, and any 3 out of these, 3 or more out of these 5 is the AMSEL's criteria for the diagnosis. So yes, thoda sa और information hota to maybe I could have said bacterial vaginosis, but I don't have enough information to say that. And remember, in a case of bacterial vaginosis, there is no itching. And only woman is treated. अब यहाँ पे आ गया है आपका लेटेस्ट अपडेट. आप लोगों को बहुत लेटेस्ट अपडेट्स पढ़ने का मन है. अब अगर आप पढ़ेंगे जर्नल्स में, journals पढ़ेंगे, lot of journals will come and tell you so many things. Journals are saying it is better to treat the husband also now. Husband wife should be treated, but classical teaching is treat only the woman. Husband doesn't have to treat it because it doesn't have a sexual transmission. Now, till it comes in my books, Shaw's Gynecology, Novak's Gynecology, 17th edition has come out, and if it is written that, we'll change it. Okay, it is just going to be transferred to us in sometimes in the end of August to September, they are saying. If it is something different, so soon before the INI-CET, I'll be telling you that information. If it is in a book, I will tell you. If it is in a journal, I will wait for the community to decide. Chalo, what would be the, you've got some questions, okay, thank you so much. So what is the नूजेंट क्राइटेरिया पूछ रहे हैं, आपकी ह्यूजेस क्राइटेरिया पूछ रहे हैं, नूजेंट क्राइटेरिया पूछ रहे होंगे आप. ह्यूगेस तो मुझे नहीं मालूम यार. यू मेंट टू से न्यूजेंट क्राइटेरिया ना. सो एनीवे, नूजेंट क्राइटेरिया, दैट इज द माइक्रोबायोलॉजी वालों का डोमेन है थोड़ा. It is about the polymorphonucleosides in the smear and the number of rods you see. It is also for the microscopic. It is also for the microscopic diagnosis of bacterial vaginosis. Okay, it is not the Clinical criteria. Clinical criteria is the AMSEL criteria, and I'm sure the microbiology. See, I'm not very good at the the number of the routes you see in per high power field. It is domain of the microbiologist. So whenever you have a microbiology revision, I'm sure they'll help you with that better than I can. Nugent criteria is also Nugent criteria for the management, for the diagnosis, microscopic diagnosis of bacterial vaginosis. That's correct. Channel name. Dr. Prassan Vij is my channel. So if you want to join that channel, you're most welcome. I'm there on PW so much that my private channel is hardly doing anything. But yes, whatever I put on that is also important. Please have a look at it sometimes. Mostly I'm there on the PW forum, and you have enough information with us. And my channel, I just give you some information occasionally. So that also you should see. Please join that. Anyway, now, there's a question which says that bacterial vaginosis is not actually a vaginitis, so most common vaginitis, उसको आप कैसे बोल सकते हैं? देखो यार, ये ना question बहुत ज़्यादा अब repeat हो चुका है, so let me just help you with this, that lot of people say that out of bacterial vaginosis, trichomoniasis and candidiasis. Now, out of these three, which is the most common vaginitis? Please go ahead and say bacterial vaginosis is the most common vaginitis. Now, technically, it is a vaginosis. The bacteria is harboring the vagina and not doing anything. I don't agree with this. Bacterial vaginosis can cause discharge per vaginum. It can cause pelvic inflammatory disease ka relapse. Biggest problem is that it can cause PID in pregnancy, chorioamnionitis. It can cause preterm labor. It can cause intrauterine death of fetus, and it can cause puerperal sepsis. Look at the number of things this can do, and it is not a vaginitis. Matlab, without falling into the definition, it does so many things. Remember, I keep telling you that whenever you treating PID, mostly what you're doing, you're killing chlamydia and you're killing gonorrhea. But you must use metronidazole to kill the bacterial vaginosis. Why? Because if you leave bacterial vaginosis, it is going to create an environment to cause a relapse of PID. So no treatment of PID is complete without metronidazole, because it kills bacterial vaginosis. So this bacterial vaginosis technically is not called a vaginitis, but it is the most common vaginitis, and it can cause all of this. So please go ahead and mark bindas ki most common vaginitis is bacterial vaginosis. Okay, fine. Class ka PDF, Partha sir. I think I'll immediately after the class, once the class finishes, under the chat, I'll send this information to you. My team is going to send it to you immediately, but if there's a problem, I'll make sure that it is sent to you. Or you can write to me. I mean, all my students are there. I'm not supposed to give my phone on a public forum like this, but my phone number is a common knowledge. I'm sure if you put it on the internet, you will get it. So just use my phone number and send it to me. Otherwise, you can send me a request on drprassan@yahoo.com. That is my email, which I'll check. Okay, if it doesn't come. Chalo, what would be the obstetric score of a presently pregnant woman who had previously delivered healthy full-term twins? So, gravida is a state of being pregnant. Currently अगर pregnant है तभी gravida हम बोलेंगे. And para or parity is the act of delivering a baby beyond 28 weeks. 28 weeks ke beyond, that is known as viability. So if a baby is born after 28 weeks, we say it's a viable baby, baby can survive. So we say she has attained a parity, she has delivered a baby. Suppose a woman delivers a baby at 38 weeks. Last time we say para 1. She delivers at 32 weeks, preterm hai, but it is still parity because the baby can survive. So parity. Now, woman has previously delivered healthy full-term twins. She's delivered once, but they were 2 babies. So if they are alive, we'll say live 2. and now she's pregnant again. So she was pregnant once, she delivered 2 babies. Now when she's pregnant for the second time, I will say she's pregnant only for the second time. Obviously, it's not a third pregnancy. Suppose a mother is pregnant now and she delivers triplets. So it'll be still one delivery, and in triplets it'll become para 1 live 3. So in twins we say para 1 live 2. In triplets we say para 1 live 3. And if she had triplets last time and she's pregnant again, it is still a second pregnancy, right? Sometimes, if you see a goat may deliver 4 babies together. So it's not her 4th delivery, it is just the 1st delivery. And if the goat is pregnant again, we say grada 2 para 4. We don't say she's grada 5 now. 1 act of delivery and the number of children you can write. 1 act of delivery is parity attaining once. All right? Sure. So the answer is G2P1 L2. Live they have not written here, so G2P1 B is the best answer here. Right. So identify the maternal condition that can lead to the findings in the baby as shown below. So you can see the limbs are a little deformed, but look at the lower limb. It is a fused lower limb. Mermaid baby, because the blood supply to the lower limb during the pregnancy, there's a vascular steal most of the times, which can make a cyanomelia or a mermaid baby. So this can happen because of vascular problems, vascular steal phenomena. The upper body, there is a one, there are 2 umbilical arteries and 1 vein, and if one artery is too big and giving major supply to the upper part of the body and lower part is not getting the blood supply, so lower part of the body does not develop properly. So that is the most common reason. But since we've got diabetes as a cause, then we'll think of that. Now remember, gestational diabetes, it is after 24 weeks. Guys, this question is more for that information. It never causes anomalies. Those of you think that GDM causes anomalies, please see this properly. GDM happens after 24 weeks. When do you screen for GDM, guys? ये confusion पता नहीं क्यों रहता है. All of you know how do you screen for GDM, gestation diabetes mellitus. After 24 weeks, do the GTT. And the GTT which we do for the screening, all of you know it is done by the 75 grams of glucose, right? So if you do the screening after 24 weeks, because it happens after 24 weeks, GDM, it is because there is increase in human plastral lactogen, which causes insulin destruction, because there is increased insulin resistance, which causes the sugars to be high. So increase in insulin resistance, increase in HPL after 24 weeks cause the patient to have gestation diabetes. But the organogenesis completes in the first trimester. So how will GDM cause anomalies? So it is the pre-gestation diabetes mellitus. A woman is already a diabetic and she is pregnant. In the first trimester, the organogenesis is taking place. The branchial arcs are fusing, the heart is forming, and the head is forming, and the gut is rotating, and the diaphragm is forming in the first trimester. All of that can get affected by the free radical injury because of high sugars, and there can be anomalies. So always pre-gestation diabetes causes anomalies like the one which I'm showing here, the mermaid syndrome. All right. So this vascular steal hypothesis is the most common theory about this, but maternal pre-gestation diabetes is the most strongly linked environmental risk. Up to 22% of infant born with this cyanomelia. All right. Next question, identify the findings seen in this hysterosalpingogram. So when you see this hysterosalpingogram, you're seeing the uterus is looking fairly normal. Maybe I'll want to call it a little irregular, but never mind, it's fairly okay. But look at the tube. I showed you a hysteroscopy. In hysteroscopy, I showed you the uterus was like this and the tube was just a thin thing like this. I showed you a normal hysterosalpingography. In this HSG, the tube is having so much of a collection of fluid, and that is what is fluid in the tube. Tube is salpings, fluid is hydro always. So we say it's a hydrosalpings. And invariably, I mean, I'm not saying always, most of the times hydrosalpings in an Indian subcontinent is equal to tuberculosis. Tobacco pouch hydrosalpings. So you may get these words also, beaded, rigid, calcific endoscopic tube with the tobacco pouch like hydrosalpinx. Tobacco pouch, hydrosalpinx. So, if you see a tobacco pouch hydrosalpinx, that is a big hydrosalpinx classical of tuberculosis. All right, so हम इसको bilateral hydrosalpinx बोल के चलते हैं. Cornal block में you cannot see the tubes, it will be blocked here, you cannot see the tubes at all. That's a simple question, let's move on. A 53-year-old woman presented to the gynae OPD with postcoital bleeding. Guys, very important. And on vaginal examination, there's a lesion on the cervix. The lesion is necrotizing, and on per rectal examination, it was found to be extending to the parametrium till the lateral pelvic wall. Which of the following would be the management in this patient? So, if there's a cancer lesion on the cervix which is extending to the parametrium, okay, let me just change the color so that you understand. The same growth which is extending to the vagina, then to the parametrium. But from the parametrium, it is growing all the way to the pelvic side wall. It is involved the pelvic side wall also. So, can you see from the cervix? From the cervix, there is a growth till all the way, from the cervix all the way till the pelvic side wall. There is no cancer-free area. So, the ureter which comes like this ureter can get compressed in the growth and the patient can have a hydronephrosis. So, this is classically stage 3B. The stage which is most common when women in our country come to us, because they'll be sitting with the growth and they'll be having postcoital bleeding, dirty foul smelling discharge, sab kuch hoga, but they will not come to you. One day the growth goes and starts involving the pelvic side wall, and the pelvic side wall, when it is involved, it causes the pelvic bone is involved. It is a very painful cancer now because it is involving the bone. So, woman comes to you because the pain, and moment she comes to you and we see a growth on the cervix, before we complete the examination, we know it's going to be 3B. That's when they will come to you. Most common stage, and it is with hydrosalpinx. So, yes, when there is 3B, what is the treatment? From stage 1 to 2A1, we say a radical hysterectomy, and after stage 2A2, we say chemoradiation. So, yes, most of you have said answer as chemoradiation, which is perfect. Answer is B for Bombay. Till 2A1, it is the radical hysterectomy. Now, after that, we cannot do a radical hysterectomy because the cancer is much extensive, it's big, very vascular, the surgery may be not adequate, we may not get a very adequate clearance, and the patient may actually bleed a lot. So, that's why we say it's safer to do chemoradiation. And mind you, even in stage 3B, most books will tell you, even in stage 3B, especially in India, a lot of work has been done in CS cervix. Why? Because we have so much of CS cervix. So, CS cervix, because of the Indian data, the staging by FIGO was changed. It is our own doctors from AIIMS. They have given the data of the country, and there was a stage 3C made. The stage 3C, pelvic and paraortic lymph node involvement, this can be checked by ultrasound or by CT or by MRI only. So, that's why CS cervix is staged clinically. All cancers are staged surgically in gynae, but CS cervix is staged clinically. I do a PV, see the growth. I go to the vagina, see the involvement. Then I go into the rectum to see the parametrial involvement, clinical. But after 2018, okay, doctors from AIIMS, they gave the data, and the International Federation of Gynecologists and Obstetricians, they decided that they will include this pelvic lymph node and paraortic lymph node involvement in this. It changed the management also, and stage 3C was introduced. Just like endometrium, there's a stage 3C in CS cervix also, and that requires, along with clinical examination, you do a ultrasound or a MRI to find out this. So, now how do you stage? Black for the cervix, limited to the cervix, microscopic. If it is more than 5 mm size growth, you can see with your eye, it becomes macroscopic. So, stage 1 limited to the cervix, microscopic till 5 mm, 1A1 and 1A2. Now, more than 5 mm but less than 2 cm, B1, 2 to 4 is B2, and more than 4 is B3. So, see, black growth for the black code I have given you here, limited to the cervix. Now, when the cancer goes to the vagina, please be careful. Upper vagina is 2A, lower 1/3 vagina is 3A. No, don't say 2A and 2B. Upper vagina 2A, lower 1/3 vagina is 3A. Then, from the cervix goes to the vagina and then goes to the parametrium, the blue growth, blue code there also. So, when it is going into the vagina, it is just gone to the vagina but not to the pelvic wall. It is 2B, parametrial growth, short of pelvic side wall. It is gone to the vagina and the parametrium, but from the cervix is gone all over to the parametrium and there is no cancer-free area. So, it is involving the pelvic side wall like I showed you earlier. So, that is stage 3B. So, 2A is upper vagina, 3A is lower vagina. 2B is parametrium, 3B is parametrium till the wall, and that's the most common stage. 3B, I told you, hydronephrosis is there, with which women come to the OPD. So, if it is 3B, we give chemo radiation. Now, how do you give the radiation? How do you give the chemotherapy? So, remember, chemotherapy in CA cervix is cisplatin based. Cisplatin is there in almost all the cancers, oncology or cancer chemotherapy in gynecology. Even CA vulva we say, and we see ovary definitely we say cisplatin, carboplatin. Now, what about the radiotherapy? So, this information is going to come a little later also in this discussion. I thought I'll finish it off here. So, if you see the radiation is given to control the cancer. There is the cancer here. So, there is a way to give the radiation. 2 centimeters lateral and 2 centimeters above is the point A, 2 and 2 centimeters, and 3 centimeters lateral, is point B. 3 centimeters laterally is the point B. So, point A is the place where the ureter is crossing the uterine artery. I think I'm not going to draw that. The ureter, okay, I'll do it just like this. This is the uterine artery and the ureter is coming like this. So, that is the point A, ureter crossing the uterine artery. Point B is the lymph nodes, the sentinel lymph nodes like the external iliac. External iliac is the main node now, and the obturator node. Nowadays, we say external iliac is the main sentinel lymph node. All my life, I was told that obturator lymph node are the sentinel, the first group, but now we say external iliac. Either one of them can come in the exam, but if both come, say external iliac. So, point A has to get radiation, point B has to get radiation. Point A has to limit the spread in the immediate vicinity of the uterus, and point B has to prevent the spread to the lymph nodes and treat the spread to the lymph nodes. So, point A, we give maximum radiation, 7,000 to 8,000 rads is given to the point A. Point A is this. Point B, we give somewhat lesser, 6,000 rads. So, that is how you give the radiotherapy to contain. But how do you give the radiotherapy for the primary cancer? We put a rod inside. We put a rod inside the cervix, and this rod has the cesium source. See here, this rod has the cesium source one by one in tandem. So, the tandems are used in rods. Tandem rods are used into the cervix, and then we have these metallic balls here, right? These are known as the ovoids. So, the tandem and the ovoids, these are the instruments by which we contain the disease here. So, this is the way of giving the radiation. Brachytherapy by this, brachytherapy by this, and external teletherapy by this. All right. So, that is a method of giving radiation in a case of CA cervix. Just the outright basics. Chalo, आगे बढ़ते हैं. A 16-year-old girl came to the OPD with a history of primary amenorrhea and cyclical pain. On examination, there was a suprapubic bulge. On per-rectal examination, there was swelling felt anteriorly in the upper part of the vagina. Guys, थोड़ा सा question में change हो गया है. Don't think this is don't think this is a imperforate hymen. So, if you see the woman who is having primary amenorrhea, and you see a imperforate hymen that is at this place, but it is a transverse vaginal septum, it is much higher. So what happens? Both of these conditions, there will be accumulation of blood in the vagina, which is known as hematometra. There will be blood in the vagina also. So uterus may, did I say vagina here by mistake? Okay. So collection of blood in the uterus, collection of blood in the vagina. So what do we call this? We call this a hematometra, and this known as a hematovagina. I'm not writing that now. I want to use this for something. So hematometra and hematovagina. Now, if you do a per rectal examination here, we can feel the bulge in the vagina. I put my finger like this and I can feel a bulge, but only in the upper part of my finger. So that's why it is a transverse vaginal septum in this patient. But suppose this whole vagina was full, suppose this complete vagina was full, I'll use a different color to show you what I mean. Suppose this complete vagina was full with blood here. So then I would have felt the bulge throughout my finger when I did a PR. So I see the complete vagina which is full, then it is more likely a imperforate hymen. So this case is a case where you are having a transverse vaginal septum. All right, these are different. All right, so this is a case of a transverse vaginal septum rather than an imperforate hymen. Anyway, a 28-year-old woman with a history of infertility was on treatment with human menopausal gonadotropin. You know, HMG is basically human menopausal gonadotropin is a mix of injection FSH and injection LH. Both are there together in this. It is for stimulating the ovary. And this is the most common cause of what problem I am seeing. Most common cause of severe ovarian hyperstimulation syndrome. All over, most common cause of ovarian hyperstimulation syndrome is clomiphene citrate, but that is the mild variety. But if somebody asks you the severe ovarian hyperstimulation syndrome, sorry, what did I do? When I say severe OHSS, then I say it is injection of human menopausal gonadotropin here. Now, an ultrasound was done to assess the follicular growth. The most likely diagnosis would be, it will be ovarian hyperstimulation syndrome. Okay, theca lutein cyst, it is not this. Okay, theca lutein cyst is due to, it may look something like this, mind you, but it is due to increased HCG. So something to do with pregnancy should be there. Early pregnancy should be there at least, or a molar pregnancy should be there. Okay, twin pregnancy, molar pregnancy. So theca lutein cyst is high HCG, twin pregnancy and molar pregnancy. Ovarian hyperstimulation syndrome is more likely answer because we are giving a stimulation. In PCOS, you will not see such big follicles. Let's see this video, you'll understand what I'm trying to say. See, look at these follicles. They are around 10 to 15 follicles. All of these are big. You're going to see a very frustrated surgeon just now. Just see this. That's me getting frustrated with this case. Even now, we see a lot of cases of ovarian hyperstimulation syndrome. It's not that we don't see them at all, but yes, we have methods to make sure that the patients do not get very sick. We are able to manage, and touch wood, and God bless my patients, we are able to save all of them because we have seen a lot of OHSS with our practice and we are able to save most of them. So it's, yes, it can become very crazy sometimes, but we can manage. By the way, something else came to my mind. Ovarian hyperstimulation syndrome. What is the main pathology? Pathology is increased estrogen due to increased follicles recruited in IVF. So more than 20 follicles, per follicle is 200 estradiol. So more than 3,500 picograms of estradiol. That will increase the vascular endothelial growth factor. And the HCG, which I give for the final maturity of the eggs, that will also promote the VEGF, and that increases vascular permeability. that increases the vascular permeability, and because of that, fluids will move out of the intravascular compartment and collect in the third space. Pleural effusion, ascites, pericardial effusion, and it can be such severe one, like in HMG, they can be severe or critical ovarian hyperstimulation. We can lose a patient also. All right. So because of this HCG and high estrogen. Now, there was a question once in NEET exam, which one of this is the final nail on the coffin to cause the major problem of ovarian hyperstimulation syndrome? And that is the final nail is the injection HCG. Yes, all of you know it is because of the high VEGF, vascular endothelial growth factor, the permeability increases. Why? Because there is high estrogen, this estradiol. This is also contributory, but the final nail in the coffin is the high HCG. So that high HCG can cause a woman to have OHSS. So this OHSS can happen early. It can happen early OHSS, which is within 3 to 7 days of injection of HCG most of the times. And when she has ovarian hyperstimulation syndrome, then we don't allow her to get pregnant. We save the embryos. We don't put the embryos into a body so that she should not get pregnant. We save the patient. But sometimes we feel कि चलो mild चाहिए है, कोई खास problem नहीं है. It's a mild OHSS and we can transfer the embryos. Now, when the embryos go and get implanted, implantation will increase the HCG and HCG will spoil this. So when we do the implantation, it is generally on the 5th to the 6th day. 5th day we do the blastocyst transfer and she'll implant on the 6th to the 7th day. So after day 12 or 13, after equal to 13th day, due to pregnancy HCG, she gets the late OHSS. This came as a NEET question long back. Suddenly I remembered. So early onset OHSS is first 3 to 7 days and 13 days, some books say 12 days and beyond. It is due to the HCG of the pregnancy that she gets the late onset ovarian hyperstimulation syndrome. And that if a woman in pregnancy is having OHSS, that means the HCG you cannot contain. With the pregnancy, the HCG goes on increasing every day. At least till the 66th day of pregnancy, the HCG, that is 9.5 weeks tak HCG badhne wala hai. And till 9.5 weeks, you're not going home, you're sitting with the patient because she'll be having very bad OHSS. You can lose a patient more with the late onset OHSS than the early onset OHSS. All right, so let's move on and see another question. A 17-year-old girl presented with primary amenorrhea. On examination, she had no pubic hair, no axillary hair, and a well-developed breast. Her height was 155 centimeters, fairly tall for a girl, and there is normal breast, but no pubic hair and axillary hair. देखो यार, जो भी intersex का question आता है, उसमें pubic hair, axillary hair जरूर लिखा होगा. And why are they saying that? Because pubic hair and axillary hair is because of the androgens. The androgens give the pubic hair and axillary hair to all humans. Women have more, so they'll have, men have more androgens, so men have more florid pubic hair and axillary hair compared to women who have lesser androgens. But androgens are the cause of pubic hair. Now, this girl has no pubic hair and axillary hair till 17. That means the androgens are not working, and she's got fully developed breasts because the non-working androgens have gone to the periphery, converted the fat to estrogens, and estrogen give rise to the glandular development of the breast. So this is classical case of androgen insensitivity syndrome. Why? Because you have another information that 4 centimeter size bilateral inguinal masses are seen. So those are the undescended testes in this boy. So this is a boy who's got a 46XY karyotype and is a very pretty female. Yes, it's a very pretty female. But it's a boy. It's actually a boy. Looks like a female, but it's actually a boy. So this looks like a very estrogenized woman who's got a normal feminine proportions, like breast is there. She's got a vulva also because the androgens are not working, so the penis and the scrotum doesn't form. Androgens are not working, there is no descent of the testes. That's why the testes are undescended in the inguinal area or in the abdomen. Classical hai. Ab Turner syndrome mein, they would have told you that there is some breast development, if not best. it will be something like Tanner stage 3 at least, and there will be scant pubic hair. Some pubic hair will be there, and more, there will not be inguinal masses. They will say there are small or streak ovaries. So small or streak ovaries will be there in a case of a Turner syndrome. PCOS to khair you know so well. Now it is known as polyendocrine metabolic ovarian syndrome. Iska to you know it so well. Isme peripheral place follicle hoga, and she'll have delayed cycles, and she'll have more pubic hair and actually hair because of the androgen excess. So that is not PCOS. Now hypergonadotropic hypogonadism, that will not come with undescended gonads which are there in the inguinal canal. They'll give you information that she's not getting periods and the LH and FSH is high. Hypergonadotropic hypogonadism. So this is hypertropic or hypogonadism is ovarian failure. So you will get some different information. Definitely there will be no breast growth when there is a ovarian failure. There will be no estrogen. So breast growth won't be good enough. So straight away androgen insensitivity syndrome. Chaliye. So androgen insensitivity syndrome, some books, you know, we were taught that there are 5 varieties, minute variation. But yes, convenient and more practical way to say that androgen insensitivity syndromes are the 3 types. Mild one or the complete androgen insensitivity syndrome. So mild, minimal androgen insensitivity syndrome, partial androgen insensitivity syndrome, or the complete androgen insensitivity syndrome. So complete androgen insensitivity syndrome is the boy who's got a typical female kind of an appearance and has primary amenorrhea. Now partial androgen insensitivity syndrome has got ambiguous because there is some androgen working but not complete working. So you may not have a properly formed male genitalia, or there could be a mildly variable kind of a male genitalia and atypical genitalia like we say at birth. But mild androgen insensitivity syndrome, that will come with a typical male type of an appearance, but he will be having infertility and will also have, because of less androgen, some gynecomastia. So these are the 3 types, but they'll generally ask you the complete androgen insensitivity syndrome. A woman presents at 9 weeks of gestation and the ultrasound shows dichorionic amniotic twin pregnancy. However, the estimated age of one of the fetus is 4 weeks and 3 days more than the smaller fetus. They're trying to say there is a pregnancy with 2 babies and it is only in the 9 weeks of gestation. Now 9 weeks of gestation, we don't say there is twin to twin transmission syndrome, please. That presents around 20 weeks at least. So this is not twin to twin transmission. Choice may be nahi diya hua. Now, what are you guys asking me? Can it also give us an idea of the Tanner stage of the patient is up to age or not? Yeah, Tanner stage has not been given. Breast is well developed. So, most beautiful female is a male. Yes, Dr. House said that, and Dr. Vij says in every class. One of the prettiest females, prettiest women are actually men, unfortunately. But please, the women are going to kill me for this. So please, only for the benefit of you to understand androgen insensitivity syndrome. Girls, please just ignore what you heard just now. Okay. Turner में दिखेगा pituitary adenoma से दिखेगा. Okay, fine. Can you please explain hypergonadotropic hypogonadism? If the LH-FSH very high and still the woman is not ovulating, that means there is ovarian failure. High LH and FSH trying to stimulate the ovary and making follicular growth. That follicular growth will make estrogen progesterone and suppress the LH and FSH. But LH and FSH is increasing, ovary is not working, so there is no ovarian estrogen progesterone. No estrogen progesterone, no feedback to the brain, so the LH and FSH goes on increasing, hypergonadotropic. The problem is, you should know that the FSH and LH are known as the gonadotropins. If you remember that nomenclature, you will never get confused. Hypergonadotropic means more LH and FSH. Chalo. Partial androgen insensitivity syndrome. Phenotype is atypical genitalia at birth because there is some androgen working, but partly it is not working. So the male genitalia may not be the exact male genitalia which you expect to see. All right. Chaliye. Now let us see this question which we are discussing. We got distracted a little by your discussion here, but never mind, that also has to go on. A woman presents at 9 weeks of gestation and the ultrasound shows a dichorionic amniotic twin pregnancy. So there are 2 gestation sacs. There is one placenta here, dichorionic, another placenta here. There is one baby here, but another baby is much bigger than the smaller baby. So the estimated gestation age of fetus, one fetus, is 4 weeks and 3 days more than the smaller fetus, like this. So there are two placentas. That means it's a dichorionic gestation. So dichorionic twins is because of two oocytes and two sperms. So this two oocytes, two eggs in one cycle, or there can be two eggs of two cycles. So dichorionic twins can be this or this. Now, they can be two eggs ovulating for a woman and both gets fertilized by the sperm of the husband, and that's what is going to make two different babies, but they are conceived together. That is known as the superfecundation. That is known as superfecundation. It is the most common, dizygotic twin. One cycle, two eggs. Now, if there is one egg this month and it ovulates, one embryo is implanted. Next month, in spite of being pregnant, because of some freak in a biology, she ovulates again next month, in spite of being pregnant. Now, with another act of intercourse, another baby is implanted next month. Obviously, it will be 4 weeks or 4.5 weeks or 5 weeks smaller than the previous month's baby. So, that is known as a superfetation. This one is superfetation. So, dichorionic twins, two eggs in one cycle or two eggs of two cycle. Two eggs of two cycle is known as superfetation, and this is more common in animals. So I was not happy with this question in the first place. This is more common in animals. Superfetation is seen in cows and buffaloes and goats and horses. Okay, more common in animals. And in humans, the more common type of dizygote twins are the superfecundation. So the answer to this question is superfetation A. That is done. But what is supposititious child and what is a posthumous child? Posthumous child is that the baby is born after the death of one of the parents. Mostly it's the father. Mother is pregnant, the father dies, and the baby is born posthumously of the father. Posthumous child. Yes, the mother can also be dead sometimes, that the mother arrested and somebody did an urgent cesarean section to save the baby and the mother is dead. So posthumous child is mostly a dead father, but it can be a dead mother also, rarely. But suppose it is child, that is something different. So let me tell you, posthumous child, child born after death of one of the parent, most commonly the father. Posthumous child. But supposititious child is a fraud. Supposititious child is a fraud. Somebody has never got pregnant but wants to show the world that I have got a pregnancy. So they steal a baby, or go to some other city, get a baby through hanky-panky means, and then they come and say, this is my baby. So that is a supposititious child. So please understand, that is a fraud which is happening. So that's something which is not biology, that is a lot of social problem. Chaliye, a grad of 4 para-3 woman comes for routine sonography at 12 weeks of gestation. Generally, we do something called the nuchal translucency and nasal bone scan, isn't it? NTNB scan we do around 12-13 weeks. She has 3 daughters and desires a boy this time, asking for sex determination. Doctor साहब, ये लड़का है कि लड़की है? मेरी 3 लड़कियां हैं, तो लड़की है तो बता दो, मैं इसको मरवा दूंगी, है ना? Please. Even if I say this, and if some of my friends from PNDT are listening, they may come and ask you, Dr. Vij, you are cracking very absurd jokes while you're teaching. I may be actually reprimanded for cracking this joke. So you're not even supposed to talk about this. It is such a strict thing that tell me the sex of the baby. When I do an ultrasound these days of a pregnant lady, I have to fill 2 forms, and each form are filled individually. You cannot put a carbon sheet. Each form is 4 pages, both sides. 4 pages, both sides means 8 pages one form, 8 pages other form. I have to fill that form saying that I have not told the sex to this lady whom I am doing the scan. And the lady has to sign on the form saying that I have not asked the sex to this doctor. And this is every time I do the scan. So IVF वालों में तुम समझ सकते हो, when she gets pregnant, I do a scan. When the heartbeat comes, I want to see it 2-3 times to check if the heartbeat has come. Already so many forms have been filled. And when the baby becomes NTNB worth 12-13 weeks, again form. So every time I do the ultrasound, forget a gynecologist doing a scan. Radiologists have to do that. Hello, forget radiologist and a gynecologist. A cardiologist is doing a scan for a mitral wall prolapse or a mitral stenosis in a pregnant woman. He has to put a board that I'm not checking the sex of the baby. So anybody with an ultrasound machine touching a pregnant lady has to fill a form saying that I have not seen the sex, because we have so much of female feticide. So if so many students come to me, those who know me that I'm a reproductive medicine specialist, they'll come and tell me, sir, my cousin does not have a boy, they have 2 girls. Can you do something? And I will, beta, the things you're asking me, I have to report to the police. Since you're a student and you're doing this probably for the first time, I strictly advise you not to talk about this to anybody. Yes. Even if you ask me, I have to inform the police. If you call me, my phones are obviously tapped because I'm a gynecologist and I may be doing this. The authorities always think any gynecologist is at risk of breaking the law. Yes. So all of us who do ultrasounds, our phones are probably tapped. I'm telling you that. So any one of you who know me, please do not even think of finding out. So that's the question which has come. I thought I'll tell this in more detail. PNDT Act, it is the purview of the forensic people to teach you. But remember how frequently you should get a certificate for the registration of the machine. The machine which is there in my department is registered to be there in this department. If the Department of Pediatrics wants a machine to do a ultrasound and their machine is not working, they cannot take my machine from my room to the pediatric department. They have to take the baby from there to the radiology department and get it done there, but the machine cannot be moved. And if the machine is moved without telling the authorities, you will have a hospital sealed. The authorities have that. So read the PNDT law. NEET is the only exam where they'll ask you these questions. So yes, based on ethical and legal guidelines, which action would you choose? Check routine antenatal and sex for development anomalies. No, I'll check for developmental anomalies but not check the sex. Wrong. Check routine ANC and sex for development anomalies and do reveal the gender. Nonsense. Reveal the gender if it is a girl. Nonsense. Check only routine ANC and do not check the sex of the fetus. Wait a minute. Some of these have to be better choice. So the only possible answer to this is check only routine ANC and do not check the sex of the fetus. Look, if I'm a gynecologist or a radiologist, when I'm doing the ultrasound, I'll anyway know the sex. I immediately know the sex, but do not reveal the sex. The choice has probably not been recalled properly. Do not reveal. I should have read this before I gave this. So I beg your pardon for this. Do not reveal the sex of the fetus to the parents. Yes. Moment to tell them it's a girl and she has 3 girls. Look, let me confess in front of you. I am passionate for having a girl as a daughter. Every father would love to have a daughter. Every mother would love to have a daughter. But the society has gotten so crooked that a daughter is equal to a lot of dowry. I'm so sorry. It is the harsh truth of a country. So there is so much of female feticide. We are very happy that there is a strict law against this gender disclosure. We should not. So forget doing an ultrasound. I am an IVF specialist, and when I am doing IVF, I have to fill all those forms which I told you. Yes, that is also part of the PNDT Act. When I am doing an IVF, you can come to my hospital and see the number of forms I fill, and I must sign them on a daily basis. There are inspection happening, and they'll come and say, Dr. Vij, you've done an IVF? Where is the sign? You've not signed the forms properly, because there are so many forms. And if I'm not signed all the pages, they can actually take me to task. They can ask me a question and give an explanation कि आपने इसका बताया क्यों नहीं? IVF में तो क्या है? IVF में तो embryos ही है ना? We are having only embryos too. But you can genetically test the embryos and tell that the sex is a boy or a girl. So there also you have to say that I have not told. That's how things are. Okay? So please read about the PNDT Act. This is very important. Detail में पढ़ना थोड़ा बहुत, ठीक है? The at least the gist. You can do a AI search. Okay, don't do a Google search. Do an AI search, and you can find out the salient features of the PNDT Act, the practical points you should know. Okay, chalo. Which of the following is the anticoagulant of choice for a pregnant woman at late pregnancy. देखो यार, anticoagulation can be given for deep venous thrombosis if a person has a mitral valve replaced, and valve replacement के बाद the this thromboembolic phenomena and all these things can happen more. So you must give a anticoagulant. So in the early pregnancy, we always give heparin or low molecular weight heparin. Now, apixaban is not given in pregnancy because it is not approved to be the safest. It is associated with anomalies, all right? Even if you know the gender, you can't tell. No, you can't tell. That's why I was feeling abnormalities come to know without knowing sex. See, there's sometimes, see, there is something which there is something about the previous question. If there's a Duchenne muscular atrophy which happens to the boys, and now the parents have come to us ki if it is a boy, maybe they may have a Duchenne's again. So that time you are legally permitted. So you have to get a permission and then disclose that yes, it's a girl, so they will not be Duchenne in this one now. At most they'll be carriers. So please understand that under strict guidelines, they have to be conditions where you can disclose. When there is a disorder which is likely to be life-threatening, not just something like, this is likely to happen to the boy and like prominent hair on the ears, that is not going to cause anything to the boy as a normal life. So something which is life-threatening, if it is going to happen to a boy or to a girl, then you may be allowed by the law to disclose, but not otherwise. Okay. Chalo. So this is a question, remember, which of the following is the anticoagulant choice for a pregnant lady in late pregnancy? So heparin is given in the first trimester because it is safe. It is safe. It will definitely go to the fetus. But this is not as effective as warfarin. So warfarin is given after 12 weeks. We can give warfarin because it's got a better effect. You know that if heparin is given, then that is safe only till, safe in the first trimester, but action wise warfarin is better. So after 12 weeks, first week to 12 weeks, we give generally the low molecular weight heparin, and from 12 weeks onwards till the 36th week, we give the warfarin. Now after that, this question has come in your NEET exam only. After equal to 36 weeks, we change to low molecular weight heparin again. You can give unfractionated heparin also. Why? Because suppose at 37 weeks, she's sitting at home and suddenly goes into labor. If she's in low molecular weight heparin, the action of the injection fades off in 60 to 90 minutes, the half-life. So around 5 times of 60, that is 5-6 hours, the drug is totally washed out. Half-life is 60 minutes, and 5 to 6 hours, it's totally washed out. And if she goes into labor, she'll not bleed. But if she was on warfarin, the half-life is up to, sometimes this is 60 hours. That is 5 days into 5, it will be there in the body for a long time, 10-15 days. So if she goes into labor with warfarin, she can bleed. That's why we say it's better to change to low molecular weight heparin at term. All right. Anyway, you should also know the antidote. You know the antidote of heparin is protamine sulfate, and of warfarin is vitamin K. Okay, what are you guys asking me? Okay, fine. Yeah. This is the half-life which I want to tell you. Heparin half-life 60 to 90 minutes. So generally, rough rule. I'm not the best pharmacologist to tell you that. So rough rule is that 5 half-lives it takes to totally wash out. To 60 into 5 is roughly 5 hours, and 60 into 5 hours, God, that becomes almost 20 odd days, 25 days. Okay, a pregnant woman presents with a history suggestive of hyperthyroidism at 7 weeks of gestation. What is the drug of choice for hyperthyroidism in pregnancy? Hypothyroidism, of course, eltroxin is safe in the first trimester. The only 2 drugs we can give in the first trimester, eltroxin and folic acid. Otherwise, we don't even give anemia treatment for mild anemia in first trimester. But this is hyperthyroidism. You can think in terms of 2 drugs. One is propylthiouracil and one is the methimazole or the carbimazole. Methimazole. Now, this cannot be given in the first trimester. Only propylthiouracil can be given in the first trimester because it is safe. So, drug of choice in the first trimester is propylthiouracil, and carbimazole or methimazole. One of them can be given after 12 weeks because the organogenesis completes after that. You can give. If you give these in the first trimester, carbimazole or methimazole, they are going to cause the patient to have corneal atresia, aplasia, cutis, and defects, anomalies. So many things can go up. So that's why we don't give them. Propranolol is for the thyroid crisis. Of course, you guys know better than me regarding that. So yes, methimazole. What are the toxicity? Aplasia, cutis, and skin defects, mostly on the head, corneal atresia, esophageal atresia, abdominal wall defects, congenital heart defects, the major problems. Now, you must understand that carbimazole is actually completely converted to methimazole in the body. So, the profile of carbimazole and methimazole is the same. The same congenital defects is seen. Carbimazole, in fact, becomes methimazole in the body. So, both of these you will not give. By the way, there was one question which came. First trimester drug of choice, propyl thiouracil. After first trimester delivery, what do you give? Methimazole. But if they ask you throughout pregnancy, what is the drug of choice? If they ask you this question, that throughout pregnancy, what drug of choice you can give for hyperthyroidism, then obviously you can give only propyl thiouracil, because propyl thiouracil can be given in the second trimester, but it can be given in the first trimester also. So that's the only logic behind this answer. You may say, nahi sir, effective to nahi hota. Arey bhai, safe to hai na? So if I have to give one drug throughout pregnancy, if they ask you throughout pregnancy drug of choice, then you have to go with propyl thiouracil. Mind you, this is also not totally safe. It has got unacceptable incidence of hepatotoxicity to the mother. So we are not saying that this is totally safe, but it is much safer than methimazole and carbimazole. All right. Warfarin embryopathy. Oh God, warfarin embryopathy. Yes, stipple epiphysis and nasal defects, and there are so many things about warfarin embryopathy you must read. All right. Chalo. What is the typical time between fertilization and earliest implantation in human reproduction? Now, this is a very important question because a lot of you say 7 to 9 days after fertilization. This is not wrong, but earliest pucha hai, earliest implantation. So, the embryo reaches the uterine cavity after fertilization. Of course, it happens on the day of ovulation. So if they ask you fertilization or from ovulation, don't get confused. Life of the oocyte, 24 hours. So actually we say 24 hours to 48 hours, but mostly it is, if you have to pick one, 24 hours. From day of fertilization पूछ लें, day of ovulation पूछ लें, it means the same. So now the embryo is formed on the day of fertilization, and the embryo reaches the uterine cavity on day 3 or day 4. It reaches on day 3 or day 4. Day 3 is a 8-cell embryo. Day 4 is a 16 to 32 cell embryo, which is known as a morula. All right, and 8-cell on day 3. And it implants. Now, that's the question which they have asked. Implants earliest on the 6th day. Can happen till the 10th day. But अगर earliest पूछ रहे हैं, okay, earliest is the 6th day. Now, why am I so vehemently telling you this information? थोड़ा सा जोर ज़्यादा ही लगा के बता रहा हूँ. Because if it is happening on the 6th day, then you can prevent a pregnancy till 5th day of unprotected intercourse. That's the logic why we say that IUCDs can be used up to 5 days of unprotected intercourse. Why? 6th day implantation हो जाता है. So yes, emergency conception is 3 days by definition, and drug of choice is levonorgestrel. But IUCD can be used up to 5 days. Why only up to 5 days? Why not 6 days? Because 6 day implantation हो जाता है. So, what is definition of emergency contraception? 3 days. Can be pushed up to 5 days because of IUCDs. Why not 6 days? Because implantation earliest happens on the 6th day after fertilization. All right. So, let's move on. A 27-year-old pregnant woman has just delivered a healthy baby via normal delivery. What is the earliest time at which an intrauterine contraceptive device can be inserted? She is just delivered, and when can you give a PP-IUCD? I think we already discussed this earlier in the discussion. Earliest you can do within 10 minutes, can do up to 48 hours, and after 48 hours to 6 weeks, you should not do this. You should not insert. Why? Because it causes infections. Okay. And then after 6 weeks, when the uterus is normal, you can again have the insertion of IUCD. So when a woman has delivered, mostly we put the IUCDs after 6 weeks. But now we have something called the PP-IUCD. So what is this discussion? Is about the post-placental. This is about the post-placental IUCD, and that is why we have now some control on the unwanted pregnancies. देखो यार, हमारी uneducated women जो हैं, जो village women हैं, they are going to just listen to us during when they are delivering. देखो, you have already got one child, okay, you must have spacing, you must take contraception. Come to me after 6 weeks and I'll put an IUCD, okay, or come to me after 6 months, I'll give you COCPs. Huh, doctor sir, we will come. And next I see this woman only when she's delivering on the delivery table after 2 years. So what we have hit upon now, that moment I take out the plasma by control cord traction and the plasma is in my hand, I put IUCD inside in that big uterus itself. Sir, if you put the IUCD in a big uterus like this, such a big uterus, she's just delivered, the plasma is out. If you put a small IUCD like this and a big thread like this, then sir, आपको नहीं लगता कि this will, with the contracting uterus, don't you think this will be expelled? Yes, I think it will be expelled, but only in 12% time. That's why this question has come in your NEET exam. The expulsion rate of a PP-IUCD, the expulsion rate is only 12%. Matlab 88% women will be retained. So at least almost 90% women who have delivered, we put an IUCD and they don't get conception till they come back to us and we remove the IUCD. So yes, this is something better than nothing. It's a great idea we've hit upon, provided all women deliver in the hospitals where we can put PP-IUCD. All right. Yeah, Pusha, earliest when we can do. But she's just delivered, you take out the placenta and within 1 minute you can put. Generally, we say within 10 minutes is earliest you can do. You can do up to 48 hours. In a standard mediolateral episiotomy repair, what is the correct order of suturing? Now, this is for the interns. All of you assisted and done this. So, episiotomy is sutured from inside outwards. So, first is the vaginal mucosa, then is the muscle, and then is the skin. So, answer is A. Vaginal mucosa is continuous and muscle is interrupted and skin is also interrupted. Okay, so both are interrupted and we use absorbable sutures. You can imagine if the woman has to come for suture removal in the vagina, it will be so painful. So that's why we say absorbable sutures, and mostly earlier we used to use catgut. Nowadays most of us get Vicryl, that is polyglactin we use for the suturing. Fairly simple question. What is not cut in an episiotomy? So when you're doing a cut, when you're doing an episiotomy, the most common is the mediolateral episiotomy at 60 degrees. First of all, don't say 45 degrees. And you will cut what all tissues? You will cut the skin, subcutaneous tissue. You will also cut the bulbospongiosis and levator ani. So bulbospongiosis gets cut, levator ani gets cut, and the transverse perineal muscles, perineal muscles, they will also get cut. But what is not cut? This question came. Ischiocavernosus. Ischiocavernosus somewhere here to the clitoris it goes, somewhere here, the muscle is here. You have to be a butcher when you're doing this cut and you go and cut this ischiocavernosus, then you have to be a butcher to do that. So ischiocavernosus cannot be cut. These questions also have come in your exam. Right, guys? Chalo. A 26-year-old woman presents with amenorrhea, breast enlargement, linear nigra, bluish discussion of vagina and vaginal mucosa. So, vaginal mucosa bluish discussion is Chadwick sign, but please remember Chadwick is classically for the cervix. You can say also for the vagina, obviously. If the cervix is having a bluish discoloration, the vagina won't be, red or crimson or violet, okay? The vagina will also be blue. So, bluish discoloration of the cervix or of the vagina is Chadwick sign. Please, none of the exams they'll ask you. I was discussing this in a forum 1 year back, and exactly 3 days later this came in the exam. Chadwick sign is only for the cervix, if they want to choose one, but the vagina also will be blue. Chaliye. According to the pregnancy signs classification, these findings are considered to be what? These are the confirmatory sign of pregnancy, probable signs of pregnancy, presumptive sign of pregnancy, or diagnostic signs of pregnancy. So now this has become a standard question. It came in 2 exams last year. So remember, the list is here. Chadwick sign, Goodell sign. Chadwick is the bluish discoloration. Goodell's is the soft cervix. Hagar is the soft isthmus. All of these signs are probable signs of pregnancy, but not definitive. Okay. So internal ballotment, external ballotment, positive pregnancy test also, it can be high in some tumors. That's why it is not a definitive sign. So probable sign of pregnancy are these. Presumptive signs are these symptoms of pregnancy. All right, amenorrhea, nausea, frequent urination, quickening, fatigue, linear, quickening. I'm feeling the baby move. Sometimes she's feeling her bowel move and she thinks she's pregnant. So she's presumptively pregnant, but not definitely. And then striae gravidarum, chloasma. All these are skin lesions, can be there without pregnancy also. But the definitive signs, positive signs, ultrasound showing a fetus, fetal heartbeat by Doppler, and fetal movement felt by the examiner. So this probable sign, these are the ones which are generally coming in exams. So remember this list properly of the probable signs. Misoprostol use in the induction of labor is an analog of which of the following types of prostaglandin? Fairly simple question. Misoprostol, remember the dose is where you get confused. It is PGE1, misoprostol, the answer to this question. PGE2 is dinoproston, and PGI2 is prostacyclin. This is what I discussed with you regarding the vasodilators in the blood vessels, and loss of vasodilators can predispose to vasospasm in PH. PGF2 alpha is your favorite carboprost, favorite injection. It is given IM only, never given IV. It is the go-to drug. This line actually came in an exam. Which of the following drugs used for the management of PPH is the last drug before surgical management have to be resorted to? So none of the drugs work, but carboprost will work. Now if carboprost doesn't work, then you have to go for the surgical management of the PPH. So go to drug, matlab bada bhai of the PPH drug, carboprost, IM. Okay, magic drug hai. Now this misoprostol dose you should know. For PPH, we say we give 800 microgram rectally. Some people give even 1000. Now you can give it sublingual also. Now if you give sublingual, look, I'm not even writing it. Sublingual, if you give it, gets absorbed and bypasses the first pass metabolism. But there are 4 tablets and a lot of women will eat it up, and that such high amount of prostaglandin will cause gastric hurrying and they vomit a lot because of that. So we generally give it rectal, okay, preferred route. But for abortions, MTP, it is 800 microgram again, the medical abortion in the first trimester. But in second trimester, I reduce it to 200 to 400 microgram. And for induction of labor, I can use it for induction of labor also. I reduce it to 25 microgram. Now you will be surprised that why is the dose not increasing? Please remember, when the woman has abortion in the first trimester, it is 800, and if I want to induce labor, full term baby, itna bada bachcha, ye chota sa bachcha at let's say 7 weeks, I'm giving 800 microgram. It's a full term 3 kg baby, just 25 microgram. As the pregnancy increases, the prostaglandin receptors keep doubling, they increase. So at term, there are so many prostaglandin receptors that if you give even 25 microgram just in the posterior vagina, not even the cervix, they get absorbed and start contracting the uterus and the woman will deliver. So yes, as the pregnancy increases, the demand of misoprostol reduces for whatever function you are giving. Remember these things, okay? Contraindicated in asthma, yes, carboprost is not given in asthma. Carboprost is also not giving the active management of third stage of labor. So let's get into that discussion now. Carboprost is contraindicated in asthmatics. That is also one question. Also, it is contraindicated for active management of third stage of labor. Active management third stage of labor, you can give oxytocin. The new kid in the block is the carboprost, and the carboprost is given in the dose of 100 micrograms in 1 ml intravenously in 1 minute. So that is there. Carboprost can be given, oxytocin can be given. Me, as a gynecologist, Dr. Vij, has always given a drug called methylergometrin. I was taught in JIPMER that drug of choice for management of PPH is methylergometrin. If it doesn't work, repeat methylergometrin. If it still doesn't work, again repeat methylergometrin. And that's why I got into gynae in 1996, and it's almost 30 years and more. God bless. I've always banked on methylergometrin. I can't teach you that because drug of choice has to be given as oxytocin by WHO. So you have to answer that in the exams. But those of you who are going to become obstetrician and gynecologists, please bank on methylergometrin and not on oxytocin. It works. But it's a good practical advice from your senior that if you're managing PPH or preventing PPH, bank more on methylergometrin. This is given slow IV, okay? It can cause a lot of vomiting if you just push it. Slow IV, or you can give it IM also. Then you can give this for the active management of third stage of labor, this oxytocin, methylergometrin, but not carboprost. It is contraindicated for active management. Now, what about this active management of third stage of labor? Please remember, the controversy still stays, but I will not allow you to get into that. The controversy is not of any meaning when you are discussing with me. The drug you have to give is oxytocin at the delivery of the anterior shoulder of the fetus. Why? Because by the time the delivery completes, the oxytocin will reach its peak action. So 10 units, you can give 5 also intramuscularly, you can give IV also. But classically, all of us give it IM. So by the time the posterior shoulder comes out and the baby comes out, and then you do delayed cord clamping, and then after some time you do the control cord traction, and you will wait around 5-6 minutes for the placenta to finish, and then only do the control cord traction. By the time the placenta comes out, the peak action of oxytocin is achieved, and the uterus will contract and prevent PPH. What is the next step? After that, you will do delayed cord clamping. Delayed cord clamping, that is more than 60 seconds you will wait to increase the hemoglobin of the baby by 1 gram, and then you will do controlled cord traction, and then you are going to do something extremely important, and that is what is known as the uterine massage. You have to do uterine massage. Please do not say that you don't do uterine massage. WHO has been saying ever since 2012. Latest कोई update नहीं है. 2012 से हर साल कह रहा है WHO. Don't do uterine massage. And all you interns at least now. If some of you are the FMG students who have not seen Indian setups, then you may get confused. But once you pass, and now those who are doing internship, you have done uterine massage. It is written in all the posters in front of all the government hospitals and district hospitals that Ministry of Health and Family Welfare says that you must do uterine massage. So I'm saying gentle uterine massage is enough. I did not say bimanual compression. A question came in AIMS 2025. I think 2025 July question. I'm not too sure when it came. It came in the INI-CET exam. Which one of the following you should not be doing? You should not do bimanual compression. Bimanual massage or compression should not be done for active management. Yes, if she's having PPH, you should do bimanual massage. One hand in the vagina, one hand in the abdomen, and you should squeeze the uterus. Can do for a management of PPH, but not for prevention. But uterine massage has to be done. Now, there is one important part. Which of this is the least important component of active management of third stage of labor? And that is the control cord traction. It is the least important. Why? Because if you do early cord clamping also, you're not going to increase the PPH, and delayed cord clamping also, you're not going to increase the PPH. This is the least important. So when you see that poster, go to your hospital wherever you're working and see the poster, maybe after the NEET exam. That poster will give you only these three: 10 units oxytocin, delayed cord, sorry, मैंने ही गलती कर दिया. 10 units of oxytocin and control cord traction and uterine massage. Okay, so sorry for the wrong marking. Delayed cord clamping. I was saying the correct thing but marking the wrong thing. Okay, so this is the least important component. I'm so sorry. Right? So if you see a Williams obstetrics, I'm sure all of you have the ebook edition. You can go and read today itself, and it is very clearly given here that they practice early cord clamping. You can do delayed cord clamping also. It doesn't change the PPH incidence, and they say that we do uterine massage. Yes, they have given a warning. There's a caveat word used in Williams that we are saying that we do uterine massage, but there is a caveat that not many people support this. Yes, correct. There is not a unanimity about that. But in our country, there's a unanimity. We unanimously say that we should do uterine massage. So WHO says a lot of things. They have come up with updates just as recent as 1.5 to 2 months back, that you should have PPH management mein you should be having no uterine massage. Again, they have said, because what WHO feels that one person will be employed in just doing uterine massage, and there are countries where there are very less doctors, peripheries, district hospitals, and one person will be employed in just doing the uterine massage. So agar PPH hai to karo, otherwise don't do uterine massage. Okay, so rather than doing uterine massage, we tell the patient that apna haath uterus pe rakho, and if you feel the uterus is loose, call me, I'll take care of your PPH. Otherwise, if it is hard, you just stay fine. Self-assessment of uterine tone. It is said by WHO. I agree. You go and say that. All you interns, kal jao. If you're working still, go and tell your PG, madam, we'll do self-assessment of uterine tone. The patient will do. We'll not do uterine massage. वो तुम्हारा massage कर देगी. Uterine massage करना जरूरी है भाई. Please, somebody will get angry with you. All this discussion is there in a lot of PG forums. But you go practically, uterine massage is done. You see your labor rooms. All private hospitals also. All hospitals also, they have this labor protocols very clear. Okay? I was in a World Congress where I was speaking for the management of PPH. The whole day we had a conference, and there also unanimously everybody said, do uterine massage. Okay, so fine, let's move out, and I've given you the time this deserved and not more than that. Okay, what are you guys asking me about this? Partha Sarthi is telling that somebody is going to get very angry. Yeah, methyl ligament is contraindicated heart disease. Yes, that's why it is not the drug of choice. Correct. Heart disease में नहीं दे सकते हैं, hypertension में भी नहीं दे सकते हैं, because it will suddenly cause contraction of the uterus and increase the volume of the patient and cause failure in. That's why it is not the method of choice. So heart disease, hypertension before second twin, I will not give. That's why oxytocin can be given in all those. That's why it's the drug of choice. So I am not contradicting the oxytocin information there. Drug of choice for prevention and treatment of PPH is oxytocin. End of discussion. Between you and me, those who are going to become obstetricians later in life, bank more on methyl-ligotrin for PPH prevention and management. That's a personal advice. I have done a lot of deliveries, and every time I remembered you. Thank you so much. Thank you so much, Aboli. I'm so proud that you remembered that, and I'm sure that you were made to do Wagmare. I think you must be somewhere in Maharashtra where you did, and there are very good doctors in Maharashtra, because it's a place where there is so much of good work happening in obstetrics. So there are a lot of men also who are obstetricians there, I've seen. So I'm sure that you have had a very good upbringing there. Keep working hard. Chalo, a 13-year-old child visits gynecology OPD with a complaint. 13-year-old child visits gynecology OPD with complaints of not attaining menarche with a karyotype of 46XX. On examination, there is clitoromegaly. Which enzyme is most likely to be deficient in the above condition? So 13-year-old girl, clitoromegaly. So penis enlargement in a boy is because of androgens. Clitoromegaly in a girl is because of excess androgens. So where are the androgens coming from? At around puberty. So when there is puberty onset adrenal hyperplasia, late onset adrenal hyperplasia, she can present with that. So what is the cause of that? What is the enzyme deficiency? So the most common cause is the 21 hydroxylase deficiency. This everybody knows. In your sleep you know the answer. So that's why in NEET exam they asked you what is the second most common cause, and that is the 11 hydroxylase deficiency. Okay, third cause is 17 alpha hydroxylase deficiency. So yes, you must remember this. See, I'm moving out of the screen and you please take this picture down. Okay, you must know the breakdown of the cholesterol and formation of the androgens here. See, androstenediol, testosterone, and then estradiol. So this pathway this side, and the other pathway this side is for the cortisone and cortisol. So the steroid formation and the androgen formation. Remember, the cholesterol breakdown because of the desmolase acting in the adrenal glands, adrenal steroidogenesis, which I'm telling you. Okay, yes, that is why you must know that there is all these enzymes. I'm not going the details of this, but I'm sure you know that the major enzyme is 21 hydroxylase, and 21 hydroxylase is the major enzyme before the formation of deoxycortisone, and then 11 beta hydroxylase for the cortisone, and the 18 hydroxylase for the aldosterone. You know, it is going to cause the salt retention and water retention in the, sodium balance it is going to maintain. Now, this 21 hydroxylase is also important to form the deoxycortisol and the cortisol. So, steroid formation will not happen if there is 21 hydroxylase deficiency. If this is not there, steroids won't form. And the steroids won't form, there will not be feedback to the brain, and the brain will increase the ACTH to make the steroids, and more ACTH will make cholesterol come into the chain of events, and this pathway will increase because that pathway is blocked. So, there will be more androgen production. Maybe you have not been able to see this properly. I'll just wait a minute. Let me make sure that you get this properly. It's very important. Yeah. So I hope you can see all these. Okay? Right. Yeah, this is live. 1 GG doc. See, live enough? Keep sending your questions. Most common site of fertilization is, now this I already told you, already one question ectopic. Now I think there will be some mixed questions, guys. So most common site of fertilization is the ampulla. So most common site of ectopic is also ampulla, which we already discussed, and rupture is also the ampulla. Okay. Isthmus is the narrow part, not the narrowest. Intramural part is the narrowest. So we've already discussed this part. So let's move on. So that is the picture, and intramural part is the narrowest. Isthmus is narrow, but the narrowest is the intramural part. All right, chalo. Interpret this partogram. All right, now that's an interesting question. If you see, this is the WHO partogram, right? The labor care guide has not come as a question so far. Only recently it came in the UPSC that what is the active stage of labor by the labor care guide. Then I told you it is 5 centimeters. Otherwise, it is the 4 centimeters thing. Now, this according to the labor care guide, we have given you a picture because it came in UPSC, and there is this, lines here. Now, if you see, cervix is by X. So, the cervical dilatation is progressing like this, going up. The descent is by the alphabet O. They'll ask you only these questions sometimes. How do you depict the cervical dilatation? By the alphabet X, and the descent of the head by the alphabet O. Now, if you see, the contractions per 10 minutes are 4 contractions. Can you see? 4 contractions. Then adequate contraction 3 to 5 hona chahiye. The cervix dilated from 5 centimeters to 6 to 8 and to 10. Cervical dilatations happen to expectation. From -1, it came down to 0, +1 and +2. Now, +2, I told you, is the time when I know that this delivery is likely to happen. But after +2, it is not coming below. It is staying at +2, staying at +2. So this is obviously that it has come till the mid pelvis. The outlet is contracted. So if it is having good contraction and it is not coming down, it is probably outlet contraction. Is it rupture uterus? If it is rupture uterus, the mother should be in shock. Look at the blood pressure. Blood pressure is actually high. It is 160 by 110. She's probably a hypertensive patient. She's not at all in shock. And the pulse rate is around 90. She's not in shock. So this is not rupture uterus. Is the baby dead? Rupture uterus, baby should be dead or at least in distress. So the line is 100 and 180. So the heart rate is 100, 110. There is no distress also. So baby is fine, mother is fine, contractions are good, but the baby is not going beyond +2. So that is obviously a cephalopelvic disproportion. If it was maternal exhaustion, she should have tachycardia. It is not there. If there is maternal exhaustion, there should be proteinuria. Sorry, ketonuria. Acetone is not shown here. There is no ketonuria. Exhaustion means not eating and not taking calories, not taking anything, and not given IV fluid. And if she's exhausted, ketones will come. That is also not there. So there is no exhaustion. So that is wrong. Inadequate uterine contraction, there is adequate. See, 4 contraction, and I see it is okay. Rupture uterus now. CPD. So I've given a slightly, blown up diagram here for you to understand. Is the same question. For a woman with 11-week period of gestation who seeks medical termination of pregnancy, the appropriate choice would be 11 weeks पे abortion कैसे करते हैं? So please don't say medical abortion now, because medical abortion, which is with the mifepristone plus the misoprostol, can be done till 7 weeks or 9 weeks. 7 weeks पे it is 99% successful, 9 weeks पे it is 95% successful. So we are not doing that. Okay, because it is 11 weeks. So 11 weeks we can do a DNC or suction evacuation using the Carmen cannula. Carmen cannula, using the 10 size Carmen cannula or the 12 size if it doesn't work. Carmen cannula, where the suction can be made either by the machine, electrical machine can make it, or the manual vacuum aspirator syringe, and that syringe is 60 ml syringe and the pressure is 610 to 660 millimeters of mercury. Okay, negative pressure obviously. So manual vacuum aspiration syringe 60 ml ki hoti hai, 30 ml ki nahi hoti hai. That was one of the questions which came in the exam. So suction evacuation I would like to do. So that's the answer here. Oxytocin and all later if you want to use for abortion. Prostaglandin, second trimester. After 12 weeks, drug of choice for abortion are the prostaglandins. After 12 weeks, that is the second trimester abortions. Okay, some more questions on abortions will come. Parthasarthi, thank you. So let's move on. Identify the maneuver shown in the image. Now, this is the favorite maneuver of the people like me who like to do breech vagina delivery. After coming head, sometimes people don't understand this term. After coming head, the baby has come, the head is inside. So when you do the delivery of the head, it is known as the after coming head. So what all you can do for the after coming head? You can put forceps blades. See, the head is like this. You can put Piper's forceps. You can go inside, put forceps and take out. So after coming head का safest procedure है the Piper's forceps. Piper's. Okay. Or you can put 2 fingers. The baby's head is inside. You can put 2 fingers on the malar prominence and do a malar flexion, and 2 fingers on the shoulder of the baby. Malar flexion, shoulder traction. Malar flexion, shoulder traction. But yes, you may injure the eyes of the baby, so you can do jaw flexion and shoulder traction. So that is the Morshio-Smellie-Vieth. Morshio-Smellie-Vieth. Basically, malar flexion plus shoulder traction. So these are the two maneuvers, Piper's and Mauritius Meliviet, which is malar flexion and shoulder traction. But the one which is depicted here for the aftercoming head, 1 and 2, the one which is depicted here is the Burn-Marshall technique. Burn-Marshall technique, you give a traction to the baby by holding the legs in a 3-finger grip. If they are the two legs, these are the legs hanging, you put one finger in between and 2 fingers on the side and give a traction. So you're holding the leg and give a traction and turn the baby in a large arc of a circle. So while turning this baby in a large arc of a circle, look at my hand, just like this. The hand is my fist is the head, and this arm I'm showing you is the body of the baby. So while pulling the baby out, turn the baby upwards and the head pops out with flexion. So that's what is happening here. The head pops out with flexion, turn the baby in a large arc of a circle. Okay. Now, for extended arms, you do the love set maneuver. Mauritius Meliviet, I told you. Look, yari, none of the above to kabhi choice bhi nahi aayega. I should have seen this, man. None of the above never even comes as a choice in any of your exam. All of the above, none of the above. I seriously apologize for not seeing that choice. I saw the first choice, Burn-Marshall, and should have taken off that. All right. I hope you understand. Those who have written any exam, you would have never got all of the above or none of the above kind of choices. Chalo, aage badhte hain. What could be the reason for a baby to be stuck in the top left image condition, such as case in a college in emergency doctor, they believed a die more than the doctor. Top left image. Top left. Like this. This one you're saying? After coming head, yes? This is what you're saying? If you see a baby like this, after coming head stuck, it is because of a big head, a very large head, macrosomia. The cervix is not dilated enough sometimes. When what dyes do is that they'll keep pulling the baby. They do something called breech extraction. That's why we say do the delivery of the breech only after the umbilicus is delivered, and then you do the assisted breech vaginal delivery. Moment you see the bum of the baby, put your fingers in the groin and pull the baby out. That is breech extraction, and that is what is going to end up like this, because the cervix is not completely dilated sometimes. So the baby, the limbs and the buttock and the chest of the baby will come, the arms will come, but the head will be held by the cervix. Thick lips of cervix will hold the head sometimes. So yes, people do get stuck with this after coming head. So and the JR couldn't manage, so the baby and mother died. Mother also died. Oh, that's horrible, man. The baby is dead. Yes, Parthasarthi, if you've seen that. Baby is dead, hydrocephalus can be the reason. It's all right. The mother should not have died. That is, maybe there was a rupture uterus. I don't know. But yes, more than hydrocephalus, it is mostly a delivery which has been, done very fast. You try to do the breech delivery very fast. You should assist in a breech delivery, rather extract a breech baby. You may end up in problems like this. All right. I've had a baby who had a hydrocephalus, and obviously we could not pull the baby out, and the baby it was an unbooked patient who came with breech. It happened in JIPMER, and the baby died. And we did an ultrasound, because we have all of that. We did an ultrasound. We saw a huge head with fluid. Obviously, the baby wouldn't have made it, but it came with a breech to us. So what we did, we put a needle into the head from below. We could not empty. When we went from the top and emptied the hydrocephalus, and the baby eventually came out. Of course, it was a dead baby. Mother actually survived, obviously. Mother should not have died. Okay, chalo, aage badhte hain. When a woman forgets to take her oral contraceptive pills for 4 days, what would you suggest to her if she presents to you on the, not one, on the 17th day of a COCP schedule. So, if she is missed for 4 days, so 3 or more days if COCPs are missed, then the effect is lost. If 3 or more days is missed, then the effect is lost. So, please remember, if one day, if there is 1 or 2 missed days, 1 or 2 missed days, take 2 today and nothing else has to be done. She is protected. If she misses 1 day, she takes 2 today. She misses for 2 days, she takes 2 today. She doesn't take 3. Now, if she misses more than equal to 3 days, then the effect is lost. So, take 1 today and it is like starting the cycle again. Remember, whenever you start the CCPs, it takes 7 days for the effect to establish. And if she misses 3 days or more, the effect is gone. So, you actually have to start the whole regime again. Basically, it means that. So, if she's missed on the 17th day, she takes 1 pill now and then next 7 days, she takes alternative contraception. But she cannot give a gap. She's on the 17th day. Suppose she takes for 4 days, the 21st day will come and the gap time of 7 days will come. So, what you have to do, discard the previous pack and start a new cycle from here. So, that's what we are saying. Take 1 tablet today and discard the remainder of this pack. Use alternative method for next 7 days and continue into 21 days. Because it is like starting a new schedule. So, D is the best answer here. Yeah, most of you got that. Morsho smelly Viet, Ishita Bishwas, Morsho smelly Viet. The baby's head is inside the, I have half baby, that's why I'm not showing you with that. So, basically the head is inside, you put your fingers on the malar bone and do a flexion. But you have to give a shoulder traction. So, hold the malar bone, do the flexion. Put your fingers on the chest of the baby. Malar flexion, shoulder traction. Let me show that to you on the baby itself. Maybe that will be better. Let's see here. So, this one. Put your fingers, do a flexion and put fingers on the shoulder and traction. So, flex the head and traction on the shoulder. That is what is the malar flexion, shoulder traction or Morsho smelly Viet. All the following affect puberty are mediated by estrogen except this one is easy now because I've already told you that the pubic hair are because of the androgens. So, androgens are from the adrenal glands. So, adrenarche we call it. So, adrenarche. So, first event in girls. In girls, the first event is the breast, pelag. Second event is the pubic hair. Third event is the linear growth spurt, the height, and the fourth event are the periods, menarche. So, once you know this, these are chain of events. Now, please remember specific events in puberty in a girl is breast. Overall, what is the first event of puberty in boys and girls both? What is the first event of puberty if they ask you? Don't get confused. If they ask you in a girl, you say breast. But if they say first event of puberty in boys and girls both, they are not specifying a girl, then don't say breast. Boys don't have breast growth, isn't it? Overall, first event of puberty is physical growth. That has come as a question. Small boys and girls suddenly start becoming taller and broader. That is what is the physical growth. All right, don't do the mistake. What is the ideal agent for distension in a patient who is undergoing hysteroscopic polypectomy using a bipolar cautery? So, when bipolar cautery is used, there's a polyp here. Suppose there's a polyp here like this. The meaning of using a unipolar and bipolar cautery. You will understand this when you understand hysteroscopy a little bit first. Look, when I do hysteroscopy, a scope goes into the uterus. I don't see anything. I can't see anything. Because I have to distend the uterus, then only I can move the scope with a bright light and I can see in the uterus. So, no vision, good vision when I distend. So, distending media distends the uterus, and I can move the scope to see inside the uterus or operate inside the uterus. Now, operation will take longer time than just diagnostic. So, when I put a scope inside, I put some fluid to distend. That fluid will go into the fallopian tubes. So, whatever distending media I am using, see, I am using saline here, and this saline distends the uterus, and I can do my diagnosticoscopy. But this will go into the abdomen also, and it will also fall out a little into the bucket. There will be a bucket below in which this fluid will accumulate. So, suppose I use 2 liters of fluid for doing my diagnosis. 1.5 liter has come here and 500 ml has gone inside. So, it is accounted for. That is 1.5 liter is here. I use 2 liters. So, where is the 500 ml? It has gone into the abdomen. If it has gone into the abdomen, it will get absorbed, and the volume of the woman will increase by 500 ml. That's all right. It's only saline. So, there is something called fluid deficit, which is the reason of this question. Fluid deficit. Fluid deficit. Now, that you have to understand, that if this fluid deficit is more than 1500 ml, I will be warned that you have used 3 liters of saline. 1.5 liter is in the bucket which has drained out of the uterus, but 1.5 liters is missing. That means it's gone into the abdomen, it's getting absorbed, and the patient is going to volume overload. You will wait, watch. If the patient is fine, then only you continue the procedure. If it is more than 2500 ml, you will stop the surgery. If it is saline, so fluid deficit more than 1500 ml you are warned, and more than 2500 ml you are stopped, because 2500 ml has gone into the abdomen, will get absorbed, and the patient whose volume is 6 liters will now become 8500 ml. They may be cardiac overload, pulmonary edema. There will be very serious problem. Now, when you're using something to distend the uterus, it is saline, but sometimes you can use glycine also. When you use glycine, you're warned as early as 500 ml to 750 ml maximum. You're warned, and you stop the surgery at 1500 ml itself, because if there's a fluid deficit of 1500 ml of glycine, glycine is a it is a protein. So, amino acids, when we are using, these will break down and cause hyperammonemia in the patient, and that can cause serious problems. So, when we having all these amino acids used as a distending media, we have to be very careful of the fluid deficit. So, glycine warning 500 ml to 750 and stop at 1500 ml. Saline warning at 1500 and stop at 2500 ml. That is the basis of this, that distension of the media is done. Now, when we have to do surgery, it will take longer. I put a unipolar instrument and I use saline. Moment I push the current pedal to cut this, moment I send current to cut this pedicle, the current will get dissipated through the saline into the body of the uterus. It will go into the body of the woman, go to the quadriplate, and is wasted. The current is wasted. So, when you are using unipolar current, you have to use glycine. Unipolar current, you have to use a non-conducting media. This is non-conducting media, because unipolar current, if you use, the tip has the current, it goes to the saline. So, you cannot cut this pedicle. Moment you press your button, the saline will conduct, ionic solutions will conduct electricity. It will go into the uterus, into the quadriplate of the woman, and the current will be lost. You won't be able to do the surgery. Patient won't get electrocuted, don't think that way. Just the current will go off into the machine. So, when you use unipolar current, you cannot use saline. You have to use glycine, and glycine you have to stop when the loss is 1500 ml. So you cannot operate long when you have glycine and unipolar current. One more basic done. You cannot operate long. So diagnosis के लिए glycine चलेगा, but you have to do a major surgery like a polypectomy or a hysteroscopic myomectomy. You need more time. More time cannot be given by glycine because glycine का fluid deficit अगर 500-700 ml भी होगा तो I have to stop the surgery. Okay, so mostly want and then we stop. If I need more time, I need to use saline. Saline can be used up to 2500 ml of deficit. Saline में you cannot use unipolar. Saline में you can use only bipolar cautery. So when you're using bipolar cautery, you can use it for a longer time because saline is used. When you use bipolar cautery, when you fire the current, suppose there's a polyp like this and this is the pedicle and you want to cut the pedicle. Moment you fire the current, it goes into this and through this itself, it comes back to the second pole. There is one pole like this and there's another pole like this. So the current goes through one, goes through the pedicle and comes back to the instrument. So current is not lost in a bipolar current. So when you're using a bipolar cautery, you can use it for a longer time. When you're using a unipolar cautery, glycine has to be used, you have lesser time. So if I have to do a surgery, I use bipolar current. इतना समझे? थोड़ा difficult है. Rewind करके फिर से play कर लेना. Never mind. What is the ideal agent for distending in a patient, distending the uterus in a patient who is undergoing a hysteroscopic polypectomy with bipolar? With bipolar, you can use saline and you'll get more time. So that's why the answer which I gave you. Okay? Chalo. A 52-year-old woman diagnosed with carcinoma cervix stage 2B was advised radiotherapy. All the following regarding the statement regarding the radiotherapy are true except point B is 3 centimeters lateral to the point A. True except. मतलब wrong statement बताना. This is true. Point A is 2 centimeters above the external os and 5 centimeters lateral. No, wrong. 2 centimeters above and 2 centimeters lateral. Point A receives dose of 7,000 Gray, 7,000 to 8,000 I say. Centigrade same as rads. Okay, you must know the conversion, conversion between units. So rad is same as centigrade. All right. Then or millisieverts also. Point B receives a dose of 6,000. That is also correct. All these three are correct, but this is wrong. So I showed you the point A and point B already earlier in the discussion of CS cervix. Let's move on and see. Identify the use of the instrument given below. Oh, this is not so great. There is a prong here, which is very, oh God, I'll make it a little prominent. Yes. Now you read the question. There's an instrument with a prong. It's a little, I think the image is not so clear. There's an instrument with a prong like this. So these instruments are getting modified every 2-3 years. But if you see an instrument with a prong like this, it's basically that 2 prongs come out, hold the fallopian tube and pull it into a cylinder and we can push in a fallopian ring over it, fallope ring over it. So this instrument is used for a laparoscopic tubal ligation like this. We can make a loop. These prong will pull the tube into a cylinder and then we fire a ring on this. So that is what is known as a fallope ring. So this is used for tubal ligation. This is known as a laparoscopic ring applicator. Laparoscopic ring applicator or a laparocator. Right. Asking. Okay, concepts. Thank you so much. Which of the following is not used as a postcoital contraceptive? Postcoital contraception, I gave you the introduction that it is within 3 days, 72 hours, but with IUCDs, you can push it up to 5 days. So can you use RU486, which is the other name for mifepristone? Yes, mifepristone reduces implantation in a dose of 25 to 50 milligrams. One tablet you give within 3 days, it works. Copper T, yes, up to 5 days you can use. Danazol you can use, it will make the endometrium atrophic. COCP is known as the USP regime and it is given 100 micrograms of ethinyl estradiol and after 12 hours you will give again 100 micrograms of ethinyl estradiol. So when you give ethinyl estradiol 100 micrograms, that is actually 4 tablets now and 4 tablets after 12 hours. If it is 30 microgram, if it is 50 microgram oral contraceptive pill, 2 tablet in the morning, and after 12 hours 2 tablet in the evening. So USP regime is very complicated. High dose tablets are given of ethinyl estradiol. They will cause they will prevent a pregnancy by inhibiting ovulation and also inhibiting implantation. If it is given after ovulation, it will inhibit only the implantation. It is a regime, it is, some books used to say it is the drug of choice. Please, it is not the drug of choice. Drug of choice for emergency conception is levonorgestrel, and it is also not ulipristal, because ulipristal is not given approval by the government of India still. So drug of choice is levonorgestrel. But which of the following, the question is not regarding ulipristal, which of the following cannot be given? Actually all these 4 can be given, but I will not give danazol because it's an androgen. Why won't you give this? It will make the endometrium atrophic, she will not conceive. But if the emergency conception fails and the woman gets pregnant, sometimes women want to continue a pregnancy. Sir, I had taken the tablet, but I actually got pregnant. I'll continue the pregnancy. So all of these methods which I used are safe to continue the pregnancy. But if you give danazol and the pregnancy continues, and the baby is a female child, there will be virilization of a female child intrauterine. So that's because of why, because I cannot give the danazol as the emergency conception drug. It is avoided because failure can virilize a female unborn child. Okay. A 25-year-old woman with a history of vaginal discharge and dysuria came to the OPD. Her husband was a truck driver. Okay. I mean, unfortunate, but if you say truck driver means they are not very sincere, and they keep stopping in many cities, and they have multiple sexual partners. So that kind of thing, it is about a truck driver, you know. They help us a lot, but they are the maligned, their impressions are not very good. Anyway, on examination, her cervix was found to have erosions. Which of the following needs to be used for management by this patient? So this is a question basically by your PSM syndromic approach of reproductive tract infections. But yes, might as well take this one also. So there's a gray kit, green kit, red kit, black kit. So here it is all for you. So remember, this patient with a cervical erosion, this patient deserves the gray kit. But since there is also discharge, ideally speaking, there should be the use of the gray and the green, kit 1 and kit 2, but that option is not there. So this is actually the kit 1, this is the kit 2. Answer is the gray kit. For the cervical erosion, azithromycin and cefixime has to be given. But if at all there was a choice with discharge and erosion both, I would give kit 1 and kit 2 both. All right. Chalo. Anyway, for me, I am very happy with the kit 6. Not for this question. I am saying overall for PID, kit 6, PID treatment. This is what we mostly give in the gynae OPDs also for the syndromic approach. She's got pain abdomen and vaginal discharge. Then we say give the kit 6. Right. That's the gray kit and the green kit. I would give both, but for your question which came, the best answer possible, since there is one choice, kit 1 or the gray kit is given. A 23-year-old woman with multiple sexual partners came to OPD with pain in the external genitalia. The image is shown below. The most likely diagnosis is there is a swelling here. There is a swelling here, which is the swelling near the labia minora and the majora at the hymen, all right, near the hymen. So yes, if you look at this picture like this, at the junction of the anterior 2/3 and the posterior 1/3, at the junction of the anterior 2/3, don't say superior, here, that's the opening of the Bartholin's gland, and that Bartholin's gland has got swollen, and if there's a Bartholin abscess, then we best do a marsupilization. Marsupilization is the best treatment of a Bartholin's abscess. Right. A 23-year-old woman was, are you asking me something? All right, let's move on. A 23-year-old woman was brought by her mother-in-law to the OPD with complaints of being unable to conceive even after 6 months of marriage. The next step of management would be, my next step of management would be that the husband and wife should come. Why should the mother-in-law come? But that's the problem in our country. The woman is brought by her mother-in-law telling, yaar, ye pregnant nahi ho rahi, mera ladka to theek hai. Which is really, really stupid. The couple is infertile. Never say the woman is infertile. Always the couple is infertile, and always husband and wife should be seen in the OPD, and they should be asked about basics first, whether they're able to have a physical relation at the right time of the month. If that is not working, then you start investigating, and the first investigation is always the semen analysis. So since it is only 6 months, the definition of infertility is not yet satisfied. At least 1 year. So what are you answering? C. Reassurance and follow-up after 6 months. Semen analysis of the husband? Not yet. Blood investigation? No. Hysterosalpingography? No. Yes, C is the answer, and most of you got it correct. All right, infertility specialists, everyone, each one of you, not bad guys. Come on, let's move on. The semen parameters now we have to know are the WHO 2021 values. Guys, I have seen some of your books telling you actually that 1.5 ml is normal. Some books are still saying 2 ml is normal. Bhai, ancient ho gaya wo. 2010 ka ancient ho gaya. Usse pehle wala to 2 ml. How many years we have not been teaching you about this? All right. So please remember that the first thing we have to do is to read the 2021 values properly, and that is the first parameter to be assessed in an infertile couple, the semen analysis. 1.4 ml, concentration is 16 million, but why am I giving total count in black? Because it is still same as the old value. Motility has increased to 42%, active motility has reduced to 30% from 32%, vitality has reduced to 54%, but the morphology is still 4%, and pus cells is less than 1 million, still the same value. So three things are still the same, and the single best parameter is your MCQ, and that is the morphology, single best parameter. Please do not say motility as some of you keep saying sometimes. Morphology is the single best parameter. Why morphology? Agar morphologically even one sperm is normal, forget millions and millions. Even if one sperm is normal morphologically and a live sperm, I can use that one sperm and inject it directly into the egg of the woman by intracytoplasmic sperm injection. And even if you got 5-10 sperms, forget in millions, 5-10 sperms, I can give his own biological child to him. All right. So that's why morphology is the single best parameter. Now the pH of semen is alkaline. pH is alkaline, 7.2 to 7.3, because it's a mix of seminal vesicle fluid, and that is 70% of the volume. It is of prostatic fluid, which is 10% of the volume. Seminal vesicle fluid is alkaline, and this is acidic. So that's why the net pH is alkaline. It's very helpful. Nature has made a very smart arrangement that the semen is alkaline, but the vagina is acidic. So if sperms are left in the acidic vagina, the sperms will immediately die. So the first event of fertilization is actually neutralization of the vaginal acidity by the alkaline semen. The semen will neutralize the vaginal acidity, and the sperms will survive the vaginal acidity and swim up into the cervix and reach the site of fertilization. Alright guys, let's see. A 45-year-old woman being treated for cervical cancer came to the OPD with a 14-year-old daughter, and she was worried that the daughter would develop cancer in the future. Nonsense. That does not happen. CS cervix is a lifestyle cancer. All of you know CS cervix because of early sex, sex with multiple partners, partners having sexually transmitted diseases, and in commercial sexual workers. CS cervix is all about sex, and it is all about human papilloma virus. So CS cervix is not a familial cancer. What runs in family? CA breast and CA endometrium and CA ovary. These run in the family. If a woman has CA breast, her sister, her mother, her daughter are having a familial predisposition, first degree female relatives. If she has CA breast, her sister, her mother, her daughter can have CA breast, CA endometrium or CA ovary. The mother had CA breast, the daughter can have CA breast or CA endometrium or CA ovary, but not CA cervix. CA cervix is all about sex. All right. So please remember, if a woman has CA cervix, the daughter is not going to get it. But yes, make sure that all women are getting some protection at least. I'm not saying the vaccine is the best thing, but at least something better than nothing, and especially for young girls, the Strategic Advisory Group of Experts. The Strategic Advisory Group of Experts on Immunization and Vaccination, they say that 9 to 14 years, you should give at least 1 or 2 vaccines. So it prevents against the major serotypes, 16 and 18. Okay, 9 serotypes are there. The major ones are 16 to 18. Something better than nothing. So you can give this vaccine to the girl. Right, most of you got that correct. For which of the following conditions hysteroscopy is being done routinely? Cervical polyp, yes, to remove and see if it has got a stalk inside. Asherman syndrome, yes. Tubal ligation, sterilization, yeah, I mean, I'm so sorry, I should have written a better choice. Sterilization can be done. I'll explain you this. So that is also correct, but definitely not subserous fibroid. Subserous fibroid is on the top of the uterus. So if you see this, there's a subserous fibroid here, and the hysteroscope is somewhere here. So you cannot take out this. You can take out a subserous fibroid by a laparoscope, but not by a hysteroscope. Yes, you can use it for a polyp, Asherman syndrome, and for sterilization. Tubal occlusion would have been a better choice. I'm sorry if you got confused. Tubal occlusion would have been a better choice. Yes, we do it for sterilization, tubal occlusion, by the Assure coil. I'm sure you heard of that. Just that it didn't hit you right now. I'm sure you are exhausted by this long session, but never mind. I've been teaching for a few days in my life, so I'm still slightly more fresh than you guys. So what we do, we put in a coil. We put in a coil like this, Assure coil, like this, into the tube. So when you put this Assure coil into the tube, this Assure coil causes fibrosis of the tube. Assure coil. Now that Assure coil is inserted hysteroscopically. Now this is made up of a, it is made of a metal called nitinol, nickel, titanium. It's an alloy of nickel and titanium. So it causes fibrosis. It causes fibrosis of this tube in 3 months. So it's a very cumbersome thing. That's why it is, you must have, maybe some of you have not even heard of it actually. It came in NEET exam, obviously. That's why I'm teaching you this. This is a NEET exam question paper revision. I've not got questions from anywhere else. These are all NEET questions. So when we have this Assure coil, experimentally they were sent to the government hospitals. It reached my hospital once. We've done this. You know what? First, you have to get her fit for a hysteroscopy under anesthesia. Then you put this coil hysteroscopically, which is an invasive procedure. And after that, you have to wait 3 months for the fibrosis. This area has to get fibrosed over the next 3 months. And you know what you have to do after 3 months? You have to confirm that this has worked. Oh God, what did I do? You have to confirm that this has worked. Do HSG. Do HSG to confirm that there is a block after 3 months. So imagine Indian women, typical Indian women who are not going to listen to the advice of sterilization, and you do the Assure coil and they have to undergo a surgery and after 3 months come for a HSG to know that there is a block. So for these 3 months they have to use an alternative contraception. So that's why. Okay. ट्यूब नहीं दिखता है. इनिशियली डिस्कस दैट द ट्यूब नहीं दिखता. मेरा फ्रेंड पार्था सारथी, यार तू तो मुझसे गुस्सा हो जाएगा राज. ट्यूब का ओपनिंग तो दिखता है मेरे भाई, हिस्टोस्कोपिक. अब देखो मैं हिस्टोस्कोपी दिखाता हूँ. आज ये सेटल करके निकलेगा पार्था सारथी. लेट मी सी व्हाट आई कैन शो यू गाइस. Okay, randomly I'll see. Okay, this is a hysteroscopy. It's got some adhesions, but fine. It's a good thing. See, I'm there inside the uterus. Where are the tubes, my friend? कहाँ दिख रहा है tubes? I'm seeing the cavity. बड़ी मुश्किल से I'm seeing the cavity. See, this is the saline which is distinct the uterus. All right. And now I see go to one side. See, I have to see the ostia. There are some adhesions here. This, see, yeah, that corner. There's an ostia there, I'll see. Now, I'll go to the other side. I'll see the left ostia. That was the right. See, yeah, this ostia you're seeing able to find. You just see the opening of the tube. You're just seeing the opening of the tube. You're not seeing the complete tube. Hysteroscopy, you see only the opening. So, the opening of the tube you see, not the tube at all right, that you can see only by the laparoscopy. So, tubal ostia is seen, my friend, not the tube. So, in this ostia which you just saw, which I just showed, in this ostia you will put the, in this ostia you will go ahead and put the Assure coil. Okay, chalo. I hope that will convince you, my friend. Chalo, let's move on. Right. All the following are the advantage of laparoscopic hysterectomy except. So, when we do, what are you asking me? Okay, I think you understood now. Let's move on. Okay. All of the following are advantages of laparoscopic hysterectomy except. So, when you do laparoscopy, you are not making a big abdominal incision. So, the recovery of the patient is much faster. And when we're doing a laparoscopy, it has got a big distension of the abdomen required so that I can see the abdominal organs easily. So, distension is done by carbon dioxide, and because the carbon dioxide, the pressures will reduce the bleeding. The air pressure actually reduces the bleeding. All right, chalo. So, early recovery, lesser postoperative pain, lesser intraoperative bleeding, and timely identification of electrochemical burn. These are the four advantages, which is not the advantage. So, the answer is timely identification of an electrochemical burn. This is the answer. You cannot. The problem with laparoscopy is that if you're not careful, you may actually burn the bowel without realizing. So, there are a lot of bowel loops here, and you're operating on the uterus here, you're doing a hysterectomy. So, when you put in a scope, see here, you put in a scope into the abdomen, and with the scope you're seeing, and then there are side ports through which you're putting your instruments. Somewhere here, you're putting your instruments. So, with your instruments, you go inside and you're doing, with the side ports, you have a clamp to hold the tube, and with this you have a scissor to cut the tube. Suppose there's a scissor here like this to cut the tube. Now, if you're careful, nothing will happen. But if there's a leak of current, moment you cut the tube, it will bleed. So, you will burn the current so that the tubing, burn the current so that the bleeding doesn't happen. Now, if the current is discharged here and it stops the bleeding, it is fine. But if the instrument is not very well insulated, it may touch the bowel here, it may burn the bowel here. Okay. So, this injury of the bowel, you may not know if the instrument is old or if you're not very careful. You've done the surgery, tubectomy done, hysterectomy done, whatever, cystectomy done, and there was a burn, and after 1 or 2 days, this burnt area sloughs off, bowel perforation happens, she gets into, acute abdomen, paralytic ileus, and she gets very sick, and you get to know only very late. So, it's not a timely recognition. This is delayed information if there is a electrochemical burn. All right. So, yes, whose opinion is not needed? Oh God, I'm sorry. Again, these kind of questions will not come. Opinions needed of all of the following except. ऐसा question आता है. But never mind. I hope you'll understand. Whose opinion is not needed for medical termination of pregnancy after 24 weeks due to fetal anomalies? Gynecologist, radiologist, pediatrician, lawyer. Whose is not required? So, after 24 weeks, if you want to do a medical termination of pregnancy, you have to have a board, and the board should have a gyno, a pediatrician, a radiologist, and a government employed person. a government employed person, generally a civil servant, or a woman who knows about the who's from the mother and child welfare ministry. All right, so one of those nominated people. So you don't need a lawyer to give a consent or the approval. All right, he's not the person. So answer is D for Delhi. Identify the degree of uterine prolapse. So if you see, if the uterus would have just come till the level, so this is the uterus and the vagina is here somewhere like this. So this has come till the level of the vagina. So it has just come down from its place, it is 1. It has come to the level of the vagina, it is 2. If it is inside the outside the vagina, it is 3. And the full uterus is outside, we call it a procedentia. So that's why it's a grade 2, degree 2, second degree prolapse. It has come till the level. In this picture, I'll take it out for you to understand. In this picture, you can see the uterus has come till the level of the vaginal opening. Yeah, so that's why it is a second degree prolapse. A 30-year-old pregnant woman presents with an intrauterine device in place and the thread is clearly visible. The woman wants to keep the pregnancy. What should be done? So if a woman wants to keep a baby, if she's got pregnant with the IUCD, then the thread, if it is seen, it is the best case scenario. Okay, she's pregnant, she's got a gestation sac like this, but there is a, let's say, a copper T here, and the thread is visible. So what do you do first? You hold the thread and pull it out. Okay. Remove the copper T gently. Remove. B is the answer. Now, if thread is seen, you remove and continue the pregnancy. If she desired, the woman wants to keep the baby, continue the pregnancy, but there is still advise, there is a 25% abortion chance even after removing. If not seen, if the thread is not seen, if thread is not seen and woman wants the baby, if the thread is not visible and woman wants the baby, then you can still continue the pregnancy, but 50% abortion chance. You have to explain. So if you can see the thread, pull out the thread, continue the pregnancy with the inherent chance of 25% abortion even after removal. But sometimes the thread is not seen and women say, nahi yaar, the baby is there, it's a gift of the Almighty and it's a child, I don't want to abort. If women think like this, and which is good, I feel, still they can continue the pregnancy, but that will be having an IUCD in situ then, and that is up to 50% chance of abortion. Sometimes this thread is not seen. Yeah, that is the problem. Sometimes this thread is not seen. The thread is probably coiled inside. Thread is probably coiled inside like this. So if you don't see, you can continue the pregnancy, but that will be having almost 50% chance of abortion. So what are you guys asking me? You're just answering. In sacrocolpopexy or sacrocolposuspension, generally for vault prolapse, the surgical mesh is attached to which bony landmark? Right. So you must understand the surgery a little bit. So if I do a hysterectomy, a vaginal hysterectomy, or let's see, even a abdominal hysterectomy, this part is gone out, and now we have the vault here. Sometimes what happens, this vault comes out, this vault hangs out like this. So that is called a vault prolapse. Okay, so we have to push it back inside and put a mesh on it and hitch it somewhere, and we hitch it generally to the sacrum. We hitch it to the sacrum, which is here like this. The sacrum is here behind. This is the sacral promontory. This is the sacral vertebra. So from the sacral promontory, we have the anterior longitudinal ligament also. So you reflect it inside and the mesh is tied to the sacral promontory. Okay, so which bony landmark? The sacral promontory is the place. Okay, so sacral promontory and specifically the anterior longitudinal ligament. Sacral promontory or specifically the anterior longitudinal ligament. Right. Which of the following diagnosis and adnexal mass on ultrasound showing incomplete septation? Which of the following is a diagnosis? Okay. Okay. Showing incomplete septation, a cogwheel appearance, most consistent with you're doing an ultrasound and next to the uterus, you're doing an ultrasound. Sorry, this you may not be able to see, and you have a big mass like this with incomplete septations like this. That's why it is called a incomplete septate, a cogwheel appearance. All right. So that is classical of a hydrosalpinx. Classical of a hydrosalpinx. Follicular cyst will be a clear cyst. It's a very clear cyst. Follicular cyst, one of the easiest thing to understand. Endometriotic cyst will be a ground glass cyst. Hemorrhagic ovarian cyst will have a fishnet appearance. Fishnet appearance for a hemorrhagic cyst. Right? Okay. Ground glass appearance now for you because I told you there, so I kept the question here. A 37-year-old woman presents with chronic pelvic pain and dysmenorrhea. On ultrasound, there is a cystic ovarian mass with a ground glass appearance. So that ground glass appearance is like this. Clear cyst will have some look like this. This is, if this is not a clear cyst, I'm just telling you. You'll have a cystic area with a clear. Clear means there is nothing inside. So the ultrasound waves will just go through. You'll see something like this. That's a clear cyst of the ovary, if at all it is there. Now, this is a ground glass cyst. This is classical of endometriosis. What is peculiar about this ground glass cyst? Ground glass is just like the ground glass, isn't it? You have got these windows through which you can see outside, plain transparent glass, but the ground glass is that door which is there on the offices, you know, that it is you know, this fuzzy glasses, those foggy glasses through which you can see that somebody is moving inside, but you cannot recognize the person. So ground glass. So that is the appearance of this endometriotic cyst. A 32-year-old female, para 2 live 2 with a history of difficult labor and now has second-degree prolapse with cervical lengthening, is considering a surgical option. Given her history, what is the best choice of surgery? So she's a woman who's got 2 children and she's only 32 years and she's got a second-degree prolapse. And she says, yeah, I want to save my uterus. I want to have a child. Now, cervical lengthening is there. So you must understand that you have to push the uterus back inside. So I can show you that with a picture here. Fairly simple. The cervix is elongated and the ligaments, the major ligaments are the Meckenrod ligaments. They are hanging loose with the uterus like this. So obviously you want to push the uterus back inside, isn't it? So when you want to push the uterus back inside, what are you going to do? You want the uterus to stay back in its place. The uterus is pushed back inside. And this uterus, it is so loose. So if you push the uterus back inside, these loose ligaments, you have to detach them. See, if you imagine me like the uterus, and these are ligaments on my sides. So the ligaments are loose and the uterus is hanging out like that. So you push the uterus back inside, these ligaments are loose. You push the uterus back inside and these loose ligaments, you pull them and tie them in front of the uterus so that the uterus cannot go out again. So these ligaments, you will detach them from here and put them, you will detach them from there, the Meckenrod ligaments, and push them in front of the uterus like this. They will support the uterus. So that is what is known as the, please be careful, don't get distracted, Fothergill stitch. Be attentive. This came in your UPSC exam also 2 weeks back. This is the Fothergill stitch. But can you see the cervix is still hanging outside because there was a cervical elongation. So when a woman wants to save her uterus, especially after delivery, there is generally a component of cervical elongation. So you have to cut the cervix also this much. You have to cut the cervix also that much. So yes, this cervix is cut. Now it looks like something like a normal cervix. So cervical amputation is done. So that's how it looks like now. So this is the vagina, and this after amputation looks like that. So cervical amputation. Now you're saving a uterus. When you're saving the uterus, the endometrium has to be tested. If she's having a hyperplasia with atypia, don't you think hyperplasia with atypia of the complex type can have 29% chance of cancer of the endometrium later? So you must always do a DNC to check the endometrium whether it's all right. So before that, you would do a DNC, cervical amputation, and a Fothergill stitch. Plus, the anterior vagina and the posterior vagina has to be repaired. So we say anterior colporrhaphy. Yes, anterior vagina has to be repaired. Plus, posterior colpoperineography. Exactly the steps of the Fothergill repair. 5 steps of Fothergill repair are there, and this was your UPSC question also 2 weeks back. So don't think this is going out of course, okay? So Fothergill surgery, it is also known as the Manchester repair. You know what? There was a doctor, a well-meaning doctor, Dr. Donald. He advised this surgery first, and this was done in the Manchester City Hospital long back. Now this surgery was modified by Dr. Fothergill. So Manchester repair, which was originally done by Dr. Donald, was modified by one Dr. Fothergill, and Fothergill gave his own name to it. Dr. Donald was more gregarious, and he gave Manchester City Hospital name to his surgery. Never mind, that is the history about it, but you must remember Manchester repair or the Fothergill repair is the same. It has these 5 steps. If you really don't want to remember this in detail, which you actually have to, but these two, anterior colporrhaphy and posterior colpoperineography, are parts of something called the pelvic floor repair. All right, so let me see what you guys are writing. You are asking me something? Now let me take a water break. Excuse me. I think we'll finish off the questions rather than taking another long break. I think we're nearing the end. I'm not too sure about it because it just kept on adding questions. Let's see another one. Another one. Hello? Yeah. We are doing an ultrasound. What are the diagnosis of this? This is a pregnancy ultrasound, and what is the diagnosis? So there's a placenta here, you can see, and there's a baby's limbs here. Body is not in this view, but you can see the head here with the eyeballs, and you're seeing something so big is missing. So maybe not the best picture for you guys, but yeah, this is not the best picture, but yes, they're trying to tell you that it's an anencephaly. A better picture will come in the exam. They'll not ask you hydrancephaly, spina bifida, lissencephaly. Unlikely that they'll ask you all of this on the ultrasound, but I think you can remember that anencephaly can come as a picture-based question. What is this grid system used for now? That is what is important. I want you to understand that the pelvic organ prolapse is now done by this grid system. So it is actually known as the pelvic organ prolapse quantification. POPQ classification. So in the vagina, cervix, anterior wall, posterior wall, perineum, vaginal opening, and the vault of the vagina, there are 9 parts, and the description of all these 9 parts is done in the prolapse. So this is the internationally accepted method of categorizing a prolapse, so that what I feel is a, let's say, grade 2 prolapse by my assessment of this POPQ grid. With this grid, I say it is a type 2 prolapse. So somebody is seeing a patient, let's say in Kenya. he is also going to have the same system, and when he says it is grade 2, his grade 2 prolapse will be same like the grade 2 ICF. Why it is important? Because this makes international standardization much easier. You know, sometimes what happens when I say by the old Shaw's classification or the Jeffcoat's classification of prolapse, what I feel is like a grade 1. Somebody will put an instrument and pull the cervix out a little bit forcibly, and he says no, it's actually a grade 2. So without any bias, this has been found to be the best way of categorizing prolapse across the world. That's why this has been accepted as the method. So yes, let's move on and see the POPQ classification. A 25-year-old woman with full-term pregnancy has gone into labor. The flexion point in a ventouse delivery is located at which of the following position in the fetal head? So, if the head is coming out in delivery like this, by let's say the occipito anterior, if the delivery is happening like this, you know the head delivers by extension. Head delivers by extension. But we must maintain the flexion till the head is here and then ultimately do the extension of the head. So, to keep the head down, see, when I am pulling the head down, when I am pulling the head down, I have to give a flexion of the head. I have to give a flexion of the head. When it comes out of the vagina, I have to do a extension. Head delivers ultimately by extension, but I have to maintain the flexion till it comes out of the introitus. So, yes, I have to apply a vacuum, and that vacuum, okay, yes, I have got a good cup here, which is something like a vacuum here. Yes, this vacuum, exactly like this, is the vacuum. The biggest vacuum is 6 centimeters. This is a smaller cup, and you have to apply it on the sagittal suture here. Can you see? It is here. What is here? It is at the sagittal suture at the posterior 1/3 and the anterior 2/3 junction here. This is called the flexion point. With this, you will cause a flexion, pull the head out by extension. So, this is known as a flexion point. It is at the junction of the anterior 2/3 and posterior 1/3. So, that junction, anterior 2/3 and posterior 1/3 on the sagittal suture. That is the description which we use. Now, they have written in centimeters. 3 centimeters posterior to the anterior frontalar, 3 centimeters anterior to the posterior frontalar. I'll go with this as the better answer. Okay, midway between the anterior posterior frontalar is wrong. Okay. Yeah, you got it, B, most of you. What is the likely diagnosis of this woman who has had a history of a cesarean in the first pregnancy and now had a hysterectomy of a cesarean delivery in the second pregnancy? Try and understand. Okay, I'll move out. Try and understand this question. A woman had a previous cesarean section. This time, because of some reason, a cesarean was done, and after cesarean, she ended up in a hysterectomy. So, what has happened to this? Oh God, you guys, are you reading or not, man? What should you read? This is what you should read in the end. Sir, आपने head transplant कराया. Yaar, I've just come out from a bad surgery of my scalp. There's a small cyst which got operated. So I'm totally bald. I don't want to show that, guys. Okay? So don't pull my leg anymore. Concentrate, man. Come on. This is just like the class. Concentrate. Don't get distracted, man. What's wrong with you? Okay, guys. So yes, okay, we'll talk about that later. So what is happening here? After a hysterectomy, look, this patient had a cesarean, and after a cesarean, she had repeat cesarean this time. But repeat cesarean ke baad, we ended up in a hysterectomy because maybe the bleeding was not stopping. So you see the cesarean incision is here somewhere, but the placenta tissue has gone all over inside the tissue of the uterus, the muscle of the uterus. So it looks like an increta to me. So what is this? Placenta increta, accreta, percreta can be there. All those choices are not there. They've just said placenta accreta. Okay. So please remember the answer to this is placenta accreta. You're all correct. But remember, most common cause is not previous cesarean. It is placenta previa. Also previous cesarean section and previous DNCs, all of these previous myomectomies. So many things, but most commonly placenta previa. Look, we may get confused by this line. Placenta previa इतने नहीं होते हैं, but the number of placenta which are there proportionately they will cause more placenta accretas. Yes, cesareans इतने सारे होते हैं कि invariably when you see a placenta accreta, she would have followed a previous LACS. But case wise we're talking. If you had 100 placenta previas, there will be something like 5-6 cases of, or maybe 10 cases sometimes of placenta accreta. But if you have 300-400 cesareans, then you will see around 7, 8 or 10 cases of placenta accreta. That kind of information I was trying to tell you. Okay, chaliye. A 27-year-old pregnant woman diagnosed with impending eclampsia started on the Pritchard regime for the magnesium sulfate administration. Under which of the following conditions should the treatment be stopped? So I told you earlier about magnesium sulfate that when you're giving the maintenance therapy of magnesium sulfate, you must give a monitoring chart to the postgraduate or the intern, and he must see every 4-hourly we should have an output at least of 100 ml, and there should be a knee jerk present, and the respiratory rate should be more than 14 per minute. Okay, anyway, I can write that again. The output should be 100 ml in the last 4 hours, and the knee jerk should be present. Why 100 ml? Because magnesium sulfate is excreted by the kidney. If the kidney is not working, then the magnesium sulfate won't go out. And respiratory rate and knee jerks both are managed by the brain. Knee jerk is a upper motor neuron reflex. So if you give too much of magnesium sulfate, it will suppress the respiratory center and the patient won't breathe, and it will also stop the knee jerks. So we have to see this every 4-hourly, and if this is fine, then we continue the MACSF. Now what is the question here? Which of the following the treatment should be stopped? Respirators less than 18, this is all right. 14 is the cutoff. Some books say 12 also, but 14 is what we take. Visual disturbances, they can be there even before the eclampsia because patient is a case of hypertension. That's not an indication. Knee jerk reflex is present, that is fine. Absent is a problem. Urine output is less than 60 ml in the last 4 hours. That is the answer to this question, because it should be at least 100 ml. Identify the type of uterus shown in the image. Now this is fairly simple. We discussed Mullerian a lot in the early part of the discussion, and this is 2 uterus and 2 vaginas. So didelphys is correct, and you can easily say it is bicollis also. If there was a common vagina with 2 uterus, we would have said unicollis. Okay, so 2 vaginal openings bicollis, 1 vaginal opening with 2 uterus is unicollis. So this is didelphys. It is the safest Mullerian defect. It is the safest Mullerian defect. There is no unicornuate here. Okay, so unicornuate is the most problematic. So there is a basic, I mean, we as specialists in reproductive medicine, we have to do a lot of things which are away from the the knowledge you're giving you here. But remember, most didelphys uterus we don't do anything because they are the least problematic. Yes, they can have, all of these can have preterm labor and malpresentations and abortions, all of them Mullerian defects. But didelphys का सबसे कम होता है, so we let them have a pregnancy, and the pregnancy usually goes till term, and we have a delivery. Now unicornuate uterus is the worst, so we don't operate because we may actually worsen things. So we don't operate by didelphys because there is no problem. We don't operate unicornuate because if we operate, we will increase the problems with unicornuate. So these two. Now the question which has often come in exam, most common Mullerian defect is the septate uterus. It is also associated, I'm not saying always, also associated with infertility. So these are the questions which have come in the Mullerian defects. I told you the best way to diagnose the Mullerian defects is the laparoscopy and the histoscopy. Now when we're talking about the most common Mullerian defect is the septate associated with infertility, and you do a septal resection. Bicornuate uterus, you will repair You will repair by a Strassman metroplasty if recurrent abortions only. Only case of recurrent abortion, you will do a repair of a bicornate uterus. Okay, don't say bicornate is more common, septate is more common. Ever since 2000, gynecologist in 96, 99, I am a SR. I've been doing laparoscopic surgeries regularly since 2002-3. Till 2011, I had done something like 300 septums. After that, I've stopped counting. It's another 15 odd years. So I don't have a count of the septate uterus I've operated in my life. But bicornate uterus I can count on my fingertips because they're not so common. And most of them, they will not have any problems. If at all they have recurrent abortion, then only we operate on them. All right. Chalo. A patient presents with patient presents with a new 2.3 centimeter black nodular mass near a episiotomy scar that is painful and expands during menstruation. What is the most likely cause? Now that is classical of scar endometriosis. Scar endometriosis. Now we are talking about the scar on the scar endometriosis. This is known as scar endometriosis. This can be in the episiotomy and it can be also the abdominal scar. Caesarean scar of the abdomen. Don't say uterine scar. Uterine scar में scar endometriosis नहीं होता. They'll keep growing every month, the abdominal scar or the episiotomy scar, and will be very painful. So what is the treatment of this? Is local excision. Treatment of this is local excision. The scar endometriosis. All right. Identify the degree of tear shown below. This woman had a vaginal delivery and then she has a tear. So the vagina has opened. So it is vaginal mucosa is grade 1. Muscle is open is grade 2. Anus open is grade 3. Grade 3 is anus and grade 4 is rectum. But you can see it has stopped short of the anus. So this is a grade 2 tear. It's a type 2 tear. Okay, so it's a second degree tear. Now the type 3 tear, the anal tear can be 3A when it is less than 50% of the external anal sphincter. Type 3B if it is more than 50% of the external anal sphincter, and type 3C if the internal anal sphincter is torn. So when there is the discussion of the anal sphincter, remember anal sphincter has external anal sphincter which is skeletal, internal anal sphincter is the smooth muscle. Please read about the anatomy, surgery and anatomy people. Gynae में ज़्यादा नहीं पूछते हम लोग, but surgery and anatomy का बहुत favorite question है. Yes, of course, the perineal tears. These perineal tears, when do you repair? Remember, perineal tears, especially type 3 and type 4. These are known as the complete perineal tear and you repair immediately. Immediately you should repair them. You have applied forceps in the labor room and moment you take out the forceps, the anus is torn. You take the patient to the OT under anesthesia, you repair it immediately because this will cause anal incontinence, fecal and flatal incontinence. But if it is neglected, if neglected more than 24 hours, suppose she had delivered in a village and she comes to you after a week of a anal tear or a rectal tear, then allow healing of the cut ends by secondary intention for 3 months to make a good scar tissue and then repair. Now that is what has been erroneously reported as 6 weeks by a lot of you. I don't know why. So we wait for 3 months for the cut ends to get healed and then we repair it if they are neglected more than 24 hours. Otherwise, we will repair it immediately. That's what you should do. If you see in your labor room, of course, senior doctors are always available in a labor room in any major hospital and you repair it immediately. If you don't have a major hospital and you see a tear, take her to a major hospital. Any village in this country is within 1 hour or 2 hours of a district hospital. So this can be taken care of within 24 hours. But if it is a CPT, she'll have fecal and flatal incontinence. So repair it immediately. If you neglect it, why do you have to wait so long? Because the cut ends get colonized. These cut ends, if suppose there's a tear, these cut ends will get colonized with bacteria. See here, these cut ends, ये जो cut है, इसके cut ends में bacteria will enter. So when bacteria enter these cut ends, these cut ends are now infected. And on these cut ends, if you put a suture, that suture will break through this infected area if you put a suture. So before the cut ends get colonized with bacteria, you must do the suturing. Right. C क्यों होना चाहिए मेरे भाई? It is not involving the anus. It is stopped short of the anus. तो C नहीं होगा. No. The picture is of second degree. I'm teaching you about the third degree and fourth degree. That's a different thing. The picture is of the second degree. Then I taught you about the third degree. Don't get confused. A 14-year-old girl presents with a history of primary amenorrhea. On physical examination, an imperforate hymen is observed. What karyotype analysis will you consider for further evaluation? Will you see? I mean, will you find on further evaluation? Oh God. Imperforate hymen is seen. What will you find on further evaluation? Imperforate hymen is almost always seen with a normal female phenotype. Yes, almost always seen. Imperforate hymen is a cannulation defect. It is not a major defect, Mullerian defect. It's a cannulation defect, and you'll see a normal female phenotype. That's a fairly simple question. All right? No. There are not 3 types, there are 4 types of tear. Third and fourth are known as complete penile tear. Okay, I showed you a second degree tear, but I explained you about complete penile tear. Type 3 and type 4 are known as complete penile tears. All right. During ovulation, what is released? An oocyte is released. What type of oocyte is released? So whether it's a primary oocyte, no, primary oocytes are arrested. I'll show you a picture. Primary oocytes are arrested when the girl is born. So primary oocyte is arrested in prophase 1. Okay, they are arrested in the prophase of the first meiotic division. Now, when the girl gets to puberty, she starts ovulating. Now, the meiotic division is resumed and she gets into the second meiosis, and then it is arrested as a secondary oocyte. And that secondary oocyte of the second meiosis is arrested in the metaphase 2. So that metaphase 2 oocyte is arrested at the time of ovulation. So all women who ovulate will ovulate a metaphase 2 oocyte or a secondary oocyte which is in the metaphase 2. Now, this oocyte will be wasted, but if she has sexual intercourse, the sperms will enter the oocyte and now will resume the meiosis again, and then it will complete the cell division. So it is first arrested in primary oocyte, then it is resumed in puberty. At ovulation, it is arrested at metaphase 2, waiting for the sperms to restart the cell division. Okay, so the question is, during ovulation, what is released? Secondary oocyte at the end of meiosis 1, secondary oocyte at the end of meiosis 2. Likely the answer. Primary oocyte wrong, primary oocyte wrong. So answer is B. It's a metaphase 2 oocyte. So metaphase 2 oocytes look something like this. There's a oocyte with the dispersed genetic material, and remember, the oocyte does not have a nucleus. Oocyte does not have a nucleus. How it has a polar body, the first polar body. So first polar body is at or just before ovulation. This question has been coming so many times, and it came in UPSC exam 2 weeks back. So first polar body is released at or just before ovulation. Please don't say 24 hours before ovulation. That is wrong. Just before ovulation is the answer. Now, when the sperm comes inside, this resumes again and the second polar body. So when it is fertilized by a sperm, the second polar body is released. All right. So what we are seeing at ovulation, what is released? It is the secondary oocyte at the end of meiosis 2, the metaphase 2 oocyte. Right. Mullary anomalies we've been discussing ever since we started the class, my friend. We've been discussing ever since we started. Okay. Tubectomy is typically performed at which part of the fallopian tube? Ampulla thickest, ampulla widest, ampulla isthmic junction, isthmic narrowest part. So remember, we want to ligate the tube where it is not narrow or broad. We want to ligate it where it is uniform. So we ligate it at the isthmus, so that later in life, isthmic sterilization, if she requires a reanastomosis for whatever reason, she wants to have more children, then this reanastomosis is easy. This reanastomosis is easy. Anyway, we will not like it at the ampulla. Ampulla is the site of fertilization, so you don't want to destroy the ampulla. So it's not at the isthmo-ampullary junction, it is not at the ampulla, it is at the isthmus, because later we want to do reanastomosis. Reanastomosis at the isthmic site is it's up to, that's the right word, it's up to 80% success. So that's why we do at the isthmus. All right. Okay. A 60-year-old postmenopausal woman presents with blood-stained vaginal discharge and a blood pressure of 170/110. What is the most appropriate next step? Please remember, irregular vaginal bleeding. That question has come so many times. I'm not even answering this question. Okay, fine. Irregular bleeding, 40 to 50 years. Not responding to regular treatment. That is your favorite MCI and NEET and INI-CET question, because that's basic gynae. Irregular bleeding, 40 to 50 years, not responding to treatment. Do endometrial sampling, or they'll say endometrial histopathological examination, and that can be done by a pipel. It can be done by a pipel in OPD. Just a pipe like one instrument is there, go inside and move it a little and you'll get some endometrial tissue in the OPD itself. That's painless procedure in the OPD. Or you can do a DNC in OT, or you can do a hysteroscopic biopsy. Hysteroscopic biopsy, BX I'm writing, in operation theatre. Okay, so please, this is a very, very basic information which comes in so many exams, right? So what are you going to do? You're going to do in this patient also endometrial evaluation for a malignancy. But in addition to that, remember what I told you just now. Okay, a 46-year-old woman presents with abnormal uterine bleeding. TVS shows endometrial thickness of 14 millimeters. What is the next step? So 14 millimeter is a little bit too much in a woman who is menstruating also. So in premenopausal woman, most people say that 9 to 12 is okay, and 14 and more. 9 to 12 is okay, and 14 and more you will do endometrial biopsy, because that goes into hyperplasia. But in postmenopausal woman, more than equal to 5 millimeter, we'll do a biopsy, because less than equal to 4 millimeter is normal. Now this is a much more common M for MCQ. Postmenopausal woman, we'll start investigating at 5 millimeters itself, because 4 and less is normal. In a younger woman, up to 12 is okay. Some people say up to 14 is okay, but 14 and more, you please go ahead and start doing a investigation. All right, guys. A 38-year-old multiparous woman delivered twice previously by an untrained birth attendant. presence with the uterine prolapse, weakness of which ligament is primarily responsible for this condition. So remember, prolapse, we must remember the best support of the uterus is always the levator ani. Levator ani is the best support, which is the pubococcygeus and the iliococcygeus. But the ligaments are also good support, and in the ligaments we have the best ligament as the Mackenrods. The Mackenrods is the best, and then we have the round ligament, and we have the uterosacral ligament, and we have the pubocervical ligament. But the best is the Mackenrod. So please don't get confused. If I ask you the best ligament support, say Mackenrod. Overall best support is the levator ani, also known as the pelvic floor. So levator ani is like this. If you see the uterus, and I'm sorry, this you see the pelvis and the uterus is like this. So this uterus, if you see, this uterus will easily jump out of the pelvis if you don't have the pelvic floor. So this is the pelvic floor. Just like this is the pelvic floor. Okay, the uterus is bobbing on the pelvic floor like this. The uterus is bobbing over the pelvic floor and doesn't come out. So pelvic floor looks something like this. See, this is the levator ani, and this is the vaginal defect, and then there is an anal defect below. So vaginal defect is the natural defect in the pelvic floor. So since there is a natural defect in the pelvic floor, the muscles of the pelvic floor are very tight to make sure nothing goes out. If these pelvic floor muscles get weak, the uterus goes out. So the best support of the uterus, no doubt, pelvic floor. Now when there is a pelvic floor, in addition to that, the ligaments are the good support, and the best ligament, if they ask you, is Mackenrod. So overall best, the best is definitely levator ani. In ligaments, Mackenrods is the best. And I did not write broad ligament there. Broad ligament is not a support of the uterus. Now the question is, which is the ligament which is the responsibility for this? Go ahead and write Mackenrod, which is also known as the transverse cervical ligament, or also known as the cardinal ligament, the Mackenrod. The Mackenrod has got three names: transverse cervical, cardinal, and the, of course, Mackenrod, cardinal, and the transverse cervical. A 38-week pregnant woman in active labor with vertex at -1 station develops continuous suprapubic pain between contractions. Fetal bradycardia and metal tachycardia. What is the best next step management? So they are trying to tell you rupture uterus, because suprapubic pain means the uterus is about to get ruptured, vertex in -1 station, not coming down. So if there is a suprapubic pain, in fact, it was, I think, with the previous LSCS and getting a trial of labor after cesarean. A woman with previous LSCS is having a trial of labor after cesarean, and now in active labor she's got a suprapubic pain, and there is maternal tachycardia, and there is a fetal bradycardia. So the first sign in mother of rupture uterus is tachycardia. Now please, first sign of rupture uterus in fetus, don't say bradycardia. I don't know how you guys are saying that. It is variable deceleration. Variable deceleration, then a late deceleration, and then bradycardia. So first sign of rupture of uterus in the woman is the maternal tachycardia, then maternal shock. In the fetus, it is the variable deceleration, because moment the rupture happens, the liquor goes out and the uterus will compress on the baby, and the cord compression happens, and you know cord compression causes variable deceleration. That's the logic. It is straightforward given in your Williams. And then late deceleration, and then the bradycardia. So yes, the management is to do a cesarean section. According to the Pritchard regime for eclampsia, the total IV plus IM dose for magnesium sulfate, we've already discussed this, I think, 3 times today's class. So it is 10 grams intramuscular and 4 grams intravenous. And the only regime they'll ask you is this one. it is to be followed by the IM regime, that also we've discussed. Okay, don't have to read the Zuspans and the lytic cocktail and the Leans regime. All these regimes, Zuspan is still valid, but all those lytic cocktail and the Leans regime are ancient. In my MBBS days, they are told that you don't have to remember this, only the Pritchard regime has to be read. Please don't read out all the regimes which are given in so many journals and old books and all. Don't waste your time. A 32-year-old woman presents with amenorrhea, lab shows elevated FSH and LH and AMH of less than 0.005. What is the diagnosis? So 32-year-old woman, AMH is 0.05 nanograms per ml. So normal is 2 to 6 nanograms per ml. I told you less than 1 is a poor ovarian reserve. Now, FSH is normally 2 to 6 international units. If more than 10, it is suggestive of menopause, and if seen in young woman, and if it is seen in a young woman, it is poor ovarian reserve. All right. So please remember, ovarian reserve is supposed to be poor if the AMH is lesser than 1 and FSH is more than 10 in a young woman. But here what they are saying, AMH is less than 0.05. It is less than 1, it is less than 0.5, it is less than 0.1, it is 0.05, extremely less, and high LH and FSH. She is into ovarian failure. So this is premature menopause, probably due to chemotherapy or whatever she had in her life. Hypogonadotropic hypogonadism, which is actually not the right thing because the gonadotropins are high. It is hypergonadotropic hypogonadism, which somebody was asking me earlier in the class. What is the meaning of hypergonadotropic? This is hypergonadotropic. If there is ovarian failure because of chemotherapy or radiotherapy, ovaries are not working, the brain is making more FSH and LH. So this woman has lost ovarian reserve probably because of chemotherapy. So answer is C. Right. Meiosis once, 1 second oocyte release. I'm not able to read your question properly, only half has come. I'll do another question meanwhile. A pregnant woman in the first trimester undergoes a routine antenatal screening and is found to have a positive IgG antibodies for toxoplasmosis. She gives a history of infection 3 to 5 years ago. What is the most appropriate management? So if the IgG is positive, she's immune. If IgM was positive, I would have given her spiramycin. So throughout pregnancy, we have to give spiramycin. Okay. So if she has IgG positive, she's immune. You don't have to give anything. All right. So start spiramycin, administer pyrimethamine sulfadiazine, perform amniocentesis, reassure and continue the pregnancy. D for Delhi is the answer. All right. Chalo. Which one? Ovarian insufficiency will be a little difficult to answer here because ovarian insufficiency will not have such drastically bad values, very high. Insufficiency could be also diagnosed in a much earlier case. The woman's age should be young. So premature menopause is a better answer than primary, because if she has never had periods, she is present with amenorrhea at 32, ऐसा नहीं होता. Amenorrhea will present at 12 years, 13 years, 15 years, 18 years. 32 पे थोड़ा ना amenorrhea primary amenorrhea करके आएगी. So she would have presented with primary amenorrhea. Now she is having amenorrhea at 32 years. It's more likely the premature ovarian failure. That is, she is getting into menopause before 40. If the woman has stoppage of period, it is known as premature ovarian failure. Now you cannot say that a woman comes at 42 with primary amenorrhea. No, primary amenorrhea is 13 years. So if the patients come to 32, I will not think of primary ovarian efficiency. I will think of secondary ovarian efficiency. It's very simple here. Okay, maybe simple for me. I'm sure it is simple for me. I've been seeing these cases so many times. Normally, the umbilical cord contains how many blood vessels? Normally, it contains 3 blood vessels, and those are 2 arteries and 1 vein. And the left vein is what is left behind. And remember, it is 4 vessels. It is 4 vessels till 3rd month. After 3rd month, the right vein gets obliterated and only one vein is there. And you all know that vein will be carrying the oxygenated blood. So only 2 systems in the body, the umbilical vein and then the pulmonary vein. These 2 veins carry oxygenated blood. All right. So CA125 levels 1025 with ascites and unilateral ovarian mass with papillary projections, classical ovarian malignancy. So papillary projections in a ovarian mass, they have not given age, should have given old age. So this is not a teratoma. This CA125 is classically associated. See, teratoma is the dermoid, okay? So all of those will have these germ cell tumors will have more of these LDH and may have lesser chances of CA125 being increased. So I will go with serous cyst adenocarcinoma. Germ cell tumors will have alpha fetoprotein, lactic dehydrogenase, maybe even placental alkaline phosphatase. Okay, chalo. After what weeks veins and arteries are seen? Seen where? Ultrasound. You have to tell me more about your question, my friend. Are seen. Till 12 weeks, you see 4 vessels, 2 arteries and 2 veins. After 4 weeks, you see only 3 vessels. I'm not able to understand your question. Hormone profile during a 21 to 25 day of the menstrual cycle. So ovulation happens on the 14th day. So when ovulation happens on the 14th day, the progesterone is high for 10 days. So that's why we say 6 days the first, I told you already, 6 to the 10th day implantation can happen. Implantation can happen 6 to the 10th day. And this 6 to the 10 day implantation is because of high progesterone. So high progesterone is definitely the answer. Low progesterone to nahi hoga. High progesterone and high FSH and LH, no. It will be high progesterone and LH and FSH will be low because towards the end of the month they will increase again so that the next cycle the follicles are recruited. So mid cycle the LH is high, FS is also high, then it a little bit small peak of FS is there and after that it reduces. So around 20-25 is mid-luteal. Mid-luteal, the FSH and LH will be low. Correct. 5 minutes break नहीं अब तो खत्म कर रहे हैं. We've been here for how long, man? We are here since 5. What's the time? Oh, we've been here for 6 hours, man. I think we'll just take a longer break and come for another session in some other forum. A 36 weeks, 8 centimeter cervical dilatation with cord prolapse. What will you do next? 36 weeks of pregnancy, 8 centimeter dilatation, there's a cord prolapse. Now, please, 8 centimeters still has theoretically 2 hours to go. Maybe at least 1 hour even if you hasten the delivery. So please don't try to do a normal delivery, okay? You will take time to develop a vacuum, build a vacuum also and all. So please go ahead and take the patient to the OT, but don't hold the cord and push it back inside. Holding the cord will cause vasospasm. So knee chest position or push up the presenting part and retrograde filling of the bladder, all are good things. Okay, both of these are good. All right. So I remember that keeping the patient low down on the head, keeping the patient low down on the head. I mean, head low position, the presenting part goes up and it doesn't press on the umbilical cord and cause vasospasm. So push the presenting part up with your fingers, not the cord. Push the presenting part up and fill the bladder. That is the best answer. You can also give a knee chest position. So avoiding a knee chest position is a bad choice. Okay. So best answer is this one. Push the presenting part up. So many times it has happened when we see a cord prolapse, I put my hand in the vagina and put the head of the baby up and avoid it to press the cord. And with that position itself, with my hand in the vagina, the patient is kept on the trolley and from inside the labor room, we open the door to the cesarean because the labor room has a OT. So open the door to the OT. From inside itself, we transfer the patient to the OT table straight. I keep my hand in the vagina till my other friend surgeon opens the abdomen and takes the baby out so that till the delivery of the baby, the head is not pressing or the breech is not pressing on the umbilical cord. That's what you have to make sure. Okay, chalo. So answer is B for Bombay. A 28-year-old female presents irregular cycles and now amenorrheic for 2 months. UPT is positive. Best way to date the pregnancy. Now, this discussion happened much earlier in this, and in the first trimester, it is always the crown trunk length. Second trimester, I told you, is the bipedal diameter, and third trimester, it is the head circumference, preferably, or the bipedal diameter. A sexually active female with profuse, frothy, foul-smelling discharge, with intense singeing, strawberry cervix, revealed on examination, what will be the diagnosis? Now, this is the straightforward, most easiest question of the discussion in this evening, and that is what is Trichomonas vaginalis, greenish yellow discharge. It's the greenish yellow discharge. And severe itching is there because the trichomonads, these trichomonads are 30 to 40 microns and they're running in the vagina up and down. So that's what they call severe inflammation. This strawberry vagina is basically red macules. So we call it colpitis. Vagina ki infection is not called vaginitis only, it is also called colpitis. And red macules are there. Colpitis macularis. Colpitis macularis, all right, and that is the answer, Trichomonas vaginalis. Post-menopausal woman, first line of drug for osteoporosis. Yes, man, come on. So, let's see how many of you are going to say bisphosphonates. So, remember, if a patient is having osteoporosis, bisphosphonates just for osteoporosis is good after 60 years. This is the question which came in INI-CET. Bisphosphonate is the answer to this question. But 50 to 60 years, please give hormone replacement therapy with estrogens because you need to take care of the bones, and your Shaw's and your Novaks is very clear that from the first 50 years to the 60 years, that time of menopause, you have to give a patient estrogens. After 60 years, the same estrogens can cause coronary artery disease. So after 60 years, is the question, and this question has come in INI-CET. I'll tell you the year also, 2021, and that's what they've asked. After 60, what is the drug of choice? Go ahead and mark bisphosphonates. All right, chalo. A patient delivered at home with complete penile tear came to the hospital after 2 weeks. How will you manage this patient? This question we've already done. A complete penile tear. Complete penile tear, type 3 or type 4. Complete penile tear is type 3 or type 4 or both, and that cannot be repaired now because it should be best repaired within the first 24 hours. If they come after 2 weeks, you must repair 3 months post delivery. Do not say 6 months, that is wrong. Answer is D for Delhi. We've discussed that already. All right. So that's the simple part of the questions. In modern obstetrics, for a sensitive Rh negative mother, what should be done to evaluate the condition of the mother? Okay, condition of the baby. Sorry, wait a minute. Condition of the fetus. I'm so sorry. That's a mistake. Okay. I think I have not seen the last 15 questions properly. I've just seen the answers. My mistake. In a modern obstetrics for a Rh sensitive, Rh negative mother, that means mother is suppose a negative and the fetus is suppose a positive. So the D antigen or the Rh antigen has gone to the mother. Mother is making the antibodies. With the antibodies, the baby will have hemolysis. And with the hemolysis, anemia happens, and for the management of anemia, the baby will increase his heart rate, and that heart rate will push more blood to the brain. So, jitna anemia hoga baby ko, because of isoimmunization, there will be more and more hemolysis. To assess the degree of hemolysis, to assess the degree of anemia, we can do amniocentesis, but that is invasive. To see how much hemolysis is there in the amniotic fluid, we'll see the bilirubin. But we can also check the hemolysis by the compensatory mechanism of the baby. Baby has hemolysis, he's compensating by increasing his heart rate and increasing the blood flow to the brain. So the brain will have more flow. So the peak systolic velocity of the middle cerebral artery if it is more than 1.5 multiples of median, more than 1.5 multiples of median, all right, and that is what is significant. That is what is significant hemolysis. Okay, so MCA Doppler, peak systolic volume nahi velocity. Peak systolic velocity is done for assessing the hemolysis. Why not fetal blood? Why not fetal blood? How will you take fetal blood, my friend? The mother is pregnant and she's having RH isomalization and she's sending the antibodies to the baby. Baby is having hemolysis. So you'll have to put a needle into the maternal abdomen, go to the amniotic sac and go to the fetal umbilical cord and do a procedure. Whereas you can simply check the flow to the brain and get to know the hemolysis. So we used to do amniocentesis earlier, but now we don't do all this. Fetal blood to assess the hemolysis, it's really more invasive. That can cause a fetal intrauterine death also. All right, so we don't do that. Right. A 7 weeks pregnant lady has had an accidental exposure to X-ray. Which of the following should be done? Remember, one exposure in the first trimester is not a problem. Yes. So 5 rads to 10 rads is safe. So that is equivalent to doing 2 chest X-rays. We never want X-ray exposure, but up to 2 X-rays or up to 10 rads is safe. Ionizing radiation, ionizing dose of radiation is more than 20 rads. Of course, you should know the conversion in sieverts, millisieverts, gray, centigrade. You should know the conversion, okay? But that's why I keep my understanding to rads. And that's what mostly comes in the exams, okay? So if it is 7 weeks and it is only one accidental exposure, I will continue the pregnancy. I will not worry. But if it is more than 2 or 3 X-rays, or she had a CT scan without knowing she's pregnant, CT scan is just too much of radiation, then I will abort the child, okay? Then I will abort. So answer to this question is A. Meiosis occurs in adult ovary, pubertal testes, at birth in ovary. All of the following, because that's what we discussed, all right? Just now we discussed this. So it resumes, it arrests, all of that we know. But yes, it arrests in the first meiotic division, it arrests and then it resumes. So it was happening even in the intrauterine life, it was even happening, but it arrests eventually, all right? 2 rads only safe is not enough. I don't know where you got that from. You must read Williams obstetrics. Dichronic diamniotic twins at 38 weeks of gestation. First twin is breech. Mother has blood pressure 140/96. 1 plus proteinuria. What is the management? First twin is breech. So remember, in twin gestation, if it is a monochorionic twin, it will be given to you, or you can diagnose it by the picture. Then cesarean section after 34 weeks, lung maturity. Monochorionic, I will not deliver vaginally. But if it is dichorionic, then deliver vaginally at term. That is what is the plan. Of course, there can be many variations, but the plan of dichorionic diamniotic pregnancy is to deliver vaginally at term. So, dichorionic diamniotic twins at 36 weeks of gestation, but the first twin is breech. Now, this I already told you in the first 2-3 questions of the evening, around 5:15 p.m. itself. If there is first of the twin, if there is a singleton breech, I'll do normal vaginal delivery. But if the first baby is breech in a case of a twin, it's a complicated breech, I'll have to do a cesarean section. All right, so we'll go ahead and do a cesarean section. Okay, induction, immediate induction delivery, induction. Okay, fine. This is the answer. Now let me explain you. In twins, most commonly there is both cephalic. Second most common, first cephalic, second breech. So both can deliver. Both deliver. Then, if first is breech, or if first is transverse lie, I will do a cesarean section because it is non-cephalic. Non-cephalic first baby. If the first baby is non-cephalic, I'll do a cesarean section. It could be breech, it could be transverse lie, I'll do a cesarean section. But I already told you today evening, yes, if the first is cephalic and the second is transverse lie, I can do vaginal delivery by internal podalic version. Yes. So this is what I explained to you earlier. If the first is cephalic and the second is transverse lie, I can do a normal vaginal delivery because first will come out and the uterus will be relaxed after the first baby's delivery. I can put my hand inside and do an internal podalic version and do the delivery by breech of the second twin in transverse lie. I'll make the baby into breech, internal podalic version. I told you the only indication of internal podalic version, I told you earlier in the evening, is second or twin in transverse lie. All right. I don't know which question. At time evaluation, meiosis 1, secondary oocyte release, because meiosis 2 completes out of it. So it should be option 1. Which question, man? See, I don't know. I don't want to go back to the question because we moved ahead. But remember, when the ovulation happens, it is arrested in meiosis 2 because meiosis 1 completes at puberty and it gets into metaphase 2. It is a metaphase 2 oocyte, my friend. My IVF will be lost. It is called, the oocyte is called a M2 oocyte. M2 is a metaphase 2 oocyte. So I'll be lost in my whole, the bread and butter which I'm earning because of IVF, I'll lose it. It is not a M1 oocyte, it's a metaphase 2 oocyte. All right. So please, I'll have to, we call it a M2 oocyte. Okay. So let's not get into that. All right, thanks so much for your feedback and let's move on to the next question. Best treatment option for septate uterus. Now, I told you septate uterus, you can do a hysteroscopic septal resection. So that is what is a transcervical hysteroscopic resection of the septum. Strassman metroplasty, Jones metroplasty, all of these are for the bicornate uterus, all right? But the answer is D, a simple hysteroscopic septal resection. Yes, this will be a septum like this. It is as simple like this. You just go inside and just snip it off like this. Okay, that is a maybe I can show that to you. That is one of the favorite surgeries for. I keep telling you that the number of septums I've done, I don't have a count. Maybe I can show that to you. Yeah, here. See, can you see I'm inside the uterus? There's a septum. And as simple as that, see, there's a septate uterus, just go inside and snip it off. Yes, maybe I'll show you the video before I took it off also. There's a simple surgery, septate uterus. Yeah, see, that's a septal resection, hysteroscopic septal resection. Maybe I can show you how it looks before the resection. Yeah. So, in a hysteroscope, you can see the ostia. See, this is one ostia you can see of the tube. Now, you have a huge septum in between and you're seeing the second ostia here. So, this was one of the easier, this was a nice big fibrotic band. It didn't bleed at all. In fact, mostly I have to use a cautery, but here I just went inside and snipped it off very simply with the scissors itself. She didn't bleed at all. This is a very simple septal resection. So, I kept it as a video for my students. This patient has already got pregnant and delivered long back. Chalo, let's, yes, are we having the end inside? Yes, we're having an end inside. Yes. Right. Next question is, a 18-year-old girl presents with 6 months of amenorrhea with a history of low-grade fever, weight loss, pain abdomen, generalized weakness. On per rectal examination, a palpable left side pelvic mass is palpated. What is the most likely? 18-year-old girl, amenorrhea, secondary amenorrhea. You'll think of PCOS, but generally it will not have 6 months of amenorrhea. Can have. You'll think of PCOS, but history of low-grade fever, weight loss and pain abdomen, generalized weakness. Yeah, this is nothing else but tuberculosis. Ectopic pregnancy, 6 months के लिए नहीं होगा, फीवर के साथ एमेनोरा नहीं होगा. 6 months baby will be a big baby, not come as ectopic. Fibroid degeneration is extremely rare in this age, and granulosa cell tumor will not come with this presentation. It will come with mass and it will be having hyperestrogenism. So she will not come with the amenorrhea. Granulosa cell tumor will have increased estrogen because granulosa cells makes estrogen. So granulosa cell tumors will make more and more estrogen, and that will cause menorrhagia. That will cause a menorrhagia. All right. Right. A 60-year-old female with a history of intermittent bleeding with an ultrasound picture shown below. What is the diagnosis? So you see this picture. Maybe I should bloom it up a little bit. You were not able to understand this picture. Okay. 60-year-old with a intermittent bleeding. Yeah, maybe now you'll understand better. Sorry. Yes. Yeah. 60-year-old lady with an intermittent bleeding. That thing I've taken off. Endometrial polyp, C endometrium, submucosal fibroid, adenomyosis. Intermittent bleeding. So if you see this mass, this is a nice circular mass, and there is a feeding vessel. Okay, that Doppler is not here. So there is a nice mass which is seen, spherical mass. Endometrial cancer, endometrial hyperplasia, you will not get a mass like this. You will get an ultrasound with a thick endometrium. I already told you, endometrial hyperplasia, you will see this endometrium will be having a very big thickened lining in hyperplasia and in cancer. It looks something like this, and you will see the endometrial thickness will be shown to you, will be like 18 millimeter, 20 millimeter, like that. Now here you're seeing a spherical mass, slightly hyperechoic, right in the middle of the cavity. This goes in favor of either endometrial polyp or a submucosal fibroid. Now, to distinguish between, adenomyosis will be here in the muscle. Adenomyosis will be here in the muscle. Here, this is the muscle of the uterus. That is not shown here, adenomyosis. So, between endometrial polyp and submucosal, endometrial polyp and submucosal fibroid, I'll see a nice circular mass, and here it's not a very, radiology people will give you a better picture, but you'll see there is all over the place a hyperechoic lining. So that basically means that it is hanging in the cavity. So more in the favor, can be a submucosal fibroid still, but more in the favor of a polyp, because polyps can present even after 50. Fibroids generally present before 50 because fibroids are estrogenic. After 50, fibroids will settle down in a woman's life. So unlikely a fibroid will present in a woman who is 60 years of age. So that's why the picture and more so the history is favoring a polyp than a fibroid. Okay, chalo. All right, I didn't know the last one is a thank you. Right, so what else are you guys asking me? Push lo yaar. So I'm good for more. What do you guys want to ask me? Let's see. Water break meanwhile. Yes. Did you guys have dinner? I forgot totally about it, man. Chalo, if I'm not seeing any questions coming up, so if you don't have any more questions, then we can call it a night, and we can always meet after some more days after the NEET PG exam to discuss the questions, and we'll have jitna bhi discussion possible hai yaar, let's keep having. अपडेट्स विच आर लाइकली टू बी आस्क्ड. देखो अपडेट यार, देखो ये क्वेश्चन ना मुझे जाते जाते मुझे लग रहा है कि आप लोग मुझसे लड़ना चाहते हो. अपडेट्स अगर आए हैं तो विलियम्स ऑब्स्टेट्रिक्स में या नोवैक्स में आए तो मैं आपको पढ़ाऊंगा. WHO ने जो अपडेट्स बताए हैं वो अभी इंप्लीमेंट कहीं नहीं हुए. दे डू नॉट आस्क यू टिल something like corona has happened and corona ka drug ye chalna hai because it's a international calamity, then medicine people taught you, the the pulmonologist taught you, anesthetist taught you, gynecologist also taught you what you have to do in corona. Till it is implemented, don't get bothered. So latest update in Royal College has come. We are not going to teach you that. If it has come, something has come by the Ministry of Health and Family Welfare. Like that, lot of your guidelines will come about use of chaya, use of mantra, use of what the ASHA workers can do. All these updates keep coming out by PSM. Those updates are very important to do. But core basics will come in all medicine, surgery and gynae kind of exams. So don't worry about updates which are coming in the international journals. Like I told you, if you did not hear the full lecture, I told you about the PPH updates. I told you about the update upon the labor care guide. Then I told you the update about bacterial vaginosis, that both the partners should be treated. That update has come in the journals, but it has not been accepted by the books so far. So they are saying it's better to treat husband and wife more. So all that has not been accepted. So stick with core basics. अरे core basics पे पास होते हैं. And याद रखो, 1 or 2 name of doctors will come in NEET PG exam in 2-3 subjects, like who was the first IVF baby born, Louis Brown, who was the doctor, who were the set of doctors who were involved with the research on IVF, Dr. Robert Edwards and Steptoe and Edwards, who got the Nobel Prize for IVF in 2011 for the year 2010. That was Dr. Robert Edwards. So all of that has come. These are all questions which have come from my specialty in your, and if in the last year, please check the history, check the last year Nobel Prize winners. Nobel Prize winners for medicine, not for, let's say, chemistry or zoology or peace Nobel Prize, not. For medicine, agar koi Nobel Prize mila hai, whether they're doing some research on the DNA or some research on coronavirus or whatever, I don't know. Whoever got the Nobel Prize in medicine, please read about that and go in the exams. All right? Chalo. Osteoporosis wala question, the best option after 60. I modified the question. After 60, it is osteoporosis, it is bisphosphonate, because all of you keep saying the drug of choice is bisphosphonate. So I modified the question after 60 years. Yes, I wrote that after 60 years. Maybe that's why you're getting confused. After 60 years, it is bisphosphonate. Before that, it is HRT, and HRT can be estrogen, also raloxifene. Yes, I give it to you. I have modified the question. After 60 bisphosphonate, before that it is estrogen or even raloxifene. Correct, you're right. I'm not denying you that, Rupak Kundu. Yeah. Yeah, see, Ishta is saying, so change that question. PDF will come. I'll have to say goodnight to you guys. You have to go back and have a dinner, and maybe another 5-6 minutes it'll go to my team. And I don't know when they're going to put it, but you're definitely going to get it. Okay, Shilpi Tak, thank you for your feedback. And somebody else also said something, but God bless all of you. You with me, Partha Sarthi. Partha Sarthi, तूने हिस्टोस्कोपी देख लेना मेरे साथ. चल अब तू गलती नहीं करना, ठीक है? I'm sure you're happy with what you saw. And please ask Partha Sarthi to ask about CA cervix. Chalo guys, some other time we'll be in touch for more question answers. I think 6-7 hours is enough session for you guys. Chalo. So please explain difference between polyp and leoma. Polyp will not come in the age group of 60. Fibroid will not come in the age group of 60 for the first time. Polyp is more likely answer, and polyp will be hanging in the uterus. So all over the polyp you will see a black area, hypoechoic area. Fibroid will be attached to the body, even if it is some mucus somewhere. So mostly, I mean, that's what would help me give the answer. Okay, GR Patel, thank you so much, and I'll have to ask your permission to leave, and we are going to meet very soon. Until then, keep reading, and all the best for your NEET PG exam. And I hope all of you get what you want. But there's a final message I want to give, that those who are writing for the first time, get what you want. Achievement. Go-getters. Yes, go and get what you want. If you're second timers or third timers, like what you get. Okay, so first timers, get what you like, happiness. But if you're second timers, third timers, like what you get. I'm not asking you to compromise, but it's about time you settle, because every time something like 2.5 lakh doctors are joining the list. So It's not a compromise. I want you guys to settle down in life. If you do not get MD or MS, settle down with DNB faster. And some places, DNB is even done better than the MD in some places. So get what you like if it's your first attempt. If it's your second, third attempt, like what you get is a very reasonable advice. I'm not saying that you're compromising, but settle down in life. Every branch has got a very good avenue. And if you're compromising a little bit, doesn't mean bad, doesn't mean that you've not achieved much. It doesn't mean bad. Okay. So all the best, guys, with hopes that you'll do extremely well, and we'll all get back and party together. Good night, guys. Thank you so much.